over all the known wisdom of biology, because the known wisdom of biology is this, that a cell, when it starts differentiating, it is an irreversible process, and differentiation process is an unidirectional process. These two concepts were turned over through the studies of allogenic bone marrow transplantation, when a female bone marrow was given to a male recipient or vice versa. And later on, when these patients could not make it and passed away, their autopsy shows that though you have given hematopoietic stem cells from a sex mismatched donor, the liver of that recipient contains the liver cells of the donor. That means the cell, hematopoietic cell which we transplanted to the patient, has become a liver cell. This process was unknown to biology, and this process is called transdifferentiation. And transdifferentiation made the regenerative medicine born. This means that if you give a stem cell of any lineage, some lineages are better than other lineage, then depending on the environment you are providing, these kind of cells are capable of adjusting to that environment and can differentiate into that line. So that is a great discovery. But in addition to that, the need for banking these stem cells arose because at different time point you needed to use these cells. This thing actually basically it started by Valery in Walter Reed Institute, where he developed the process of cryopreservation. So understanding stem cell, process of cryopreservation, and in mid-80s, showing that umbilical cord cells and umbilical cord blood is a very rich source of stem cell, paved the way for extensive stem cell banking and the use of these cells for various kinds of regenerative purposes. We should not forget the contribution by neurosurgeons in this area, because they have started already experimenting with the fetal substantia nigra cell transplantation or implantation in Parkinson's disease patients, and they found certain good result in these patients. So all these good things actually combined to produce the present scenario of utilization of stem cell for extensively for various purposes. But what has happened in India? You know, in India, many of the technologies which Wests have produced comes to us about a decade or 2 decades later. This is not different for bone marrow transplantation also, because bone marrow transplantation took root in Western countries in mid-60s. And the first allogenic bone marrow transplantation was done in Tata Memorial Hospital in 1983. Similarly, the stem cell related application also started in mid-90s in our country, but it was halted by various kinds of ethical and practical means. Meanwhile, many sources of stem cell came to light, like dental pulp stem cell, olfactory bulb stem cell, adipose tissue stem cell. Wherever we looked, limbal stem cell in the eyes, wherever we looked into, we found stem cells are there. So at the end of this day today, there are only 100 bone marrow transplant centers after 40 years of effort in this country. And out of that, only 6 or 7 bone marrow transplantation centers are big enough to tell us that, okay, these are bone marrow transplant centers where a lot of work is done. Coming to stem cell application, for big research, there are only 2-3 centers which have come up. Different buildings, different faculties, different kind of thing for stem cell research. One is by DBT and another is, of course, in AIMS. I have to name AIMS Delhi as an early stem cell application center where Dr. Venugopal and his team actually tried to use different kinds of bone marrow derived stem cell in treating patients who have end-stage heart failure due to cardiomyopathy and other kinds of problems. They were able to show that the the mononuclear cell, which also contains stem cell, which was given to this patient, led to marginal improvement of cardiac output. Looking into the possibility that regenerative medicine and stem cell application is going to have big implication in treatment in India, both ICMR and DBT actually called for in mid part of this century, this 2010-11, many projects on application of stem cells. So I think ICMR called about 100 projects, and DBT also called the same number of projects to be tried. However, all these studies showed very marginal kind of improvement in using stem cell, like spinal cord injury and others. So what happened is, I don't think it was a very happy state of affairs. Broadly, it was looked into that probably most of the cells are not doing anything great. Plus, the biologists were curious to know whether the stem cells are going to the place of injury or the place of degeneration and they are growing, or it is the cytokines which the stem cell liberate around this place to cause this regeneration or improvement in clinical situation. This question actually is a more difficult question. But however, in spite of these two government organizations setting up committees, of which I was also a member, and Dr. Jotwani is there amongst you. She had been there from the beginning in ICMR. So we basically started devising the guidelines and the rules and regulations which will regulate the stem cell research in our country. Now, three different modifications of these regulations are already in it. Plus, in the same time, in vitro fertilization became an important part of managing the difficult or infertile couples, and they produce a lot of spare embryos as a source of embryonic stem cells, and their regulations also became important. So ICMR, DBT together formed committees who actually send the guidelines. But umbilical cord blood banking started in a big way in India across the states, and many of them are still actually doing these things for various kinds of purpose. And therapy-wise, individual cases were treated for very many conditions, whether it is peripheral vascular insufficiency, diabetes mellitus. The main area was impetus was from orthopedic surgeons. So they were treating sports injuries, they were treating osteoarthritis, they were treating various kinds of bone disorders using stem cells. So at present, there are several hundred clinicians in our country who actually are using these stem cells for individual patients, but big trials are lacking. Though there are few trials, few registries showing that these trials are needed, yet I think the laws and rules and guidelines are so stiff that many of the small establishments which can do actually studies on stem cell very efficiently, they have not been included into this kind of program. So there is a need, felt need, because what happens if you say that this kind of therapy is not acceptable or not comply with that? There are 2-3 ways by which we can do it. And ICMR DBT needs to seriously ask for that, rather than asking whether stem cell is going and proliferating in that cell or cytokines are coming and doing the job. The first job is the empirical evidence that the stem cell is working. To that end, I feel, so this should be the future. So at present, what is the situation? You have quite 9 or 10 big organizations which are doing stem cell-based research, mostly basic research. And there are many, many more consultants, physicians, neurosurgeons, orthopedic surgeons, gynecologists, who are treating endocrinologists, who are treating variety of disorder on a case-to-case basis. And they are actually reporting improvement in many such cases. And, and there are studies from PGI Chandigarh where it has been shown that once you give the autologous stem cells into the pancreas, these cells grow into the pancreas. They actually secrete insulin, and they actually stay there for at least 1 year or more. So there are small studies to show that stem cells do go to the place where you want to put them. They grow for some time and they do their function. Similar studies in PGI MER Chandigarh on sports medicines, means athletic injuries and others, have also shown good results. Vellore has a big center for stem cell work. And as I said, DBT, Vellore, AIMS, PGI, MER, these kinds of center can do both basic and clinical applied research in stem cell biology. Indian Institute of Science is doing a lot of work on stem cell, but mostly on animal stem cell and their application into it. Now, what do you do about such precious amount of clinical work which is done by many which is done by many of the clinicians in our country? ICMR actually should set up a registry. As International Bone Marrow Registry has been set up, where individual doctors can put their patients showing whether they improved or did not improve using the stem cells. And this registry can be on several verticals on different diseases like cardiac diseases, like endocrine diseases, orthopedic situations, neurological degenerative diseases like that. And this should be open to everybody so that they can report the cases provided certain experimental norms are maintained. Now, this will allow ICMR to gather a lot of empirical data, whether the stem cells are working, as IBMTR has done. International Bone Marrow Transplantation Registry now contains almost 1 million transplanted case reports. And they know which kind of HLA mismatch is acceptable, which kind is not acceptable, where relapse is common, where relapse is uncommon. So these kind of data ICMR can also gather by putting an open registry or stem cell therapy. This is one. Second is, there is serious problem in stem cell application because different kinds of physicians do not use the same kind of criteria for stem cell. Some use mononuclear cell, some use CD34 collected cell, some use bone marrow, some use adipose tissue, some use umbilical cord, some use autologous, some use allogenic stem cell. And so there is a problem in this. And often when we actually submit individual project to ICMR or DBT or DST, the projects are criticized on methodological background. So broadly, I feel to help all these hundreds of doctors who have assembled in AIMS Raipur to this great meeting, and there are great speakers as I saw in this, they actually should have no problem in following ICMR guideline if they say, okay, your individual study should use stem cell preparation like this. So many stem cells can be used. 1, 2, 3, 4 different levels of stem cells can be used. If you are using mononuclear cell because your establishment does not allow positive cells, that could be separately written. So once you give the whole protocol, if I can from the August speakers which are present in the AIMS Raipur, they can decide about a program which can be followed by all of them when they are treating individual cases. These individual cases then can be put in this open registry. And then what will happen, across India, we are so many people. Hundreds and thousands of cases will accumulate to lend credence to the fact that how this actually this kind of therapy works. There is no problem in individual's mind that it works. I know all of you, and including me, I am the one who has seen on both sides of this story. So that's why this is my plea to both DBT, ICMR, and they should put much more funding into the situation so that large number of doctors and technicians and allied scientists can be produced in this area of stem cell research. The stem cell biology is our future. And once this happens, then you can say, okay, we have now shown that it works for osteoarthritis at this stage of damage. It doesn't work in another stage of the damage. Then there is another area of stem cell, which is regenerative medicine or regenerative tissue engineering, basically. On that area, we have not progressed much because that is an area in infancy. So I will not be talking about tissue engineering centers in India. However, these patients also needs to be followed up because one of the thing which has happened from stem cell therapy across the world is that stem cell therapy is safe. If you are not using embryonic stem cell therapy is largely safe. It has not caused much of the problem across the spectrum. So the organizations like ICMR doesn't control totally the clinical application of stem cell therapy. This is controlled by Drug Controller General of India along with ICMR and CDSCO. So basically, they should sit together and facilitate the stem cell research much more. It should be easier than difficult. We should not raise a bar of resistance that this cannot be done or this can be done. So cannot and can should be there, but that should be through simple regulation and simple kind of things. Then you see, diabetes is going to be a big problem in India. We already know people are telling that is a diabetes capital of going to be the diabetes country in the world. NIDDM is the one where we have adequate kind of data in terms of both at the level of basic science, at the level of imaging, as well as at the level of function, where difficult diabetic patient has been controlled for quite some years by stem cell therapies. One of the important part, apart from the private clinicians who have come into the stem cell work in clinical side as well as in research, is the entry of private companies. Started with Stempeutics in Manipal and others. They have now available the mesenchymal stem cell from the self, means they can provide the self at stage 6 or stage 7 passage of the cells, which have been obtained through properly selected donors. And they have already ran several trials across the country, multicentric trials. Similarly, the Reliance Life Sciences have some stem cell work, which mostly actually concentrated on limbal stem cell, producing corneal, in case of cornea damage or artificial stem cell based cornea therapy. But many more such organizations are needed. This is a big country. So far, last 200 years, medicine has tackled the deficiency diseases, the infections, the degenerative diseases to some extent. But these are all related to actually not regeneration. It is mostly repair kind of thing and replacement kind of thing. Now a new era from last 30 years, these hematopoietic stem cells and other kind of stem cells have actually evoked both emotion as well as scientific interest that this is going to be a therapy of the future. These dreams and ambitions of these stem cell based therapy across the world largely has still remained unfulfilled. In fact, in India, in orthopedics, even the Western companies also have come and they have in various places or their shops at various places to help in osteoarthritis and other kind of areas. So basically, I think I should end my talk by telling that at individual levels, hundreds of doctors are trying to do on individual case-to-case basis stem cell-based therapy, and many of them are reporting good results. There are very few basic research which is being conducted in stem cell biology and regenerative medicine differentiation potential, and that is restricted to 6, 7, or 8 centers in the country. There are many other bigger centers where this research can be done, and that should be encouraged. Plus, as I said, ICMR should open an open registry. They should only, if they have complied with these things, and that will increase patient did well or not. Once we have seen, okay, out of all cardiac disorders which we cannot treat properly, sort of heart transplantation this time, or other kinds of therapy fails, we can actually get good success for this proportion of cases. So this is needed. Similarly, in orthopedics, actually with Dr. Kanchan in a small center in Surat, we actually aspirated osteoarthritis joints in more than 100 patients. And when we looked at this joint fluid for different biologies, like cellular content, the mucus, the acetic acid response to mucus, we could not study the cytokine response. So these were very variable. So when an osteoarthritis patient comes, it is not only the imaging which will show you different levels of osteoarthritis and different variability. Even the fluid which is aspirated from osteoarthritis joints can also allow you the segmentation of these patients into various groups. Some of them might have responded very well to stem cell therapy. Some of them may not have responded. So we need to know them that which subset of patients should respond. And that can only be possible if all of us across the India join hands together, and the central government authorities, DCGI, ICMR, DBT, DST takes a big hand in it. And because their representatives are present in your meeting, I sincerely request them to do that. Thank you for patient hearing. And I wanted to be with you today in Raipur, but I could not reach there because of different things, because I suffered COVID and I am now held up in Calcutta. Thank you so much for your patient hearing, and I wish you all the success for this great meeting. Thank you.
Thank you so much, Professor Ghosh, for the wonderful discussion, the explanation, and the guidance which you have given to how to go for the clinical research. Even if the person is from the private sector doing few cases, to middle sector and reaching to the ICMR level through the proper channel. Thank you so much. For those who have joined late, I'll just have an introduction to Professor Ghosh. He's a former director of National Institute of Immunohematology from Mumbai, ICMR. And he's have for more than 10 years actually. And he has a lot of specialization for the hematology, coagulation, biology, bone marrow transplantation, and he has more than 700 publications. So we are very much honored with your presence, sir. And we hope then in coming future, you'll be guiding us for how to go for it, how to go for the research and various things. Thank you so much. So usually
it is a great work, sir. You are doing a great work, and I hope to be associated. I am already associated in some way, but we can have more intense engagement in various areas. Thank you, sir. Thank you so much.
Thank you so much, sir. Thank you so much. So usually we don't have any questions in the orations. So now I'll request Dr. Kanchan for the next oration.
Thank you, sir.
Thank you, sir. It's so nice of you. It's our pleasure to have you here. Really, we are very much happy to see you lecture. Thank you, sir. Thank you. Yeah. And
thank you.
Thank you, sir. Okay. Dr. Manish, I am requesting you, please come on the dais. Please call Dr. Sankar Narayana for the oration and introduce him brief. Thank you.
Well, a proper very good morning to everyone. Formally, I welcome all of you again to this second day session of Indian Stem Cell Study Group. Well, today we are having our second prestigious Professor Dr. Shankar Narayanan oration. And before inviting Professor Mahapatra to deliver this oration, I just want to introduce Professor Shankar Narayanan to everyone. Although everybody knows him very well, this was being started in 2019 with the motives, with the initiatives, with the courage, and starting from the field of dentistry, heading and guiding all of us together. So I'm going to use he is or he is not like he was. So he did his BDS in 1986 from Annamalai University, Tamil Nadu, and MDS in 1990 with a lot of work in the stem cell engaging therapies and scientific program in the last decade. He had got a 30 years of clinical practice experience with the UG teaching, also with the PG teaching and the clinical research work. He had a rich exposure and tremendous experience in diagnosing interesting clinical cases and slide reportings associated with plastic surgeons in the management of facial injuries. So we had a good discussion about these cases yesterday also. So I was missing him tremendously. Diagnosing and managing various types of oral ulcers was his passion. So all of the thing from the oral, from the fibrosis and all those aspects of the things were very much focused from him. And these were the feathers actually in his cap, along with various other endodontic treatment which he did. He has an endless list of keynotes, lectures since all in the last decades and number of publications. So it's not possible to enumerate all, but still the most important one, I'll just going to stop there. And that is the first one, the mononuclear cells using in oral submucous fibrosis. So this is a thing in India, the tobacco population, the tobacco chewing population, the fibrosis, the submucous fibrosis, it can be very well taken care with the regenerative science, with the PRP or with the neoangiogenesis. Well, so this is the list of the publications. He also authored a chapter, Stem Cells, in the book titled Textbook of Oral Embryology, and the one textbook of Orthopaedic Rheumatology, which will be just coming within a 2 month of time from Indian Orthopaedic Rheumatology Association, has also a chapter from him. So it was being given to him when he was there. So, and there are a number of, he was a very keen writer with the regional and the national newspaper. So hopefully we would get the power of his vision in all the team members. And we want everybody to take this courage and take his innovative skills, the legacy which is left behind, you can say, or it is still with us. Dr. Shankar Narayanan is a visionary, the first person to treat the submucous fibrosis and proved it histopathology in India. He was the first person for this. The first person to treat osteoradionecrosis mandible with stem cell and thus regenerated. It's just the same thing with the orthopedic surgeon. Radionecrosis of the head of the femur. So it's osteoradionecrosis, the mandible, it's the same pathology, but he had coined this thing actually. Yes, it was his proved superiority to prove the uses of dental stem cells. He quantified the millions of the stem cells actually, which can be obtained from extracted tooth, proved these as a specialty for the diabetic foot ulcers also. So we all salute to him, his work. Thank you so much. So I'll invite now Professor Mahapatra sir to give this prestigious oration. Mahapatra sir, please.
Dr. Manis, can you briefly introduce Dr. Mahapatra sir?
Professor Mahapatra sir is a professor at Burla Medical College. He's a keen researcher and he has got number of publication in index journal. In the field of general surgery, he's a key leader, having a lot of work done with the incisional hernia and all of the things. At this age, he's still very young. He is a very vigorous general surgeon, Professor Mahapatra, sir. So it's our great pleasure to have this oration, this prestigious oration from him. And he's going to guide us about the role of the regenerative science in the field of general surgery, which is a vast and ever increasing branch of medical sciences. Yeah.
Choosy. Hey, good morning.
Very good morning to all the dignitaries present on the dais of the dais. I am grateful to Lord Jagannath in the beginning and grateful to the ISCSG organization, whose president is Professor Manish Khanna and General Secretary is our Kanchan Mishra. Without this organization, I would not have been standing here to present the oration. I am grateful to Lord Jagannath because without his will also nothing happens. This is our belief. And I am grateful to the AIMS Raipur, its dynamic director and CEO, Professor Nitin Nagarkar, and the organizing secretary of this grand conference, Professor Alok Agarwal, to whom I am indeed very, very grateful. He is like the Alok. His name is Alok. He is really Alok of the Surya. Surya is, if Professor Nitin is Surya of this institute, then Professor Alok Agarwal is the Alok. So I'll recite Surya Jyoti Nama, Jyoti Suryaya Nama. We always see Surya Jyoti Nama, Jyoti Suryaya Nama. Now to Lord Jagannath, if we look, he has two beautiful eyes like stem cells and has elevation in the center, which looks flat in the two-dimensional picture. If you look to the temple, that is the lingam, the black nose-like thing is called the lingam, that is the Shiva, and surrounding is the Narayana, Surya Narayana, Chandra Narayana, Agni Narayana. So that is my concept of my Lord Jagannath. So I am delighted to present Sankara Narayana oration in presence of the great Sankara Narayana, who is there controlling all of us. Incidentally, the Dr. Sankara Narayana was swallowed up by his mouth. The fire engulfed him, and we'll all be engulfed in that fire one day. But what outlives Dr. Sankara Narayana was told by our president of Indian Stem Cell Study Group Organization, Professor Manish, that his legacy is still living. I still remember a poem which I read in my matriculation, the death the leveler, scepter and crown must tumble down and in dust be equal made with the poor crook, sheath and spade. But only the actions of the just smell sweet and blossom in their dust. In the dust of Shankar Narayan, that blossom the flower of his legacy, what we saw in the slides, and what he has contributed to Stem Cells Society of India. Had he been living, we would have been much advanced very quick. But his concept, his thoughts and ideas are blossoming and so that we can take over his thought and ideas. Now, I will start my oration with one important concept that which Professor Manish yesterday told, that we are having the domains, 3 domains. Now look here, 3 domains. The domain of knowledge and domain of affection and domain of action. The 3 domain, cognition domain, affective or affection domain, and action domain, that is called psychomotor domain. If you see Lord Jagannath, he's sitting there like this. If you have ever gone to Puri, his own place, he sits like this without hand. That his hand enters into all of us to work on stem cell or whatever discipline we are working. And this I remembered, Namo Sambhavaya cha Mayo Bhavaya cha, Namo Shankaraya cha Mayaskaraya cha, Namas Shivaya cha Shivataraya cha. He Jnana, Buddhi, Anandra Malik, Arna, Aishwarya, Santira Malik, we invoke you to bless us, to give us Jnana, Buddhi and Ananda. Jnana and Buddhi gives Anand, that is pleasure to go ahead in life. With this introduction, I'll start my oration on Shankar Narayan in a very important topic and with a good quotation that a dream doesn't become reality through magic. It takes sweat, determination, and hard work. And that in sports we call get, set, and go. This get, set, and go is the key in any field of activity. Now look to this organization, this beautiful building, this beautiful organization was initially conceived by Dr. Nitin and Professor Manish and Dr. Agrawal. And they, after getting the concept of it, tried to set. And now we are seeing it is going. Now it is in auto mode. But what effort they have made, that dream, you think it has happened magically? This beautiful auditorium happened magically? This conference is going magically? No. It just that is the domain of knowledge has got it. The knowledge of affection has set it. And the knowledge of action is going. So let us pledge today in name of Lord Jagannath that we will always keep the key in our pocket of get, set, and go in our life. Then only we can succeed. Now, my topic of discussion today will be our experience of cell therapy at my institute where I am working as professor since 2007. Now, this work has taken place a lot of effort, a lot of obstruction, a lot of energy, but succeeded by getting this oration. I am grateful to Professor Manish and Dr. Kanchan, Dr. Mahajan, and Dr. Alok for deciding to. I'm not willing to come to this conference because of this corona. And Professor Alok was so kind, and he told me in such beautiful words that you come to our auditorium, present here, so that we'll give you a sal, we'll greet you, so that you will enjoy. And that is really I'm feeling that why I was missing the bus, not to come and present it from my home, but really I'm delighted. God is great that I decided to come. So all things happens by God's decision. This paper in oration highlights the potential curative therapies, the based on cell-based therapy. Now we present here our experience On complex fistula, no, on incisional hernia, yesterday I presented, those of you are there. In carcinoma of the breast following a modified radical mastectomy, and in chronic diabetic ulcers and sickle cell ulcer, which is, we are in sickle cell belt, we get a lot of sickle cell patients. And then in Borges disease and other peripheral vascular disease, then I applied this in Hansen's ulcer and complicated bone ulcer. So all these are compared with conventional method of management, and then we decided, we gave thesis. In all these cases, I have given thesis to my residents in different years, and they have been accepted by Sambalpur University after ethical committee clearance from the institute. So institutional ethics committee clearance, that is done. That is the procedure all of you know. Now I'll come to the case study quickly. In fistula, you know, complex perianal fistula is a recurrent. If you operate, there is a saying, if you want to give a fistula, give it to your enemy. If Dr. Manish Khanna is a general surgeon and a fistula patient comes to me, I will give, no, go to Professor Manish, he will operate. Because I want to give him a bad name after failure of the operation. So fistula cases fails because of various complex reasons. That's why usually surgeons refer to their competitor to make him bad name. So what I did, I accepted them. Low fistulas, I didn't apply cells. To high fistulas, I injected cells after clearing the lower part of the fistula. Then compared preoperative, fistulograms, control and study group. Control group and study group. Thank you. On day 5, we see good quality granulation tissue coming in the study group. And on 3rd week, we still find in the control group, the wound is still bigger. And here in the experimental group, it has healed. And then we control the histopathology specimen of the control group. The fistula tract that we excised, we all sent for experimental study. And during the healing process, when we applied the cells, we also sent for histopathological analysis. Observation of the granulation tissue quality, then observation for local pain, discharge, and tenderness. And we found that necrosis was more in the control group, while in experimental group, it was less. Neutrophil and lymphocytes in the control group were less, and there were more in experimental group. Blood capillary level, that is budding capillaries, were less in number in the control, they are more in the experimental group. Macrophages were found more in the experimental group to clear the debris, and fibroblasts were also found more. This was given by the histopathological examiner study from pathology department. Now, in postoperative status, we compared the local pain to the control group study group. We found that local pain is less in the study group, while the floor of the ulcer, it was looking healthy from the very second day, 48 hours after, while it was not looking so healthy in the control group. Discharge was persisting in the control group up to day 7, but it disappeared from the study group on day 5. Tenderness was persisting up to day 7, appeared from day 2 to day 3 in study group. Diabetic foot ulcer. This was my initial study in 2007 in Cuttack. You see, diabetic foot ulcer, we applied 4 weeks after 1 week. This is the, after 1 week, and after 4th week and the 6th week, how it healed up. And I had presented this in Spain. I presented this in Phoenix, in the United States, and they were all surprised that this is happening while the patient has no amputation. In sickle cell ulcer also I applied to see how the ulcers are healing. Good quality granulation tissue, epithelialization is taking place in the study group quicker while this is persisting. In venous ulcer, okay, not varicose ulcer, venous ulcer, there is no treatment. What can you do? For varicose ulcer, you operate, Trendelenburg operation, perforator ligation, sclerotherapy. Then ulcer may heal, because in chronic venous insufficiency, what treatment you have? AIMS doesn't have. What to speak of peripheral medical colleges? Because you cannot replace vein by bypass and all those things. Chronic venous valvular deficiency in the deep venous system is a very difficult, complicated system for management. So I told, why not apply cells to heal the ulcer at least, then give this guard method and the conservative method addition to heal the ulcer first. There is no venous, there is no varicose vein to operate Trendelenburg operator. So chronic venous insufficiency ulcers also responds to cell therapy. Now in Borges disease, this gentleman was having severe critical ischemic limb. They were trying to commit suicide. The distal vascular disease, small digital vessels. How can you do stenting bypass when there is distal vessel? The digital vessels are blocked. The microangiopathy in diabetes, those pathologists they know, surgeons know, physicians know. Diabetes is a global disease which produces microvascular changes. Then it will go to macrovascular, of course, later. But initially retinopathy, then kidney nephropathy, and all the digital changes and the foot changes occurs because of microangiopathy. And that microangiopathy leads to neuropathy. The vessels, the vasonervosum gets blocked in diabetes. Both motor, sensory, and autonomic nerves gets damaged because of microangiopathy, initial microangiopathy, because of glycolysis of the vessel walls. So that causes severe rest pain. Patient cannot sleep. No analgesic response. Professor Alok Agrawal must be knowing. In no diclofenac, no morphine, pethidine will work. Patient will sit, catching the fit, and continued of such problem make me commit suicide, try to commit suicide. And this gentleman came, and with that reason he wants to commit. I injected cells to his periphery beyond the popliteal territory, to the soleal, to just not to the vein, not to artery, but only subcutaneous plane where there are cutaneous nerves ending. I injected into cutaneous nerve ending and injected into the ulcer bed, ulcer floor, ulcer margin. And immediately after 6 hours, believe me, I want to control study with AIMS, Raipur. Nobody is coming forward because nobody is accepting. Now I must thank Professor Ghosh today. He told it must be accepted as a collaborative study. And we can take this research further when we have multicentric trials. Rest pain disappeared within 6 hours, and he thanked me as God, and still living with a good limb. So this is how we inject the cells. This is the digital gangrene. Many patients. This patient is still lying in my bed. When I go back, I'll give him second sitting. First sitting I've given last week. And before giving, this was the condition. He came to many colleges. He went to Bhubaneswar, different colleges. Everybody wanted to amputate, and they made the angiogram, there was blood, and they wanted amputation. He did not agree, came back to Balangir. And then somebody told, go to Dr. Mahapatra, he may help you. He may help you. Well, I admitted, I explained, in the ethics committee, clearance was taken, and I injected the cells to the periphery, to the subcutaneous plane, to the ulcer floor, bed, ulcer margin. Of course, after debridement, you cannot give living cells in dead tissue. And what is necrosis? Necrosis is a microscopic death of necrotic tissue cells. They will also die. So prepare the bed properly before injecting cell therapy or transplanting cells there, autologous cells. Now, this is also an interesting story. Hansen's also I did. And this lady had Hansen's disease, was rejected in the family. This was the food condition. And after cell therapy, you look at the condition, you are accepted in the family. The daughter-in-law was afraid to go to the mother-in-law. This is the mother-in-law. And this happened after cell therapy. Look at the food. Believe me or not, this is the same food. Now, in cell therapy in bone also, what can you do? Orthopedic surgeons, great surgeons are here. When the joint is bone completely, ligaments gone, synovial membrane born, capsule born, what can you do? You have to wait. Entire leg is born. So you have to recover fast by fibrosis or by regeneration of the tissue. And they will not regenerate into joint capsule or joint ligament. They will produce ankylosing fibrosis. So fibrous ankylosis will start, and then you can go for grafting. And later stage, you can joint reconstruction. So that is the problem when the extensive bonds you can try. And this cell-coated mesh, yesterday I had talked, and this is what can you, this mesh, difficult incisional hernias. To coat the mesh with cells and apply, the result is better. Yesterday I have discussed this. Now, following cancer breast, this is my experiment with cancer. After a modified radical mastectomy, I gave thesis to one of my postgraduates that one group, let us apply own cells, patient's own cells to the breast bed and axilla. Modified radical mastectomy, we dissect the breast, we dissect the axilla. Only cases, not locally advanced or metastatic cases, we don't, the exclusion and inclusion criteria are there. But early breast carcinoma, stage 2 or early stage 3, we do modified radical mastectomy, where we remove the breast, remove the axillary tail, remove the axillary fat, fascia, lymphatics, and there the chance of recurrence is there. Why? There may be spillage, there may be leftover nodes, there may be recurrence at the local site, and injecting cells will may modify the local recurrence and may modify the local complications that we observed. And study group, control group, we found that local pain, local stiffness, local seroma, everything was less in the study group. So this is the mechanism of action we have now. So progenitor cells that activate many growth factors that has been discussed extensively yesterday is probably playing the key role here. And activation of fibroblast, endothelial cells, proliferation, and angiogenesis is also playing great role. And there is a meta-analysis of autologous cell therapy for peripheral vascular disease, systemic review meta-analysis of randomized, non-randomized, and non-controlled studies has been done by several other authors. And the primary analysis showed that cell therapy reduced the risk of amputation by 37% and improved amputation-free survival by 18% and improved wound healing by 59% without affecting the mortality. So bone marrow cells act as a novel and feasible technique for treatment of complex fistula, chronic ulcers, cancer of the breast, incisional hernia repair, and decreasing the postoperative morbidities. And so this paper was also presented in the Association of Surgeons of India in its annual conference in December 2020, 2 months back. On 18th December, I presented this paper, and a competitive paper, an innovation paper. That was an award for it. And for your kind information, this is the certificate I received, signed and sealed by our president, Dr. Abhay Alvi, Santosh and Abraham is the director and of the institute. So this is the paper, got first prize in all India level. So that I am proud for it, but by humble that my work has been accepted by international Indian stem cell study group today. So to conclude my speech, I must thank Again, the organizers of this conference, Indian Stem Cell Study Group, I'm extremely grateful. Now, the way we act in a given situation is more or less influenced by the mental images that we have of the past experiences. Now, in stem cell technology, most of us don't have experiences. And we speculate that this is going to happen, this is going to happen. And William Osler, while delivering his convocation address in Harvard to undergraduates, he told that the education in which we are engaged is not a college course, is not a medical course, but a life course for which training in any institution is just a beginning. And we are all undergraduates in the School of Medicine. With that language that we feel we are all undergraduates in the School of Medicine, and we have to take up research, we have to take up our work further height from ground level to 36,000 level so that we can enjoy our profession. Thank you very much. Thank you, sir.
Thank you so much, sir. So for a wonderful journey of yours, of the great achievement, the dedication, we all are inspired with it and hope that in coming years, you'll keep on inspiring us with your work. Thank you so much, Professor Mahapatra, sir, for this wonderful oration. So usually we don't have any questions. So if any question is here, we can have it. Thank you so much. I would like to invite our director, Professor Nitin, to just facilitate, sir, with a post-lecture gesture.
Mahapatra, please come, please come.
अच्छा पोल्ट्री मत खाने क्या किया
I like to request Dr. Meenakshi Sinha ma'am, Dr. Momita De ma'am, and Dr. Fugal sir to kindly chair the next session, please.
We are now we are going to start with the next session, and our next session is going to start with an online lecture by Dr. Marco Drop, Trans-European Stem Cell Therapy Consortium from Switzerland, and he is going to give us an online presentation. We look forward to hearing to him.
Hello, good morning. I just have to install here my presentation. Please. Okay, can you hear me? Am I audible to everyone? Audible. Hello.
Yes, sir, you are audible.
Okay, thank you. One moment, please. Okay, can you see my presentation? It's possible for you?
Yes, sir.
Yes. Okay, thank you very much. Many thanks to the Indian Stem Cell Group Association and the All India Institute of Medical Science for the honorable invitation. And really my special thanks I would like to express to Dr. Kanchan Mishra and to Dr. Manish Khanna and all the efforts to develop a synergy between the Indian Stem Cell Group Association and the Trans-European Stem Cell Therapy Society. I would like to go into my presentation directly. So it's entitled Impact of Stem Cell Therapies for Advanced Treatment of Neurological Diseases, iPSC and CRISPR Technology Changing Perspectives How to Treat Incurable Diseases. Because of the short time I have to present, I really have to focus on selected examples for the most advanced technology in the area of stem cell application towards medical application. The rationale is very clear. It's focused to brain function disorders, and they are giving rise to far higher level of disability, including admissions to hospitals, nursing homes. And for this reason, this kind of rationale is widely recognized to tackle brain function disorders. So the stem cell technology is a powerful tool to tackle these problems. Anyhow, the stem cell technology and all the tools we have in our hands now have to prove the ability to alter the patient's quality of life. Otherwise, it's really a pure academic discussion. Anyhow, the stem cell research so far has delivered a tremendous amount of understanding in human biology, medicine, and fired the complementarity of a significant number of biomedical as well as IT-related disciplines. I just would like to give, in brief, some rationale why it's so much important to develop and to use this technology. So, Parkinson's disease, as an example, has hit around 6.3 million people worldwide. Alzheimer's disease, actually 50 million people. No cure for the moment. Stroke is annually around 15 million people worldwide around 5 million people are left permanently disabled, placing a burden on family and communities. This is something we very often forget. Health economists have calculated that brain disorders may cost as much as 45% of the annual health budget of Europe, totaling around 800 billion euros. Now I would like to share with you selected neuro-related targets of stem cell treatment reaching clinical relevance. So I would like just or briefly present a work of my colleague Malin Parmar from Lund University. So she's working over years on using embryonic stem cells, especially embryonic stem cell transplants, to treat Parkinson patients. And just this year, Dr. Parmar or Professor Parmar is starting with a clinical trial. And so far, the data I've seen, it's really promising. But anyhow, clinical trials are tedious and time consuming, and it will take time to see how it works in these patients. Then I would like to emphasize on a phase 1 clinical study, which is running now, or which started in 2018. So this is focused on the use of embryonic stem cell-derived retinal pigment epithelium patch. So basically, it's a stem cell patch to cure macular degeneration. The work has been started by my colleague Peter J. Coffey and Lyndon Da Cruz in UK. Then I would like to emphasize on the technology, because when we talk about stem cell technology, we all know that embryonic stem cells have the biggest potential for usage. But because of the ethical limitations, there was a lot of pressure into the scientific community to find alternatives. And the alternatives are clearly MSC cells as well iPS cells. I have no time here to report on our group's efforts on MSC cells and COVID therapies. But with Miomir Knežević from Slovenia. Then I would like here to emphasize technology-wise on the latest Nobel Prize, which went to to Emmanuel Charpentier and Jennifer R. Doudna, which have incorporated the Cas9 gene editing system for the medical usage, which really revolutionized the potential also, or just to cure also diseases which are not curable for the moment. So there's a lot of promise on this technology. So then I just would like to emphasize on iPS cells, HYPE and TOPE. So mouse iPS cells were first reported in 2006, and human iPSCs then shortly 2007. And they clearly demonstrated that they're being able to contribute cells to many different tissues and transplanted at a very early stage in the development. Human iPSCs also express stem cell markers and are capable of generating cells of the 3 primary tissue layers. So what? So iPS, why they are so important? So iPS cell lines are envisioned to facilitate many categories of research in this important area of stem cell science, understanding the action of the mechanism of reprogramming factors, determining pluripotency programming of individual cell fates in stem cells. So the iPS stem cell technology is so much important because it provides a lot more look into the cell machinery and less into the applicability for medical use. So it's still, so that means iPS stem cell lines are a fantastic tool. One moment, please. A fantastic tool to study in vitro a disease, and in combination with the CRISPR technology, really to in vitro switching a disease on and off, and to get on the cellular basis a lot of knowledge about Parkinson, Alzheimer's, all the neural diseases as well, autism, and so on. And I would like to emphasize here, for example, on the European Bank for Induced Pluripotent Stem Cells, ISCSGCON. So as a researcher, you can get very easily access to up to 800 completely defined iPS stem cell lines for a whole set of neural diseases or neural disease. For example, 45 iPS cell lines derived from Huntington's disease gene expansion carriers and associated controls. And this is a very extremely powerful tool for research of these diseases. And why is that? Because the iPS cell lines offered, or which can be used from this cell bank, are cross-linked with patients' data or with patients' data. So, and that's also the reason that big pharma now is very much interested to push this kind of technology. As you can see, so ISCSGCON is making sure that all these cell lines are standardized and on a very high quality level. Okay. So I did talk about gene editing, and as you know, there are different possibilities to use viruses to express the protein factors necessary to convert the cells, and the Zendai virus takes here a central role because it's non-integrating system with the highest level of safety. And in this relation to that, I would like just to emphasize on Huntington's disease, which is a very good target for CRISPR treatment. There are many groups now starting with or have started clinical trials. One possibility is emphasized on self-destruction, enhancing the precision of the CRISPR-Cas9 box, because the tool is the gene scissor, and it's very much important that this tool is working as precise as possible to enhance the potential of success. Another example is Editor's Medicine in Cambridge. So they are using now a virus to insert the whole CRISPR-Cas9 gene editing machinery inside the body. That's the first time that this happens. I'm now coming to the final state of my presentation. So California voters approved another round of funding for stem cell research. So that means that also in public, it's widely accepted technology, and it's especially in the US, the communication to the public is excellent, so that this kind of novel approaches are widely accepted. Anyhow, I have clearly to emphasize that there's also technical, or the technique can also cause problems. That's very clear. So caution urged for the use of gene editing technology CRISPR. So recent studies on the gene editing method CRISPR have raised concerns about the suitability of this technology for the treatment of genetic illnesses. Why is that? So that means stem cell related clinical applications are working in clinical severe conditions, but CRISPR gene or gene editing, the gene editing machinery can also cause unintended changes to other parts of the genome, and this is the biggest problem on that technology. I would like to end my presentation with the words of Professor Pete Coffey. Researchers seldom like to predict how long it might be before their discoveries are tested in patients. At least 5 years is a typical response, but one that should usually be taken with a pinch of salt. Research is complex. There are many obstacles to overcome, and some promising ideas never get anywhere near a clinic. So now we should think in terms of society. Everybody, ill or healthy, is a part of the society. That should lead to solidarity and consensus instead of considering health only as a financial burden. Many thanks to the audience.
Thank you very much, Dr. Marco, for a wonderful coverage of a topic which was quite less covered, I would say, that is on the neurological diseases since yesterday. And you gave us a wonderful insight of the topic. Now, if there are any questions from the audience may ask. Maybe we have time for 2 to 3 questions.
So thank you very much.
Welcome, sir.
So please.
Any questions? Yeah.
Hello, sir. Hello, Dr. Marco.
Yes, good morning.
Good morning, sir. Actually, I was keenly listening to your lecture. It's very, very nice. Sir, actually, I have a query, important query. Like because the neurological condition, it has been discussed, Alzheimer's or Parkinson's. Like we have a pharmacotherapy aspect, actually. Clinical pharmacotherapy was there, actually. So in the cases which there is a resistance, only we are looking for the alternative. My question is that whether the stem cell therapy or whichever modality we are planning, whether it is given as a monotherapy or with the pharmacotherapy you are planning. because most of the therapy are in combination with the other available intervention.
Yes, I think you made a very good point here. I think it's very much important that we have to see the picture as a whole. So the combination of certain kind of tools we have will be very much important for success. It's not only the embryonic stem cell itself. It's really the whole system we have to check out. And this is something which the stem cell technology has produced. It has produced a complete new new look on how cells can work. But the cells, when the cells work fine in the experiment in vitro, it has also to work in the whole body, and the whole body and organs. That's a much more complex story. And from that point of view, it needs really a combination of methodology and also on philosophies.
Okay, sir. Thank you very much. Because I want to share my experience that in non-healing leprosy ulcer, I was actually previously I was in leprosy institute. We used to give fibrin gel with phenitoin. Okay, phenitoin as it will inhibit the collagen.
Yes.
There will be a deposition of collagen. So, like we never give fibrin gel alone. We used to give addition of phenitoin. So,
Yes.
very good result. So that is what my concern actually, because we are not every time we are just speaking on the monotherapy only. So there is always a need of a combination therapy for getting a good effect.
Yes, absolutely.
Thank you, sir. Thank you.
Yes, thank you very much.
Sir, thank you very much.
Excuse me, I have one more question.
Yes.
This is Dr. Pradeep. The talk what you Marcos gave is very exciting to understand the insight of neurological improvements using stem
Yes.
cells. But overall, the question which came as an individual therapy or in combination therapy or integrated part of the therapy. Well, we have documented here saying that it should be always an integrated therapy to show the optimum outcome of the cases.
Yes.
Adding question to you here is that in few of your presentations, you have mentioned how we are translating fetal stem cells or embryonic stem cells to benches. But do we have really come to the time where we can take the stem cells from the embryonic origin or fetal origin to the clinical site at this moment?
I have to tell you, this is not future. That happens. It's happening in California at the University of San Diego. So the embryonic stem cells are used widely to treat Parkinson's disease. So, but these things are happening. I think the other point is it has to be, so stem cells have to be used under regulated conditions. So any usage of stem cells outside of regulated conditions have to be condemned. And on the other side, the technology now is used in many places worldwide now, which are really regulated and which are properly used. So this is embryonic stem cells for Parkinson, MSC cells for a whole bunch of treatments, and from that point of view, this is not future. I have been talking here. This is happening right now. One of the problems is that the pharma industry, the big pharma, has a problem with the cells because it's not so easy to put just the patent of a cell. And for example, Novartis is offering a one-shot, one-cell treatment of ALS, and the cost is 4 to 5 million Swiss francs. And so with a guarantee of 11 years survival. So so from that point of view, the whole picture is really complex. So on one hand, on the research side and the clinical side, a lot of things are happening, but it's the whole picture is also driven by the pharma industry, and the pharma industry, their idea was over 100 years to use chemicals for treatment, and they have really experience that doesn't work. So cellular therapies are not the future. They are now used. Industry is stepping into it, and the clinical trials have really to prove that they are able to success, and they are promising results out, but it takes time to get the full picture. I'm very carefully with my evaluation.
Yeah, I appreciate the way you're given the views, because in fact, in the total science of biology and stem cells or regenerative medicine, if you see, every day is a dynamic thing happening. When we talk of transplanting fetal or iPSC cells for chronic regenerative disease, but there has a new theory come up, which is called as the UPRs, like unfolded protein responses. Are taking up more of a neurodegenerative treatment protocols, which will be coming in the molecular form.
Yes.
Is also going to be a competitive along with the integration part. If you see the results to take off, UPR protein management will be a more better form than going for a transplant form. The risk and benefit if you associate to it. Third part, which I was to talk about, is that when we talk of induced pluripotent cells to convert into a therapeutic part, but there are new technologies which are coming up which can lead autologous adult cell to adult cell transfection, leading to get into his own non-rejected cell components, which are coming in the form of tissue nanotransfection in future. Thank you.
Yes, thank you for you.
Thank you very much, sir. Thank you for your time and wonderful insights. Thank you very much.
No, I thank you very much, and I'm really proud to present in India, and I think your country can really be proud on the scientists' contribution to vaccination on COVID. This is fantastic, really.
Thank you. Thank you.
Thank you very much.
Good morning, everyone. Next, I call upon our speaker, Professor Dr. Shoman Mishra, for his speech on role of stem cells in ophthalmology. Welcome, sir.
Let's start. Good morning, everybody. At the outset, I thank our director, sir, Professor Nitin Nagarkar, and Professor Alok Agarwal to make this happen. With this COVID, at one time, probably we thought, in fact, we planned it for last year, the COVID started, and we could not make it. But I never thought that it would be possible. It is the first sighted vision of our director, sir, and the hard work of Professor Alok Agarwal, which make it happen. And we are here very much. Thank you, sir. So I start my presentation. The stem cells were first discovered in ophthalmology. I will not go into the general stem cells by Devenger and Evenson in the year 1971. And these stem cells were found around the limbus in a palisade of Vogt. In 1989, the first limbal stem cell transplant was possible, and it was done by Keong and Seng. Now coming to the real stem cell, first it was found around the limbus. Limbus is nothing but the junction of cornea and sclera. That is called limbus. So around the limbus, first discovery of stem cell took place, and scientists continued their journey, which I'll tell later. These are called corneal stem cells, which are located around the limbus, and they're, in brief, they are called LESC, or limbal epithelial stem cells, because it is at the limbal and around the region of epithelium. How to identify it? The stem cell has been found on with the electron microscopic study in the pattern of palisades of Vogt. Now coming to the real clinical condition where stem cells are deficient, there are three clinical conditions where stem cells are deficient since birth. First being aniridia, although it is a different clinical conditions like absence of the iris, but stem cells are absent around the limbus, major deficiency. And look at the photograph, all these three clinical conditions, aniridia, ectodermal dysplasia, and cicatricial pemphigoid, where stem cell is deficient, I mean limbal stem cell is deficient since birth, and the deficiency gives rise to three important clinical changes. First is conjunctivalization of cornea. What is conjunctivalization of cornea? Conjunctiva is limited up to the limbus, then the cornea starts. So in this condition, the conjunctiva starts growing over the cornea. That is called conjunctivalization of the cornea. Then the vascularization, by and large, but originally cornea is an avascular structure. There's no blood vessel, healthy, normal cornea. And you look the second photograph where this is a second photograph, where you look at the cornea where the blood vessels have grown from all around. Blood vessels have grown all around. So conjunctivalization of the cornea, vascularization of the cornea, and that has led to look at the cornea, which is absolutely transparent. It is practically white. So giving rise to blindness. So there are three clinical conditions where we are devoid of stem cells and which has led to corneal blindness due to corneal opacity. Now dysfunction of the limbus stem cells in rather acquired conditions. These are three congenital conditions I have told. These are three acquired conditions, that is pterygium, here deficiency of limbal stem cells, not other stem cells, chemical burns, and Stevens-Johnson syndromes. So in these three clinical conditions, there is a major deficiency of limbal epithelial stem cells, not elsewhere. Again, leading to two conditions where corneal opacity, other is something growing over the cornea, somewhere here, something growing over the cornea called pterygium. Now, what is pterygium? It is a degenerative condition where the conjunctival and fibrovascular tissue grows over the cornea, leading to astigmatism and also loss of vision later stage. These conditions, around 35 years of my professional career in ophthalmology, people all over the world have started this finding why, and there must be more than 20 surgeries which has been designed, redesigned by different scientists all over the world, and people had no answer. Around 10 to 15 years back, some scientists noticed that it is not the surgery which is important, it is the stem cell which is deficient in pterygium in this photograph. And due to the deficiency of the limbal stem cell, this degenerative condition is growing. And the complete surgery, more than 20 surgeries which people have designed all over the world, and over 50 years, everything became obsolete, and people started thinking of stem cell transplant, either from the same eye or from the other eye. So this is about pterygium, and the surgery is the last statement. Surgery is you bring the stem cell either from the same eye, elsewhere, other part of the same eye, or from the other eye, and you have to put a conjunctival graft, because stem cell you cannot see. You simply take a graft, the stem cell will come along with the graft. So we cannot pick up the stem cells, so you pick up the graft, and the stem cell will automatically come and will cure the condition, which took more than 50 years of different experiment to find out the stem cells are deficient in this condition. Next is stem cell in conjunctiva. So people started searching stem cells all around and found in the conjunctiva, and three clinical conditions, rather three pathological situation comes. One is conjunctival scarring, and other is cicatricial pemphigoid and dry eye. All these are deficiency of stem cells, which probably played a very big role, which disease is eradicated. That is trachoma. Trachoma is practically eradicated now, but that time also the trachoma probably has destroyed the stem cells and leading to similar conditions earlier, which is practically now gone. As people's journey continued, people found stem cells in the iris, and it's still not much work. The ciliary body. This is known. The ciliary body stem cells has potential to regenerate retina. Different retina degenerative conditions where people are blind, retinal blindness. I mean, not the other or earlier one of the corneal blindness. There we can mobilize the stem cells of the ciliary body to migrate on the retina and can regenerate the neuroretina, leading to regainment of vision. So this is neurogenerative cells which is there in the ciliary body. Also, people's journey continued and people found out stem cells in the lens. Obviously, it is operable and in a different condition, but still people have found stem cells in the lens also, I mean crystalline lens. Stem cells in ARMD. ARMD means the commonest cause of legal blindness in the developed country as of today is ARMD, age-related macular degeneration. People of the 80, 90 or more have lost the central vision, have become blind. The name says the central retina is degenerated, age-related macular degeneration leading to blindness. This is the commonest cause of legal blindness in the developed country. Because other conditions are treatable, this is practically untreatable. Here, the stem cell has played a big role for the regeneration of the macula. The first stem cell was tried in ARMD in the year 2012. This is in brief how the stem cell can reach the degenerative retina or the macula. It can be injected in the vitreous, probably with the intravitreal and all newer advances. Something here we can inject in the vitreous and the cells will migrate and reach here. Inject here, which is very easy, and will migrate here. You can directly inject there, but as you know, the macula is very sensitive, the neurosensory retina, and it may lead to complications, but it can be injected directly at the site here, second one, or it can be injected little away from the site, which automatically will migrate to the site and will start its repairing work. So stem cells in ARMD, 3 injection sites where it can be given mainly from the fetal embryonal stem cells or other stem cells, which I have already mentioned. This is in brief where we stand in ophthalmology in different areas of stem cells. This is a schematic diagram. I know how clear it is. It's a big diagram. It shows where we are. These are where the rats are there. These are in animal models. Different stem cells are being tried in the animal experiment rather. These 3 are in animal model, which people are trying, rather experimenting. with the stem cells. Here, one more in the trabecular meshwork. These are all animal models and rather animal experiments. These three are in human trials, like choroid, conjunctiva, retina, vitreous, optic nerve, already has come in the human trials, others are in animal trials. And the last one, and the limbus already in clinical use. I have mentioned the clinical conditions where it can be transplanted or being transplanted at many places, particularly two institutes at RP Center and at LV Prasad Eye Institute in India. Extensively, they are working, and people got the Bhatnagar Award and all those. And we here at Raipur AIMS, some of our faculty members are already doing this work, the limbal stem cell transplant, putting a surgical technique, SLET or SLET, putting the stem cells, small pieces, putting with the cyanoacrylate glue and putting over one bandage contact lens so the stem cell can migrate. That is already, we are doing it, quite a good number of cases we have done right at AIMS Raipur. That is mainly the limbal epithelial stem cell by SLET operation, which is there and with a good encouraging results. So in brief, this is the present status of stem cell where we stand all over the world. Already one in clinical use, probably another few more will come in near future. To conclude, probably 100 years back, Tagore thought in his imagination that probably everybody wants to live forever. So that is more than 100 years back, his imagination. Today, where we stand here with the regenerative medicine and other transplants in the human body, by the year 2050, the whole medical world may make humans immortal by the year 2050, which was the imagination of Tagore 100 years back. So I leave it for the 2050 to make humans immortal. Thank you. Thank you.
Thank you very much, sir, for your excellent and impressive and understandable presentation. Is there any questions from the audience? Few questions. Okay, thank you very much, sir.
Sir, we would like to felicitate you.
I call upon our next speaker, Dr. Saptarshi Mondal. He is an associate professor at transfusion medicine at AIMS Jodhpur. He will be online with us today, and he will be delivering his lecture on angiogenesis and vascular remodeling in inflammatory arthritis.
Okay, can you hear me? Am I audible?
Yes, audible.
Okay. So good morning, everybody. I'm Dr. Saptarshi Mondal, and today I'll be talking about angiogenesis and vascular remodeling in inflammatory arthritis. And I would like to thank Professor Alok Agarwal and the organizers and Director Professor Nitin Nagarkar for inviting me and for organizing this conference. So, just very brief, and then I went to Stanford University where I attended a lot of courses. I was a MS master's student there, and I also attended a lot of courses on stem cell engineering, tissue engineering, and regenerative medicine. And then I joined the University of California, Davis as a postdoctoral fellow in the Department of Rheumatology, where my professor, he moved from Stanford to UC Davis, and he took me as his first postdoctoral fellow. And I did a lot of work on angiogenesis there. And then I was invited by Professor Vinay Kumar to do a residency in pathology in University of Chicago, where I did my residency and my fellowship in transfusion medicine. And then I came back to India, and I'm presently in AIIMS Jodhpur. So I started this book chapter when I was a master's student in Stanford, and I'd done a project in regenerative medicine. And so Professor Shiva Prasad Raychaudhuri, who was a rheumatologist, he saw my presentation and he invited me based on this. And so I wrote this book chapter also with him. And so, 10 years later, I wrote another book chapter with my wife. She was that time in CMC Vellore, and so we both share our common research interests. So here we start with the topic. So if you see that normal synovium, there are like particular structure of arcades of blood vessels which get completely disrupted in inflammatory conditions. And in all inflammatory arthritis, there is simultaneous increase as well as some pruning in different parts of this angiogenesis, and which is qualitatively and quantitatively very different. And so as a student at that time, I was very fascinated by the regulation of angiogenesis by hypoxia, which I later realized is only a very small tip of the iceberg of the regulation. And so at that time, I came up with this cycle of the vicious cycle of rheumatoid arthritis, which was true only for rheumatoid arthritis mainly, but for other conditions, it was way more complex. But this made place into that book chapter, which I wrote with Professor Raychaudhuri. So it is indeed true that when there is more hypoxia, there is more vessel, but those vessels are not helping. Those vessels are actually adding to the metabolic burden, and that is aggravating the hypoxia. So there is more blood vessels forming. So in rheumatoid arthritis, the pannus is growing and it's invading into the bone, and it's causing bone loss that way. So here is a comparison of, if you see on the top, that is a normal synovium, and the yellow ones are the bone, and the synovium is the pink one. And if you see the comparison on the osteoarthritis, is a bone growing into the bone growing out like osteophytes. And on the other side, if you see, it is the other side, you see that in rheumatoid arthritis, the pannus is growing into the bone, right? So this picture might be familiar to many of you when you see in arthroscopy. So the pattern of the blood vessel is also very different. So on the right-hand side, if you see rheumatoid arthritis, the pattern is very branching. Here is a little better picture from another publication. So here on the right-hand side are the pictures where you see straight branching pattern of angiogenesis, whereas on the left-hand side you see more tortuous, more kind of convoluted kind of angiogenesis. So here are some little bit of statistics from different publications, and if you see the rheumatoid arthritis, you see mostly straight branching vessels, which is pretty large in percentage. Here's another, let's see. So 84% of rheumatoid arthritis are showing straight branching angiogenesis, almost like a broomstick-like picture that you saw, whereas 91% of early psoriatic arthritis had tortuous bushy vessels, and only 9% had straight branching vessels. And 16% of rheumatoid arthritis also had mixed patterns. Now, when we talk about psoriatic arthritis, we can't miss the topic of psoriasis, which was one of the earliest diseases, so which was related to angiogenesis. So when angiogenesis was first discovered in tumors, the very next year, the discovery of angiogenesis in psoriasis, not angiogenesis, but relation of angiogenesis to the mechanism of psoriasis was discovered, and that mechanism is also connected to the psoriatic arthritis. So if you see in the nail bed, it was discovered that in psoriasis, there are very tight loops of convoluted blood vessels. And those loops are mostly venulized. That is, even though they are growing, apparently you might think they are going to be arterioles, but they change their nature into venules, so they are going to be leaky. And through these leaks, actually, there are neutrophils and other cells coming out, and there are small microabscesses and other structures which are specific to this disease. They are coming out, they are homing there because of these because of this leaky and sticky vessels. And the particular mechanism by which these vessel convolutions are happening is also very interesting. That was a topic of my 70-page article. So I'll come to that in a moment later. So now, why is this angiogenesis in psoriatic arthritis so different from the rheumatoid arthritis? So there has been many different speculations, and there is some evidence for a few of those. As for example, people have shown that there is a difference in expression of integrins. Like in psoriatic arthritis, you have increased expression of the basement membrane integrin that holds the endothelial cells. There is also increased expression of the angiogenic markers TGF-beta and VEGF in psoriatic arthritis as compared to rheumatoid arthritis. And that way, psoriatic arthritis shares some common features with in other inflammatory reactive arthritis as well. And also, rheumatoid arthritis is more in inflammation with TNF-alpha, whereas psoriatic arthritis has more of IL-17 related mechanisms. However, the IL-17 is not coming from very classic Th17 cells. In case of psoriasis, in the epidermis, they come from neutrophils, and in the dermis, they come from mast cells, which also are major sources of IL-17 in that disease, which is relatively different than other conditions. And also, there is a plethora of other cells, which I'll be briefly mentioning later, which play a very complex role. And also, there are various VEGF isoforms whose roles are different, which I will be summarizing in another slide. So, and also, even though there is so much VEGF, why is it not causing hyperplasia of the synovium as well? The explanation is not exactly clear, but some of the hypothesis includes that there is a lower level of LIF and oncostatin M. That's only one hypothesis. People don't really exactly understand, but it's an enigma that in psoriasis, in case of growing and the way even the lifespan of neutrophils are long is quite different from the physiological situation. However, it's not acting the same way in every tissue. So here is just a brief summary where if you see that in these box plots, you see that TGF-beta and VEGF are more in psoriatic arthritis and late inflammatory arthritis, whereas in case of rheumatoid arthritis or osteoarthritis, they are quite less. So just continuing with the contrast, in case of osteoarthritis, we see bone deposition and osteophytes, and whereas in psoriatic arthritis, we are seeing both what is seen in rheumatoid as well as osteoarthritis. You can see features of both in case of psoriatic arthritis. And also, there is a little bit of mechanistic insight known, but this time is too short to get into the mechanistic part here. So here is another aspect. So if you see the timeline, the time with which rheumatoid arthritis evolves is pretty long, prolonged. And only in the late stage, you get so much angiogenesis. Whereas in psoriatic arthritis, the evolution is almost explosive. If you see this time graph, and the angiogenesis happens quite early on, whereas in case of inflammatory reactive arthritis, it is not so fast. So psoriatic arthritis is one of the fastest evolving angiogenesis in case of inflammatory arthritis. So the history of our understanding has also been evolving. Like earlier, people used to think of autoimmunity. Now we think of another term called autoinflammation, which I'll be coming in next few slides. So the overall picture of our understanding has been evolving. Now it has been involving biomechanical stress. It has been involving genotype. It has been involving microbiome, role of the microbiome, microflora. And also there is a very complex interplay of various different cell types and various signaling networks. So just I want to briefly mention one of the major change in the understanding has come from Dr. Dennis McGonigal. So he has shown that even though we classically think that enthesitis is there only in some joints, but he has shown that many joints actually share partially enthesitis-like features, and it is those places from where actually nerve cells also invade and also blood vessels invade. So if you remember that during development, the neurovascular bundles grow together because the signaling molecules that regulate the nervous growth and the molecules that regulate the growth of the blood vessels are quite shared, and the signals there is crosstalk between these signals. And so here there is more pain because there is more nerve, but also the blood vessels and nerve growth factor. For example, nerve growth factor, though we call it nerve growth factor, but my mentor, Professor Shiv Prasad Raichaudhuri, was one of the first to show that NGF is also a major angiogenic molecule. So, so this work that I've done with Professor Raichaudhuri in University of California, Davis, later on I have continued in a slightly different line, but this work was very interesting, and I have published these two book chapters with him, and where, like for example, here, if in this picture, if you see that there are these microfractures in these in the blue, if you see this, these are the fibrocartilage, and this fibrocartilage is having this microfracture. Those microfractures will be the place from where this whole problem is starting. And so this is actually micro-inflammation, which is evolving into angiogenesis. So it's more of auto-inflammation rather than autoimmunity in case of psoriatic spectrum of disease. So here McGonagall goes ahead and makes a more integration of this, which is related to orthopedics in general. So, and then he has also shown that, so there are these different diseases. If you see on the left-hand side, so autoinflammatory versus autoimmune, they have shown examples of some diseases which are very high in autoinflammatory score, whereas at the bottom, if you see, there are diseases which are very high on autoimmune, and there's a whole spectrum of long list of diseases, which I'm not going to go into right now. So here is again another side-by-side comparison of the different factors of autoinflammatory versus autoimmune classification that they have proposed. It's not yet coming to the mainstream, but it's a very interesting hypothesis which might be related to the mechanism of these diseases. And so what they're trying to propose is that traditionally we say that there is this T cells and autoimmunity which is triggering this whole pathway, whereas now people think that it is aging and damage and microflora and other environmental problems actually more directly regulating our internal milieu and causing more angiogenesis. So just briefly about angiogenesis in general. So angiogenesis undergoes a cascade of steps. There is initiation, then there is amplification, then there is a stabilization. And if you see during initiation, what happens is the endothelial cells become activated. And that involves changes in the basement membrane, which induces certain trigger master regulator genes like Hox family of genes. Hox is homeobox. And there is, on the right-hand side, there are some pictures of just a few examples of those genes. And then the picture zoomed out. This is like over the last 3 decades, people have understood gradually bit by bit that there are so many molecules involved. And initially there is breakdown of molecules. And then later on, some of those broken molecules are the same thing, which was stimulatory now becomes inhibitory to the angiogenesis. And so there is some sort of a feedback loop which closes it. But the actual picture is far from complete here. So like, for example, nowadays we understand a slight more detail of the different steps. Like, for example, the cell that starts the process is called the tip cell, and behind the tip cell, there is a stalk cell, and all those cells have various different properties. And these stalk cells must be bridged by immature myeloid lineage cells, which are called MDSCs. And so there are all these complex interplay of different cells. And in each of these, actually, there are many different stem cells involved. For example, in the tissue, there is this mesenchymal stem cells, which undergo Hedgehog signaling, and those pictures are not in there. The time is too short to get into too much of that. But we must remember that in every tissue, there are different tissue stem cells, which are resident stem cells, and then there are circulating endothelial progenitor cells. So there is both local proliferation as well as global recruitment of these different types of progenitor cells and stem cells. And they interact in a very complex way in every tissue. And this angiogenesis in the inflammatory arthritis is no explanation, no exception. But there is like very interesting different manifestation of the same set of cells in different environment. And so finally, when the network is stabilized, when the blood flow is established, then the whole picture looks different. And so in case of endothelium, in case of synovium, there are just this specific set of players, which initially we thought these are these many. This was the picture sort of 10 years back, but now we know that this number of players is way more. And so, and our knowledge has got back and forth from the tissue, the subject of tumor angiogenesis. So majority of the experimental result comes from tumor angiogenesis. Majority of the drugs come from the investment in tumor angiogenesis field, but many of them have been tried in this field as well. And so, so just a very small tip of the iceberg. Like, for example, for initiation, we know that there is this sequence of cascade of signaling that goes on. Initially, there are a certain set of genes. Then those genes, they switch on to some other genes. And then eventually when it closes, so there is an initiation, there is a peak, and then there is a decrease in the whole complex network of interactions, both at a genetic level, at a gene expression level, as well as tissue signaling level, as well as systemic level. And so some of these things, if you tweak around, for example, if you take hypoxia, if you increase too much hypoxia, you will get into a problem. If you decrease hypoxia, then you get into a problem. So as for example, you generally think that hypoxia triggers only formation of endothelial cells. That's not true. Hypoxia can induce formation of various different tissue types from the mesenchymal stem cells. So the directed differentiation that we do in vitro is way different from directed differentiation that can happen in the body. And so and also the type of angiogenesis is also very complex. Like, for example, generally people know about sprouting angiogenesis, but there is a huge number of non-sprouting angiogenesis, many of which take place in these in this local milieu. So here are just a few examples. I'm not getting to go into the detail, but we must remember that in case of psoriasis, it is more of non-branching, lengthening type angiogenesis, whereas in case of rheumatoid arthritis, more of a branching type angiogenesis. And also when we say angiogenesis, we are talking about formation of blood vessel from pre-existing blood vessel. But during development, there is something called vasculogenesis, whereas in adulthood, we have another thing called vascular remodeling. And so many times we are just talking about angiogenesis, but what is actually going on includes vascular remodeling as well, where there is a pruning of some vessels, formation of some vessels parallelly, and also there is a rechanneling of the blood and also rechanneling of the resources to reorganize the whole network. So that is why it's called a vascular vascular remodeling, which involves even thickening, changing the nature from venular to arteriolar to lymphangio. There are many different types it can take. So, and also the interaction that we normally talk about are even more complex than that, because, like, for example, every tissue has this different basement membrane. In the different basement membrane, there are these different separate cryptic epitopes which are exposed. And also there are this kind of different bidirectional.
Can you finish your presentation in 5 minutes, Dr. Mandal?
Yes, I have just a few more minutes left. So just one example I've shown here is VEGF. There is a whole long list which I'm not going to go into. For example, VEGF has a long list of different isoforms, and just VEGF-A has this many isoforms, and B, C, D, E, they also have other isoforms, and they might have alternately spliced B isoform, little b, which is like each of those big A has these different lengths, and each of them can have a B isoform, and then they can also have a translational read through long forms which are inhibitory. And also out of the two main receptors, the first one is inhibitory, second one is activating. And also there are these so many co-receptors. For example, neuropilins are a receptor classically known for semaphore.
Yes. Can you conclude your talk, please?
Yes. So this is my...
We're running short of time.
Okay. Okay, so here are some experiments that are done, which are interesting for nerve and angiogenesis interaction. And so here I'll just show one glimpse of one of my work, one of the gene therapy cases where there was a rheumatoid arthritis lady, 36-year-old, and she had this gene therapy drug, and it caused her to die, and she was being treated for rheumatoid arthritis, and it was published in New England Journal of Medicine. And also, so nowadays I do more of apheresis, which is my clinical role. And so I collect a lot of stems. I have collected a lot of stem cells in the US in several different scenarios. But these interplays with the angiogenesis work that I've been doing earlier. And so I'm thankful to the organizers for giving me this opportunity, and I'm happy to discuss later. This is a very interesting topic. Thank you all.
Thank you very much, Dr. Saptarshi, for your energetic presentation. We are running short of time, so maybe might not have time for questions, and we'll move on to the next speaker. The next speaker is Professor Amit Denda, Emeritus Scientist, ICMR, and HOD, AIMS, New Delhi. He is going to speak on application of nanotechnology in regenerative medicine. A wonderful, interesting topic, and we look forward to hearing him. Professor Denda, please.
Yeah, thank you very much. Hope I'm audible to the audience. Yeah. So thank you very much, the organizer, for giving me the opportunity to just introduce. This is a vast area. So what I thought that I will just present some of these work very quickly in just 10 minutes. And so that give you an idea of a interesting material which we are now producing in our lab, and Dr. Vijaya, which is a DST woman scientist working in this topic. So I'm just sharing my screen, and yeah, hope it is visible. So what I'll talk in just 10 minutes is about the elastin-like polypeptide, or ELP. Now this elastin, all you know, it's a very, very important extracellular matrix protein. Now it is possible that we can put this human elastin expressing gene into the E. coli and then express it and produce it in vitro. The advantage of this is that these elastin-like polypeptides are temperature sensitive biopolymer. So if you change the temperature That means in the cool condition, it is soluble, but the moment you increase the temperature, it precipitates out. So that is a huge advantage that you can thermally responsive polymer you can make, you can alter the substitution of this amino acid and engineer this expressing gene so that you can develop different kind of polypeptide, elastin-like polypeptide. So in one hand, it has got a human component, so it is not antigenic. And on the other hand, you can engineer it very nicely to create an array of elastin-like polypeptides, which you can use for different kind of tissue regeneration. In fact, I'll show you that we are using it lot many other conditions in the nanoform, in its macro form for scaffold formation and all. Now, this is the scheme very quickly, as I told you. Basically, this human elastin gene, you can, through the genetic engineering mode, you can express and upload it in the E. coli model, and then you can extract this protein very easily, and you can use it for a large number of conditions. So basically, these are the different kind of areas this human elastic-like protein or ELPs are used. In fact, as a drug delivery also it is used, and obviously as a scaffold and tissue engineering also it can be used. Now these are the different areas the people are working with: the ELP, the gene delivery, even the respiratory disease remodeling also it has been used, for cancer therapy also it is used, ocular disease, and our the current interest is also regenerative medicine, but we are also working with the cancer and gene delivery areas. Now, Dr. Ashutosh Chilkoti, I think some of you may be knowing, he is one of the pioneer in this area of human elastic-like polypeptide. And then after that, there are a lot many good papers have come. In last year, I think about 2 months ago, in Advanced Wound Care, we have published a very good review article. I think those of you interested, you can look into this article. And in 10 minutes, I'll not be able to present whatever you have written in that article, but you can go through it and you can get a very good idea of this emerging area of human elastic-like polypeptide. Now, so basically, it can be used for different purpose in the nanoform also. So in ELP, we have got the interferon gamma, the gene component substitution, and we have produced a fusion protein of IFN ELP, and I'm not going to the detail. And then similarly, the other substitution gene can be done, and you can produce even the KRAS mutant specific the component embedded in the human elastic-like protein. You can actually combine with the other the drug and biomolecule also for different kind of use. And this has been nicely compatible, and with the different kind of cellular systems we have worked and shown that as such it is a very biocompatible system, and at the same time you can use for a different purpose. And there are for the cancer area there are a lot of work which is already done and published, and the tissue engineering area work now we are doing. The advantage of this that this component of this human elastic-like protein you can alter to make it in different kind of aggregate form and for your particular type of use. I'm not going to the details of all those. And so the basically effects of molecular and structural conformation of this multivalent elastic-like polypeptide, it can have a different kind of issue for the tumor accumulation if you want to do it is a nano and targeting, but also you can tissue-specific biodistribution you can make of these polypeptides. So basically, even if we go back to these regenerative medicine and wound healing, it can be used as a part of the extracellular matrix protein. You can express a lot of these RGD, the moieties on the top of it, and the G protein coupled receptor proteins, and different kind of the alteration you can do with this protein so that you can actually help in differentiation and as well as maturation of different kind of stem cell depending upon your requirement. So that's why and in fact some of this work we have done in the wound healing area also. and shown it is showing excellent result on that, and we are trying to develop in a more of a product oriented human elastic line polypeptide application. And as I told you, you can express RGD laminin and RGD laminin complex, and obviously there are a lot of scope in this area. So I think in 10 minutes I'm just concluding. It's a very interesting thermally responsive ELP, which you can form in the nanoform and form a nanoparticle, and which you can use for the drug targeting, but at the same time as a matrix form also you can use for extensive tissue engineering. It's excellent biomaterial, and a various kind of modification is possible. So this platform has got a huge potential to expand. Thank you very much for your kind attention.
Thank you very much, Professor Dinda, for an excellent coverage. And most importantly, I think is the you manage time so well and coverage so well. So if there are any questions from the audience, please can go ahead. Please.
Sir, good morning, sir.
Yeah.
It's a very excellent presentation, sir. Sir, actually, I want to know whether, all the experiment which has been discussed, it's on preclinical only. Do we have the material clinically?
Yeah, so basically, yes, I think what we are trying to do now we have completed, particularly the wound healing and the regenerative area. We are completing our animal studies, safety and quality issues, and I think the clinical trial will start in the near future, because as I have shown you that it can be done in a different format. And but then each of these formats need the quality and safety issues cleared. But as it is a human elastic like protein, we have seen already there is no immunogenicity, any other toxicity. But human clinical trial, I think, has to be done. So we are moving for that.
Oh, okay, sir. Thank you, sir. Thank you very much, sir. Thank you, sir.
Thank you. Thank you.
Yeah. The next session is role of stem cells in biological sciences. We invite our speaker, Dr. Pavan Agarwal, Vice Chancellor, OUAT Bhubaneswar, Odisha. He is available online. Now he will be delivering his online speech. Welcome, sir.
Thank you very much. Thank the organizer, chair, co-chair, participants, and I am thankful to Dr. Alok Agrawal, organizing secretary, for inviting me. Can I upload my slide, share my screen? The other screen is still on. It is not taking. Am I audible?
Professor Dinda, can you stop sharing your slide? Thank you. Please continue, sir.
Yeah. It is not taking out.
Sir, Professor Dinda is still sharing his slide. Professor Dinda, can you please stop sharing the slide, please? Yeah, thank you. Thank you. Yes. Okay.
Thank you so much again. The chair, co-chair, organizer, Dr. Alok Agrawal, the organizing secretary, and all the participants. Today I thought of making a presentation related to overall stem cell versus biological sciences. I hope that makes a sense to overall participants. When we talk, I've divided my presentation to these 5 subjects. What briefly we mean the stem cell, history, what are the importance and for research point of view and therapy point of view, also issues and prospects. When we talk of stem cell, they are undifferentiated or blank cells. That means they are capable of developing into cells that serve numerous functions in different parts of the body. Most cells in the body are differentiated cells, serve specific purpose in a particular organ. All humans start out as only one cell called zygote that eventually differentiates into different functions. That means stem cells have the ability to divide and make an indefinite number of copies of themselves, that is stem cell to stem cell, or they can replicate a limited number of times before they break down. In biological sciences, that somatic cell also can give offspring, and somatic cell also can behave like a stem cell. So that is one interesting area for research point of view. If you see the stem cell therapy, animals and medical sciences, mid-1960s onwards, there are a lot of publications, there are a lot of information are available. Transplant of hematopoietic stem cells for treatment of cancer have been done for years. They are accepted as good initial predictors of what occurs in human being. That means working stem cell is a good indication. And a Nobel Prize in 2012 for stem cell therapy was an appreciation for the importance of stem cell for research and therapy. Here I'll bring plant science a little bit. Knowingly I'm bringing, because in the evolution, the micro plants, amphibians, animals or vertebrates, this trait of capability of giving these similar kind of cells or as cells going to a whole organism has some commonality and some evolutionary conditions that make difficult to create a condition. So when you see the animals, a fertilized oocytes give either pluripotent cells or multipotent cells. Both have application as stem cell therapy or stem cell research. When I come to research, very few points I have highlighted. One of the interesting things to understand is how the stem cell turn to other type of cells. If we understand, then manipulating them and making their application for clinical point of view will be very, very useful and very, very easy also. How the undifferentiated stem cells turn into differentiated stem cells that form specific tissues or organs, and how to control the process. If you understand that, then definitely in the treatment point of view or in other manipulative processes, it will be easy. Then we have to develop the method to manipulate the stem cell processes so that we can create a particular cell, either in vitro or in vivo, and or whatever the conditions we can add to that. I'm giving one example. I'm bringing some experience of plant science before I come to animals and of course clinical therapy. As you are aware, as early as 1898, plant cell is totipotent and you can get an organ or get a whole plant. It was established. As early as 1934, the cell of a plant can be proliferate and can go to organogenesis. It was almost established, and publications and successful regeneration of tissues were established as early as 1959. You can get a protoplast. That means plant cell has a cell wall, unlike animal cells. You take the cell wall and get a protoplast that is as good as animal cell or human cell, and you can convert to a whole organism, whole plant. Proliferation was established in 1960s, and whole plant you can get in. That was first publication came around in 1986, 85, like that. So I'm knowingly giving one this example. The left side upper photograph, it is a basically undifferentiated cell mass. You can compare with a cancer cell, and you can create a cell line, and then you can differentiate it to a whole plant. You can say the cell division, 2-stage, 4-stage, and then callus. That is a kind of de-differentiation stage to redifferentiation stage, and get a whole plant. So my point is understanding from all the organisms will give a insight what factors can be manipulated to what level, and there is a lot of commonality between the system that can be useful. As far as therapy is concerned, this is an august audience. I need not talk a lot, but I'm giving a brief only that pluripotent stem cells are known to use for therapy for diabetic cases by creation of insulin producing cells with animals with acute spinal cord injury for Parkinson's disease or muscular dystrophy or heart failure. A lot of animal studies have been proven to be purposeful or useful. Similarly, multipotent stem cells have been treated for bone marrow, treatment of leukemia, myeloma, or lymphoma. They are also proven to have the ability to form whole joints in mouse model particularly, and bone marrow derived stem cells are in clinical trials for remedy of heart ailments. If I give you some example, it is just for the sake of example I'm giving. It can be a big list. There are a lot of successful report of isolation and manipulation of stem cell in animal models. In human being, of course, I gave some example. Particular transplant of hematopoietic stem cells for cancer treatment is known. At least there are 80 approved disorders like leukemia, thalassemia, aplastic anemia, sickle cell anemia. I've listed few more like traumatic spinal cord injury or burns, rheumatic arthritis, heart disease, Parkinson's disease, like that. So there are a lot of potential area where some level of success is already reported. This I'm giving an example of animal science where high density platelet-rich plasma concentrate to be used to treat the open wound in horse particular. This is the example. But two more concerns I thought I'll bring to your notice. One is some of the issues. And one of the issue, I hope you all appreciate that it has a lot of potential, but stem cells still are imperfect to a great extent, but they are accepted in the scientific community as good initial predictor of what occurs in human being. That means it has potential, but it should not be hyped. That means in stem cells, suppose you do a research, there is a possibility you can extrapolate the observation to be useful as adult animals or human beings. But along with that, also there has to be a lot of carefulness that stem cells have been overhyped by the media in regard of their readiness. Sometimes the claim also is too high. That is why we need to be realistic. Stem cell tourism has become a lucrative yet unethical business worldwide. So we have to be very careful how much to claim and how much to treat. And I'm giving one example of an American amendment particularly that is called Dickey-Wicker Amendment that prohibits in USA at least that federal funding should not be due for embryos that are destroyed or discarded. But if you see Chinese experience of last 15 years, they do a lot of research, they manipulate and their law allows it. There are a lot of countries which are very soft use of stem cells and manipulating stem cells. Some countries are very strict. So there has to be a commonality, there has to be a understanding and somewhere we have to come as a common platform. Some prospect stem cell research has a potential to have a significant impact on human life. Controversy around the development, uses and destruction of human embryos is a concern, but also it is a prospect that a lot of countries have already allowed and a lot of countries have a some way between the Chinese and American laws in between they are there. So there is a lot of prospect that Indian laws allow, if I understand. Then possibility of adult stem cells into pluripotent stem cells. There is a lot of potential. And once we are able to convert adult stem cells or a somatic cells to a stem cell that can replicate to themselves as a stem cell, or they can convert to other kind of cells, that will be a great scientific achievement. And I'm sure, I know a lot of research is going on in this direction also. There's a lot of prospect. A lot more to be done before it's successfully treatment through stem cell therapy. Understanding causes of genetic defect in cells, how the diseases occur and why certain cells develop into cancer cells. It is a very big area of research. We know some, we don't know many, and we have to know a lot. So I'm sure this area of genetic defect versus stem cell therapy, a lot of basic understanding will be required, and there's a lot of prospect. I'm sure coming decades will be more for understanding than therapy, and better we understand the therapy part will be better. With this, I thank you very much, and I thank you a lot. I'm sure I'm within probably 10 minutes of the time, my time. Thank you so much.
Thank you, sir. Thank you very much. It's a very interesting as well as overview of the stem cell in biological sciences. Is very much interesting also. Like the last aspect of your slide regarding the issues and challenges, it's really important. So, like.
I'll call upon our next speaker.
Okay, thank you. Thank you very much.
Thank you, sir. I'll call upon next speaker, Dr. Professor Satindra Fuljale, sir. He's a HOD of Orthopaedics at Pandit JNM Medical College, Raipur. He'll be delivering his talk on the very interesting and emerging topic of PRP for management of non-healing ulcers. Please welcome on stage, sir.
Good morning, everybody. Respected chairpersons, Senior Director, Dr. Professor Nagarkar, sir, Director AIMS, senior faculties, and dear colleagues. First of all, I am thankful to the organizing committee of this prestigious International Stem Cell Conference in AIMS Raipur, particularly to Dr. Alok Agarwal, organizing secretary, Dr. Vikramkar, Dr. Harshal, and their team, and the other senior professors from AIMS and dear colleagues, to give me the opportunity to share and discuss my experience in PRP in non-healing wounds or ulcer. So to start, this is the photograph of our medical college. Introduction. Non-healing ulcers are the major health problem worldwide and have a great impact at personal, professional, and social level, with a high cost in terms of the human and material resources. Chronic ulcers or the non-healing ulcers are defined as a spontaneous or the traumatic lesions, typically in lower extremities that are unresponsive to the initial therapy or that persist despite the appropriate care and do not persist towards the healing. There is a chronicity in that particular wound, and the use of the regenerative therapy such as the PRP application is becoming more promising as it is a low invasive procedure and have a potential to stimulate and accelerate the wound healing. So PRP, from yesterday we are discussing the stem cell and the plasma rich platelets. Platelet is plasma. Plasma suspension to obtain from the whole blood. It contains a platelet concentration higher than the normally found in the circulating blood. Platelets play a major role in the process of the hemostasis and later wound healing in any wound. Wound healing carry out with the help of the various growth factors derived from the platelet granules. That's the physiomechanics, the platelet growth factor, platelet drive growth factor, and the transforming growth factor, vascular and endothelial growth factor. Various growth factors are there, and the cytokinins which helps in the angiogenesis and healing. So we are the PRP equipments, test tubes, and the centrifugal machine. We have to do a speedy. And activation can be activated exhaustively by the thrombin calcium chloride mechanical trauma. Collagen is a natural activator of the PRP, so it does not need to be activated when used in the soft tissue. After activation, secretion of the growth factor begins within 10 minutes. This is the various step how the PRP forms the regeneration and the growth factors. And this is the stages of the wound healing. The number one is the injuries, and then there is the inflammatory process occur. There is a proliferation of the cells, and epithelialization, and then the remodeling of this. These are the diagrams showing the wound healing, first the hemostasis, then inflammation, proliferation, and the remodeling. These are all diagrams. Here is the initial injury, and then inflammation process, proliferation, and the remodeling. So, PRP preparation, most of the institutes are aware of this, how to prepare the PRP. 30 ml of the patient's blood without withdrawal. Blood draw occurs in addition to the anticoagulants such as the heparin to prevent the prior activation. In two-step process, whole blood is first centrifuged at the rate of the 3,500 RPM for 10 minutes to separate the plasma from the packed RBC and the supernatant. This supernatant plasma is again centrifuged to separate the PRP from the platelet plasma. So this is the diagrammatic representation from the whole blood. This is the supernatant we again has to centrifuge in, and this particularly yellow portion is this. PRP application, wound is debride to remove any necrotic tissue and thoroughly clean with the betadine solution. Based on the wound size and the area, 3 to 4 ml of the PRP was injected subcutaneously inside and around the periphery of the wound. These are the certain photographs, clinical photograph. This first initial, the size of the wound, that it's showing nice granulation and healing, and there is a complete heal. Another wound of the grade 2 healing, and there is a complete healing. These certain in the orthopedic fractures, the compound fractures, we had to stabilize the fracture by the application of the external fixator, but the healing of the wound is the major problem. In then we use the PRP. It's showing the reduction in the size of the wound, and there is the healing of the wound. Another photograph, complete healing of the wound here. This is some type of the non-healing ulcer, fungating mass after application of the PRP is growing, healing. There are certain studies which supports this. A study, Indian study, Manish Sutar and Sanjay Gupta from the 40s, Gurgaon, Delhi, published in the Journal of Biomedical Science 2017, they conclude that the PRP is a safe and effective treatment modalities for the chronic non-healing ulcer. Using PRP to treat the chronic wounds may not only enhances the healing but also prevent the lower extremity amputation. Most of the non-healing ulcer in the lower extremities are one of the cause for amputation of the lower limb, below knee or above knee. So with this PRP newer concept, we can prevent the lower extremity amputation. Another study from the Madrid, Spain, they conclude that by the Elena Conmetrio, conclude that PRP is widely used throughout the diverse field of the medicine and improving the tissue regeneration. So there are the various studies are there. One of the study, another study from the Spain. Again, Indian study is a platelet-rich plasma is a treatment of the chronic non-healing ulcer. A study of the 10 cases by the Nikita S. Deshmukh from the Pune, Maharashtra. They conclude that the PRP fastened the healing process of the chronic non-healing ulcer. Being autologous, it has rare chances of the hypersensitive reaction. So various studies are there. And the discussion. PRP is a cost-effective, less time-consuming, also against the infected flap wound, and overall improves the prognosis and the decreased morbidities and OPD and the ward procedure. It could be simply prepared automatically within a short time using a centrifugation machine. Conclusion, results have shown that the PRP is a safe and effective treatment modalities for the chronic ulcer. Using PRP to treat the chronic wounds, ulcer may not only enhances the healing, but also prevent the local extremity from the amputation caused by the non-healing wounds. Thank you.
Thank you, sir, for a very nice presentation. Sir, actually, I had one question, personal one at that. Yesterday also we spoke about use of PRP in chronic ulcers and all. Sir, do you apply the PRP immediately after debridement at the first sitting, or do you wait for, like yesterday it was discussed, the inflammatory phase to settle down, and then on the fourth day, when the proliferative phase starts, at that time better to apply the PRP? So what do you do, sir? And what is
it depends about the size of the wound. If the size of the wound is small, then we can inject in the periphery or direct over the wound. But if it is a larger size of the wound, particularly in orthopedic injuries, lower extremity, then we have to do a repeated injection of that.
Okay, sir.
Sir, one more question, sir. Sir, one more question, sir. Sir, what is the acceptance rate actually?
Dr. Prokul, just a minute. So using PRP for wounds, so it has been tried, and just following the debridements one should do to start injecting into the periphery 3 to 4 ml. And it has been found that it is effective for 3 to 4 days. So basically you are supposed to do it every 4 days. The problem comes that the patient is having a large wound, but he is also anemic, hypoproteinemic. His platelets are less. So how to get his sample? But otherwise, if you do it every 4th day, then the paper yesterday, which was presented by Dr. Sandeep Srivastava, and who has published a book on it, they have mentioned every 4 days you have to call the patient and inject 3 to 4 ml. That will lead to the earliest wound healing. Thank you.
Can I ask one more question?
Sir,
just 2 minutes. In case of PRP, when we all are talking about application in wound, I have a few very demographic questions, which probably should be eye-opener when we are using specific biological products. When we talk of a biological product like PRP being used in a morbid patients of diabetic, and any patient who is morbid, carrying morbidity in the form of either metabolic disorder, autoimmune disorder, or any
diabetes, all that.
Any disease. Remember, the wound is not healing because the platelets are not good. They don't have that kind of profile of secretome what is required. That is the reason the wound is not healing. The entire epithelial growth is not getting, entire vascularity is not getting, the entire angiogenesis is not taking place, depletion is not taking place. It relates to the basic mechanism of the platelet, which is failing there. One. Second part, we should also understand when you are applying this kind of studies, a very important part, what is a physiological dose of platelet in your body and what is a pharmacological dose of body. If we don't differentiate these two parts, whatever you do, we may claim the wound is healing in 10 days, 15 days, 20 days. But remember, if there is a design protocol which considers morbid condition, age and size of the wound, and the particularly the number of cells what we are going to use, then we can definitely come to conclusion, because the platelets, we don't know how many platelets getting lysed there to release the growth factors. Whether the platelets do have that number of alpha beta factors to release that number of VGF, PDGF, EGF, basic FGF, we really don't know. So I would rather request all the participants here, go to some basics to standardize this instead of claiming directly. If we standardize this, we can have a better results, very good quality. And second part of my advice is, when we talk of platelet, in case of any infective diseases like malaria, like dengue, we always transfuse them without having blood group match. That is, they don't carry monoimmunogenicity. But we always prefer to have a single donor so that in future they may not have antibodies. If you can design a model where the immunogenicity in platelet is in the platelet wall, not in the granules, alpha and beta granules. Those are the pure protein particles which carry all the cytokine, chemokine, exosomes and all those. They don't present with any kind of immunogenicity. If you can lyse the wall, remove the remaining immunogenicity in the platelets and use those growth factor in the form of what we call lyophilized. Then we can grade the doses, grade the count, particularly we can control the sterility also, and standardize also, source also, everything. This would just suggestion when we talk of a platelet. If you want to have a more scientific approach, spinning is not only the method by which you should do use, because there are counts which are going to change, morbid conditions going to change, and remember, any living molecule, cell molecule, changes with the environment, changes with the handling, changes with the water content, temperature, everything. So we need to find out how do we standardize these procedures. Thank you.
Thank you.
Thank you very much, sir, for your important, valuable comments. And with this, we are coming to the end of the session. And with your presence, sir, because you are physically present, we can still have the discussion can go on even afterwards. And thank you for it.
Thank you.
Thanks for the this opportunity for us to be here. Thank you very much.
Very much.
I would like to request Professor Alok Agrawal, sir, to kindly present memento to our chairpersons. Dear friends, I have a very important information to share with you. Just now, we'll all go down in front of the auditorium and have a group photograph for the conference. So I request all of you to come there for the photograph. And just after the photograph, we'll start with the next session. Our chief guest, Dr. B. Shiv Shankar, will be leaving back after this photograph. So I request you all to please come at the starting. Thank you.
I like to request Professor Dr. Nitin M. Nagarkar, sir, our director, sir, Professor S.P. Dhaneria, sir, our dean, sir, Dr. Mahesh Sinha, sir, to kindly chair the next session.
So thank you very much. We will be starting our session number 7. We'll be starting the session number 7 now. And with me, I have Professor Dhaneria, our Dean. I have Dr. Mahesh Sinha, very senior and learned person in the Department of Anesthesia and has been a doyen in the IME for Chhattisgarh. So welcome everybody again. And the next talk is by Dr. Pradeep Mahajan from Mumbai. Again, a very active person in this field. And he will be speaking on the role of regenerative science in cerebral palsy. So I think we'll just... move on to the...
I invite Dr. Vandita, Assistant Professor in the Department of Pathology, All India Institute of Medical Sciences, Raipur, to speak on stem cells in neuropathology. Dr. Vandita, please.
A very good afternoon to my seniors, colleagues, as well as students. I am here to give a very short introduction to stem cells and neuropathology, my area of interest. So the objectives of my lecture are going to be to enumerate what are the neural or glial stem cells in normal brain, what's the scope of stem cells in neuropathology, what's the difference between neural stem cells versus glioma stem cells or tumor stem cells, specific reference to stem cells in glioma genesis, any diagnostic, prognostic, or predictive markers associated with stem cells that can be targeted, and therapeutics in the pipeline. So there are niches or special areas in the brain which have the neural or glial stem cells. The function of the glial or neural stem cells is to maintain the general stem cell numbers, become progenitor cells which migrate to different areas in the brain and maintain cell populations there. And also they have a role in neuroprotection, which is very important after injuries. Now, where are these neural or glial stem cells in the normal brain? Neural stem cells can be found in several locations in the adult brain, including the subventricular zone, dentate gyrus, and the subcortical white matter. However, the most important area is the subventricular zone, and that is because the stem cells there have been reported to be associated with gliomagenesis. What's the scope of stem cells in neurological diseases? Neurological diseases can include degenerative diseases, multiple sclerosis, which is an autoimmune disease, and also injury-related diseases. But all of these diseases are not biopsied, and the only way we look for the stem cells are at the time of autopsy. Therefore, there is not much neuropathological role in those conditions. Whereas brain tumors are commonly biopsied, histologically classified, molecularly defined, and prognostic and predictive role of stem cells are known in brain tumors. What is the difference of a neural stem cell from a cancer or glioma stem cell? A cancer stem cell is just a normal stem cell that has oncogenic potential in the host. It can lead to a heterogeneous population of cells that comprise the tumor mass. Now, the glioma stem cells, like all other cancer stem cells, have the functional characteristics of being able to self-renew, cause proliferation, initiate tumors, and also are present in significant amounts in a tumor to express cell markers which can be identified, and they can differentiate into different cell populations within a tumor. In addition, glioma stem cells in the brain have the ability to basically cause invasion or spread of the tumor, have immune evasion, that is, they evade the immune surveillance of the body. They also give rise to interaction with tumor microenvironment, which includes development of new blood vessels and some growth factors. So what is the role of stem cells in gliomagenesis? Basically, stem cells in gliomagenesis, that is brain tumor genesis, is basically origin of brain tumor propagating cells from the glioma stem cell. Where are these stem cells present? They are present in the subventricular zone. The subventricular zone, just underneath the ependymal cells which underline the ventricles, are your neural stem cells. Whenever there is a mutation in these stem cells, they propagate and migrate away from the zone to different areas in the brain where they give rise to tumor formation. What are the common gliomas in the brain? The common gliomas in the brain are astrocytomas, oligodendroglioma, and the highest grade tumor, which is a glioblastoma multiforme. As you can see from the survival curve or progression-free survival, glioblastomas have a very low overall survival, only up to 12 to 15 months, despite advances in surgery, radiation therapy, and very expensive chemotherapy that includes temozolomide. Despite all of this treatment, these tumors are marred by therapeutic resistance and recurrence. So there is a need to research molecular biology of these tumors, including the role of stem cells in these tumors, so that it can be targeted and these tumors can be treated better. What are these glioma stem cells? They are a subpopulation which are identified within glioblastoma, a brain tumor. Compared to neural stem cells, glial stem cells exhibit enhanced self-renewal and compromised differentiation. They have a key role in resistance to conventional therapies as well as recurrent disease. In glioblastomas, these stem cells express unique surface markers which can help in identification of these cells as well as target these cells. They also modulate signaling pathways which promote tumorigenesis, and they cause vascular formation and changes in the tumor microenvironment. Therefore, these are very, very relevant targets for directing therapy against in glioblastoma multiformes. What are the important cell signaling pathways which are seen in glioma stem cells? The important cell signaling pathways are the Notch pathway, the sonic hedgehog pathway, and the Wnt pathway, which are essential for preserving multipotency of the stem cell and for creating the self-renewal or maintaining the stem cell of the glioma stem cell. Glioma stem cells upregulate a lot of these pathways, and it may differ in different tumors, and they are required for maintaining these stem cell populations within tumors. So how do we target these tumors? How do we target these stem cells in glioblastomas? We can target them by targeting their cell surface markers, by targeting the signaling pathways, or by targeting the interaction of these stem cells with tumor microenvironment so that they are not able to sustain. So the real challenge in glioblastomas are that these tumors are radio-resistant and chemo-resistant, and they are always marred by recurrences. And it is hypothesized that this is because of increased population of glioma stem cells within these tumors. There are different mechanisms by which these cells remain in the tumor, and all of these mechanisms are opportunities for therapeutic intervention on glioma stem cells in these tumors. So we have to target the stem in order to treat gliomas. What are the therapeutic strategies to target these stem cells within glioblastomas? As you can see from this figure, there are three important things that we target. One is the cell surface markers on these stem cells, signaling pathways which help in proliferation of these cells, and the microenvironment and the interaction of these stem cells with microenvironment that helps it stay. What happens as a result of targeting of these markers? As a result of targeting of these markers, there is induction of apoptosis in the tumor cell, differentiation, autophagy, and also these markers can serve as a starting point for making vaccines against these tumors and also epigenetic drugs. So the therapeutic targets, if I repeat again, would be to target the cell surface markers, signaling pathways, interaction of these cells with tumor microenvironment. What's the role of neuropathology in all this? What we do is we have different tests like immunohistochemistry, flow cytometry, or PCR, by which we can identify as well as quantitate these targets within a stem cell population in a tumor. What are the targeted therapies? The first is therapeutic targeting by surface markers. The important surface markers of glioma stem cells are CD133, EGFR variant 3, and L1-CAM. These markers are amongst a big list of markers, but the importance of these markers are that there are specific drugs which are available which can target these markers and therefore give rise to better response to treatment. What are the signaling pathways which can be targeted? We have the Notch, sonic hedgehog, Wnt, BEGF, STAT3, and BMP. Again, we have targeted therapies which can block these signaling pathways. How do we target the interaction of the stem cell with the tumor microenvironment? There are a lot of things in the tumor microenvironment, like other tumor cells, neurons, macrophages, T cells, and vasculature. And all of these need to be targeted in order to dry out the glioma stem cells. So microenvironment is essential for maintaining the glioma stem cell stemness. And this microenvironment, the most important components are microvasculature and macrophages. What are the important markers for the microenvironment in a tumor? The important markers are markers as in the things that we identify in our biopsies or that can be measured in blood. So the important markers are VEGF and periostin. There are drugs which can target these markers depending on their levels expressed. Therefore, we can target the interaction between the glioma stem cell and the microenvironment, and that can represent an alternate approach in glioblastoma therapy. To summarize the therapeutic strategies, there are various avenues for targeting glioma stem cells in glioblastomas, which can selectively poison epigenetic, metabolic, microenvironmental, post-transcriptional, and immune interactions of these tumors. There are already a whole list of diagnostic markers via immunohistochemistry that we do on our tumors. But all of these markers are only diagnostic. They are not very reliable as to the predictive value. That is, response to treatment. Similarly, there are several markers which are associated with glioma stem cells, but not all are important. The very important markers are nestin and CD133. And these are markers which are very easily identified on immunohistochemistry performed on these brain tumors. So the markers of glioma stem cells are several, and not all of them are important or viable in the clinic, but nestin and CD133 are reliable and present in the market. So to conclude, glioblastomas are tumors in which there has been very little progress made towards improving patient outcomes and survival despite all the advances in therapy. Understanding the molecular biology involving stem cells in these tumors is needed so that therapy can be tailored towards addressing the root causes. Stem cells in gliomas can be identified and quantified using IHC, flow cytometry, and PCR performed on biopsy material, and directly targeting glioma stem cells and their microenvironment is a promising opportunity to eliminate the likely source of gliomas and the nidus of their recurrence, which is the main problem, mortality and morbidity. Thank you so much.
Thank you, Dr. Vandita, for very lucid discourse on the role of stem cells in neuropathological disorders. Now, this topic is open for discussion. 1 or 2 questions. Any question?
Dr. Vandita, just one query from my side. Any clinical trials have been, because we all know that this is a very lethal tumor, and you rightly mentioned that it's chemo-resistant and radio-resistant. So what has been the progress? Of course, we know that a lot of research is going on, but any clinical applications as yet, any trials going on anywhere, any part of the world?
Yes, in the US, actually, there are 2 trials on vaccines which have been developed against these glioma stem cells in phase 2 and phase 3. So maybe in the next 3 years, there'll be a vaccine against glioblastomas, which are the worst kinds. There are also a lot of trials based on combination drug treatments, which are less cytotoxic because they only target the stem cells and leave the normal brain unaffected. So it's very much there. It's not exotic. And I think in our patients, especially, the overall survival is even less. It's only 3 to 4 months. And there is huge potential for this in treatment in medical practice.
Thank you. Thank you.
Thank you.
Now I invite Dr.
I have a question. When we are talking in glioblastoma, since we know that is one of the dithering and very challenging tumor in the management, using even the cell-based technologies or immunotherapies, various kind of, are you aware of any drug-targeted treatments using MSC for glioblastoma?
Yes, sir. Like I said, they are in trial because the cell signaling pathways which are involved in glioma stem cells are similar to those in neural stem cells. So these pathways are already known. It's only that a couple of mixed drug therapies are needed to target them based on the expression in a particular tumor. So
here, one of the studies says that we could tag the therapeutic chemomolecule to MSCs, and MSCs are having chemotactic action towards the tumor or any healing process where there is inflammation. And tumors are a kind of inflammation, always a kind of inflammation. So almost all targeted chemotherapeutic molecule can be chemotactically targeted to the tumor using MSC tagged with chemotherapeutic molecule, which is a target molecule. This is one of the research which is in pipeline, probably will come as a very good solution in future.
in the COVID era, sir, all of us know about mRNA vaccines. There are a lot of mRNA viral vectors which are already being used in glioblastomas injected locally within the tumor. Like I said, they are in phase 3 and phase 4 trials, in fact, in the US. So it should come in the market in 2 years.
Hey, just one question. As you mentioned, the vaccine can be effective with these patients.
Yes.
And what is the mode of action or how the vaccines will be delivered through virus or some other ways?
They are given locally, intraoperatively.
So is it called vaccine or is it sort of modified chemotherapy?
it's called a vaccine because there are susceptible populations who are more susceptible to these tumors or have low-grade tumors which are molecularly like glioblastomas. So as a preventive or preemptive measure, those vaccines are given in the tumors at the first surgery before recurrence. So it's vaccine to prevent a recurrence or a higher grade tumor. They can't be given to normal people.
That's
They can't be given to
the
normal
vaccine
people.
conventionally is the different
The vaccine is for those who are operated at the first.
So, miss, after the surgery, you inject locally to prevent the recurrence, is it?
At the surgery site, it is injected.
Obviously, after the excision of the muscle,
Yeah.
maybe you do the cryo or immediate histopathology and give the vaccine.
Yeah.
Is it right?
That's
Thank you, Dr. Vandita. Thank you very much.
Now I invite Dr. Pradeep Mahajan from Mumbai to talk on.
Sir, I would like to request our director, sir, to kindly present a memento to Dr. Vandita.
Dr. Pradeep Mahajan from Mumbai to speak on role of regenerative science in cerebral palsy. Dr. Mahajan, please.
At the onset of the conference, let me give special thanks to the organizers, Dr. Nitin and Professor Nitin, who is heading the organization, and active role Alok, which he has taken to bring this conference in existence because of COVID, which was getting delayed. Fortunately, it was supposed to go online, but definitely we have a mixed picture. We have online plus and personal. Institutional academic participation into neuroscience is the vision for new upcoming doctors. And I'm really obliged for having the ages background from the various orthopedic association, Gynec association, AMA for such a conference. The reason is that 10 years before when I started work on regenerative medicine, by telling I'm a neurosurgeon basically, when I started, I had a lot of resistance every angle. Because we were not taught basic research of biology after 12th standard till you master. We knew only a cell, nucleus, cytoplasm, and their organism. But we never thought this biology, once taught in our school, will change our life. So, in case I would say the medicine, the way we practice in future, will be absolutely different what we are doing today. Absolutely different, the way it is going to practice. And this practice will be related to entire biological products. We are replacing by nanomolecules, by genetic therapies, by mutation therapies, by unfolded protein therapies, cell therapies. We talk of the therapy or chaperones, growth factors, a number of things are going to come. In fact, being today here on the podium of AIMS, I would say rather no institution can complete the dream and promise of upcoming medical doctors if they don't include in their curriculum this people. I would request to our honorary dean and as well as the director to look into that. If we give these upcoming doctors the opportunity, probably new generation will be well prepared and very armamentary ready to give you output of the current therapies which we are talking about stem cell. The good news is that when I talk about academic, the good news is that Maharashtra State University of Health Sciences has approved with STEMARX, Government of Maharashtra and India has approved 2 years fellowship, official fellowship for postgraduate MS, MD, MCH, DNB and equivalent foreign graduates just for research purpose to give them the background of research. And I'm very confident from my own experience trust me, a clinician can be a better researcher than the basic researcher, though we need to have basic researchers with us because we know the clinical side of it. Once you know biological side of it, physiological side of it, the molecular level, how to correlate the diseases. If you come for one disease, I assure you, the same molecule can be used for 100 other indications. But this is possible only for a medical doctor, not for basic researchers. So I appeal to all of you to motivate yourself to take this science at a higher level by participating in this. Now we will talk of a complex brain regenerative medicine and brain. We did not take biopsy here together on the brain, so we could not know much of the brain structure, and it remained a bit complex. And orthodox teaching of ours, neurons are same at the time of birth, and they die or they atrophy at the age. We never teach even the having the anastomosis or having the network, which is going to increase with the learning patterns. This also is not taught. This is the orthodox teaching, which we have found out with this smiling face, the child, which is carrying some neurons in the brain and the network that is called a purning of the neurons, which is showing with the genetic effect with the environment outside, the purning effect means new connections developing. Now, if you see, when we want to talk of the topic of cerebral palsy, we have to see an in-look of embryology of the brain. How many of you know when the neuron starts developing in the embryo? Anyone can tell? Neuron is the only cell in the body is differentiated before the mother knows she is pregnant. Before the mother knows she is pregnant. Second component of the body which differentiates is the immune system. Under the influence of immune system, the infertility and brain are so thickly connected. Every cell is monitoring. T cells are monitoring, monocyte derived cells from the bone marrow are monitoring. Then T Rex cells are monitoring. Every level they are monitoring, and they control entire system of differentiation. But we hardly look but we have connection in 1 month. The division goes in millions and millions to achieve 100 billion neurons in the first month itself. This I'll show you. Then comes the migration, differentiation. And these all periods, including migration, we call them the sensitive periods. After the sensitive periods are the periods at what level these changes are taking place in the neuron. Today, I'm going to talk of the mechanism. Why? Because when you target the treatment, if you know the mechanism at molecular level, your outcomes will be fabulous. Today, I can say, if a cerebral palsy patient comes to me, I will assure him 6 months time, he will achieve ADL, activities for daily living. Absolutely, at least he's not dependent on anyone. And this plays a role between gene interaction and the environment. The expression keeps on changing from the child growing. Expression keeps on changing. So good environment gives the gene different way, and bad environment gives the gene different way. Now, this is just to show you what are the areas of the brain which we are focusing in cerebral palsy for the implant. This is called a mapping of the brain. When we do different PET scan or scans or MRIs, we need to focus the area of the brain. Though we know clinically which area could be representing where, but if you have documentary proof, in the repairing system, we can focus on these areas very clearly. Very specific area. So this complex brain doesn't remain complex now. It has solved almost questions now. Now remember, specific neural circuits of the brain remain dynamic with these specific stimulation. That is why we keep child training with different to develop new circuits. And this period of youngness up to 10 years is highly responsive and highly plastic. If you want to look into any kind of therapeutic protocol, when we design, we should know the molecular behavior, cell, what time they are differentiating, what the signals they are getting, how they are differentiating, and what are the external sources. Because I'm going to talk on a sandwich protocol. Sandwich means endogenous and exogenous. In between both of them, we'll try to make them fit. Now, pathways of the brain become established along the more active connections. Active connections means the theory, the environmental teachings, the environmental areas which are present with the child will develop those pathways very thick, and those pathways are long-term pathways. They don't forget. There are short-term pathways also which child forgets over a period of time. This is a formative experience the child develops because of the environment. Entire block based on 4 cells. That is, the neuron has got 4 parts: dendrite, cell body, axon terminally, and giving the most transmitters, which is a basic thing. Without having the components of the neuron supporting cells, the oligodendrocytes, astrocytes, ependymal cells, neuron cannot function. Let me complete. The body is composed of hundreds of cells. Every tissue is composed of hundreds of cells. Ever have you thought brain is so simple organ controlled only by 4 cells? We never think. We think our brain is complex. But remember, it is controlled by only 4 types of cells. How simple brain is there. Once we analyze the entire study, we get to know very simple study. The second part, the functional brain works through the electrical impulses. Get me water. Electrical impulses. When either the environment is not good or the cell is not functioning because of some kind of pollutants or damages or hypoxia thing, the electrical impulse doesn't go complete. If you can see the disease and damage electrical circuit. And the other one, when the environment is good, supporting cells are good, the electricity impulses has to pass absolutely like dynamic. Now, this slide is very important for our therapeutic protocol. Why I tell you? When the brain is developing, remember in the first 1 month, we have abundant of proliferation of neurons to reach the target of 100 billion. Thereafter, the proliferation is very much reduced. I'll show you some scale of sensitive period. Here you can see very well, older neurons migrate towards the surface of the brain. Older neurons migrate towards the surface of the brain, and new developing neurons base towards the cortex base. This concept you should keep in mind before you start the treatment. Older neurons go towards the periphery, and new neurons which are developing, they will remain at the base. Now, this plays a major role when we develop a protocol for treatment, because we are trying to talk of making new neurons. Where do we give the new neurons? How do they develop? Because old neurons are going to migrate towards the surface of the cortex. 4 major neurotransmitters: acetylcholine, dopamine, noradrenaline, serotonin. And this is one slide which shows the proliferation, migration, and the axon synapses, what they are developing towards we become adult. Now, this slide is very important for you when you are developing therapy. Look, at birth, 1 month, 3 months, and 6 months. What does it speak? It speaks the proliferation is completely done 99% at the time of birth. What remains is a connections of the brain. The child from the birth to the 6th month reaches the maximum purning effect. Means it develops all the sensory, motor, learning, synaptic connection. This is a child which can grasp anything permanently if you try to give them that. But at the age of 6 months, why I'm talking this? Because this again comes to the relationship of cerebral palsy treatment. Where and how you can enhance and which child. You can even give the outcome definitive to the child. What outcome I can give to the child? This is also very specific. We can't talk randomly. We can point which are the areas which can function, how much we can function, because we know what is a purning effect. After 7-8 months, 1 year, this purning effect starts going down. The moment it is going down, the new connections to develop by nature is difficult. Then we have to train the child by various therapies, what we do to develop those connections. If we don't want to develop those connections and they are existing connections, and that time you want to start the treatment, this is the ideal period for before 1 year. You can start. I have got 2-3 babies whom treatment I have started at the month of 8 months for cerebral palsy and 14 months. This plays a major role. Now, this is a sensitive period which we have to keep in mind. If you see the line which is showing color green, the proliferation has come down by the time of 1 year. Whereas all 3, synaptic connections, myelination, and developing new connections, they are growing as the baby borns. Baby is born. This is a time, critical time, when we can talk to the parents, convince them what I can do best for the baby. We have to catch the natural cycle of brain. The moment we catch natural cycle of the brain, we can assure the outcome of the child, what we can do. We know the migration of the neurons. We know the area of the neuron. We know the pattern when they are migrating. We know the myelination, what time it is taking place, when the connections are getting down. We know all these things as a molecular level. Then I think Clinicians are the best people who can develop the protocol for this. Now, as a cerebral palsy, I'll just quote out some points, then I'll go on a stem cell directly. Now, 1862, the first case was referred by William, around 2 to 3% is the ratio globally, and played with many factors. This is total is an umbrella, basically is an umbrella cerebral palsy with various presentations. These two briefs I have shown you for a reason. While at the time of natural delivery or at the time of infection, how you should handle the head of the baby. If you handle the head of the baby in a little unhealthy way, undynamic way, it may lead to some kind of damages which subsequently you will not know that moment, but you may feel the baby was normal born. But you forget the baby had a neck bend for a transient 5 seconds, 10 seconds. That time is sufficient for hypoxic damage in the brain at that time, because that is a time where brain is highly dynamic, differentiating, carrying, perspiring, everything for growth. And even 5-second hypoxia is more than sufficient for that. Now, these are antenatal prenatal. I don't want to comment on this. The areas of the brain which represent in the form of cortex, basal, cerebral, multiple areas, and the representation is a mapping like how we represent in the body physical signs and symptoms like quadri, di, mono. And highest number incidence which we find is spastic condition which you find. Rest of them there are. This spastic only because the damage major takes place in the motor area. Major motor areas. This is the classification normally when we grade before the treatment. These two slides for the classification. CP versus normal brain. What are the damages we are expecting? I also make it very clear. When we talk of CP child, you should see the perivascular, intravascular, and cerebral. You will see 4 findings which are commonly seen in palsy child. At the time of birth, intrauterine hemorrhage it may have in the uterine condition also. But these are the findings broadly we should look for and correlate for that. The conventional therapies may fail today because we are targeting only therapy, only extracellular programs, which cannot give us ADL, that is I call actually the activity for daily living, actually are very challenging. Now, when we see, we need to have disruptive technologies. Now, once we have seen the cells in the brain, they are repairing their position. Can we heal or repair? Yes. Whenever you get a cerebral palsy patient or a CVA patient, you can see naturally brain repairs to some extent. Yes, healing potential of the brain is there by nature. Now, why we can use this potential of natural healing of brain using the basic concept of this slide is that I told you, when the single embryo comes on first neuron differentiation takes place, and which goes with every cell differentiation. Till 6th month, the brain is completely developed. 6 months, fully developed with full connections, except myelination, synaptic connections, which are the remaining part, which I have shown in the sensitive period, which we have to target in the treatment of a cerebral palsy. Now, embryonic stem cells do play, as we have been discussing, but they play a long time for therapeutic application, so I will not comment on that. But definitely neurogenesis is there. I think you can see neurogenesis naturally present through this slide. How it works, replacing the old neurons, new neurons are coming up. The areas where our progenitor or neural progenitor cells are like dendrite, subventricular zone, or one more is substration, olfactory area, and subventricular zone. Now, these areas, basically, we need to focus in our entire treatment program, where we call, can we harness this power of stem cell into repair mechanism, which are natural repair? I always teach in my all classes, can we convert all repairing systems of the body into therapy? Simple. Repair system is working with me. Can we convert into therapy? Yes, we can do that very much. These have been already proved in CP in animal models, and these are because their basic qualities, self-renewal and differentiation, multipotency, we consider these two basic characters. Also, umbilical cord. If you see, it shows that experimental models have an animal as achieved successful rate. How it works? At a stem cell today at a level where cerebral palsy, what are the microscopic environment or niche areas, what are doing the changes? One is oligodendrocyte. I said you supporting cell plays a major role for myelination, which we need. We have to support them, myelin sheath development, axon for communication, and neurons. All these are microenvironment, how the cell components are functioning. How do we use these therapies into practice? Now, this is my sandwich protocol, which I'll always in my practice, where endogenous, autologous stem cells, along with various therapies by proper mapping of the brain, we can deliver the cells by two ways. One is exogenous. We take the bone marrow, adipose, or whatever the source we want, isolate them, make a proper concentrate of mononuclear cells with the mixed cell population. If you have technology how to get very small embryonic-like stem cells from the autologous patient, the baby is a child, has got n number of population in the bone marrow, of which one is the best is VSEL cells. These are carrying embryonic marker SOX2 as well as CXCX4, which are very important for taking complete angiogenesis and neurogenesis of the brain. If you have that kind of technology with you, you can isolate mix to the big cell population and then transplant exogenously. This is one part, and various therapies what we use in the form of therapies in the form of electrical stimulations, transcranials, you can use magnetic forces, you can use electricals, you can use oxygen impulses, oxygen carrying molecules, and then the repairing mechanism we'll see taking place because of the both factors. One, with your MSC using neurotropic factors, which you can see there, then also basic macrophage removing the dead particles, and if you see the Schwann cell wall getting repaired with through the all microenvironment repairing system. This is where we can use auto and allo. I'm not going to talk about allogenic today here anymore. I'll only focus on autologous. Allogenic means sources from the cord tissue, then the sources from the amniotic fluid, placenta. You talk about cord blood. They have also a mixed population, like cord blood has got a mixed population, same way that we have bone marrow. So we focus on the bone marrow. Then there are some studies using these kind of combination of cells along with EPO. Now, this is a bone marrow, a standard protocol, probably most of you are doing it. How to harvest, this is the adipose, most of you are doing it. And this is a most important addition to sandwich protocol, which I spoke about endo and exogenous sources. I also speak about the role of cerebral disease, discussion of effective components of umbilical cord and its mechanism. Now we have to see, we just don't want to put the cells, but how it is happening, mechanism, what's the mechanism? If you don't know the mechanism, you just can't put blindly anything inside the body of human being. Now, the role is many controlled trials are happening, randomized trials are happening, which indicate that the components like MSCs, components like endothelial progenitor cells, angiogenic, which are regulatory T cells with immunomodulatory, anti-inflammatory, hematopoietic stem cells. This role in this environment, hematopoietic cells play only niche role. They support the niche as an environment to develop the entire growth of the damaged cells. And monocyte-derived suppressor cells are the cells which are first coming into immune reaction when the neurons are developing in the womb of the mother. They play a major role in entire migration of neurons, differentiation of the neurons, and also connecting them to autonomic nervous system. This particular monocyte will play a major role in this. Now, treatment mechanism, first of all, summarizing few points. One is homing and neuroregeneration. What is homing? Homing, we talk of cells home, but how do they home? Why do they home? Have anyone thought? Why do they go there? See, remember, when we talk of a microenvironment, the homing relates to the cell, extracellular matrix, and various cytokines. The most important signaling pathways which take for the homing responsibility is SDF, stromal derived factor 1, second chemokine, CXC, motif, and CXCR4, and again it will come monocyte, chemotrantin proteins, MPCP3, and cinnamol coenzyme reductase. Hepatocyte growth factor again plays a major role in entire homing, migration, or chemotactic action. These are the major molecules which play. Now, what happens at that level where we want to hope? We have never thought. Cells go and doesn't sit like that there. When we transplant the cell, there is a shear resistance adhesive reaction, following which the cell from the flowing blood, or flowing what we use from the exogenous cells, and the vascular endothelium of the target tissue has an interaction because of integrin beta 1. Integrin beta 1, which gives them cell adhesion, migration, chemotactication to encourage, to anchor around the traumatic area and release their factors. We need to focus on this. How do we improve those factors? Then your migration is more, and anchoring of the cells is more, cytokines are more, growth factors are more, and I actually assure you the results are fabulous when we do these following things. MSCs do work through their chemotactic action, which already I have mentioned you, and these most important instigating factor for MSCs to come into action is hypoxia, which has taken place. Other tropic factors which play more important for the cell are extracellular vesicles, which are included here, and soluble factors, which are coming from the cell component of all the cells you take in the body. You take any cell, you take a stem cell, you take an adult cell, you take an infertility cell, you take a fertile cell, you take a brain cell, any cell. Every cell has its own secretome from adult to embryo. And that particular secretome, which is called as extracellular vesicles in the form of exosome, micro or macro, or otherwise you can call them soluble factors. These play in the different form of role to improve things. Now, tropic extracellular vesicles and soluble vesicles, they are produced how? That also I'll make it clear. Remember, nothing comes out of cell like that. You have jumped and something is coming out. There is a process called as endocytosis, exocytosis. When they take the signal, they take the cell by endocytosis. When they give the signal, they go by exocytosis. And from the cytoplasm, endoplasm. Nuclear, similarly. All mRNAs are released with these kind of mechanisms in the environment where we want to heal these tissues of neurons. Angiogenic factors, which are again VEGF and EPCs. One more important thing I would like to show you here. Of all the cells which I have shown in the microenvironment, EPC are the only cell which don't play a role in immunomodulation. EPC are the only cell in the environment don't play a role in immunomodulation. But rest of all the cells from MSC to progenitor to every cell you take, they have immunomodulation. Not only immunomodulation, neuroprotection. Again, how do we assess that? If you see two indicators, reduce the inflammation of CD34 cells in the brain and reduce microglial activity as the two important parameters on which can study by marker studies. The same thing which I spoke in a big diagram, a big talk, I have just put it in the small diagram. If anybody wants to understand the entire process, how the brain repairs is in small nutshell of it like. The various studies globally happening. Now, as I told you, there are certain studies with different factions. Since I'm going to talk on regenerative, various studies are happening. Intravenous cord blood, matching by doing HLA typing from the donor cell also, haploidentical also, and self also, if it has so. But the activity of the stem cell you can enhance. The result, if you see, if you use erythropoietin with the calculated dosage, I assure you, the results of angiogenesis, then what you can say, myogenesis, particularly methanogenesis, we call it terminology called as methanogenesis. Angiogenesis is for this, neurogenesis for this, methanogenesis. Methanogenesis is the mesenchymal cells giving the lineage into all different lines. So that can be found at a very beautiful way. So rehabilitation are standard protocols which everybody is following. I don't want to talk on this. One or two, this is a good, which is around 13 months old. I told you the earlier the treatment, you can listen to her what the baby was very bad and very was hopeless. Can you see the speaker? This is a 14-month girl. Nobody would have thought of taking this girl because the age is underweight. But underweight, neither the age is contraindication. Yeah. I think speaker is a problem. No. Fine. I'll show this one. Now this boy, I showed it two ends. I specifically wanted to choose two ends. I wanted to show two ends specifically. One, the newborn. Second, going into adolescency. I wanted to make you hear because these were very good cases. They would talk, they were expressing all their desires of their life. Unfortunately, no, I don't think so. No problems. These are various links again with international national patients and hundreds more. These are my various research publications. I got 21 publications in various subjects. My topic of interest is always avian in almost all type of indications, where I have got 50 case reports published in the British Journal. In the British Journal it was produced. Then there's one beautiful case which you have done, a neurogenic bladder, which is a very challenging case. And it was on, again, a PubMed publication. There are 2-3 patents of my own, particularly for avascular necrosis, then ankylosing spondylitis, and dental pulp. Some of these media knows various conditions. And ultimately, I would like to say, there are certain cancer products which we have got with Prodigy. We work it. These are certain recognitions for my work, which I worked out from different levels, national, with the president and with the current minister. Dr. Chandan Sen is a mentor for me. He's a chairman and regenerative medicine professor for Indianapolis. And I was lucky enough to have with Luke Montague, who is a Nobel laureate for HIV. At least 3 days I spent with him. And my training in US, where I did my whole state training in tissue culture complete. This is my team where I used to work. And in conclusion, various important notes. Neurons are plastic. One should know the non-druggable diseases take into druggable diseases. Non-druggable diseases take into druggable diseases. I always call one more thing very important here as a beyond hope. As we constantly strive towards the future, we find technology and scientific breakthroughs move us towards a direction that was never imagined before. Ongoing discovery of stem cell treatment has given a rise to a new alternative treatments and a new to control our lives. Stem cell technology has emerged as one of the most exciting gift field by biology science today. Advances in stem cell science will give us ability to manage our lives so we can live a fuller and healthier life with a new hope. This journey through stem cell treatment is an exciting one as it would enable me to help lives. Thank you, sir.
Thank you, Dr. Mahajan, for the very highly informative talk.
Thank you, sir. And you have extended little time for me live. And you had a patient hearing. Anything questions you can ask me or the lunch, whatever is there. Any questions on regenerative medicine science? Thank you.
Sir, I'm pediatrician here. I'm associate professor. I want to know, sir, the source of the stem cell used for treatment of cerebral palsy. If you have experience, to my knowledge, stem cell therapy in cerebral palsy is still experimental, and I expect or I hope that you may definitely say it is a standard care of treatment in coming time. Like stem cell therapy is a standard care of treatment in aplastic anemia, thalassemia, like this. So hope this may come in future. But the neural precursor cells induce pluripotent stem cell and mesenchymal stromal cells, they where you obtain, they may be the only source where the CNS cell regenerate. Bone marrow cannot be a source because they are lineage committed, and only stromal cells from the bone marrow will help in regenerating, giving a environment, but they can't differentiate into CNS cells. I just want to your comments on this, how we can improve the source, how these cells can be obtained to benefit the cerebral palsy.
Doctor, what's your name?
Yeah, I'm Dr. Sunil.
Dr. Sunil. Dr. Sunil, I think you were not connected during the talk. During the talk, I came across allogenic sources and autologous sources. In autologous sources, in the bone marrow, I clearly mentioned a population of mixed cell. I also mentioned a word which is specifically called it VSEL cells. These cells are of the size of 2 to 4 microns, lesser than the stem cell size. They have a complete full of chromatin with a thin layer, thin cytoplasm, and they represent the markers of embryonic character. I'll explain you. Just remember one theory. After post-chemotherapy, for all of you, after post-chemotherapy, patients go in infertility because of the ovarian cells dying away because of chemotherapy exposure. After 5 to 10 years, if the lifestyle remains good for the patient, I can assure you that lady conceives again back with the ovulation, conceives again back. This is because the bone marrow. Bone marrow is the organ which is constantly signal responsive to the body damages. To stimulate progenitor cells, first of all, I will make you clear. There are 3 layers of cells in our body which work for us. One is a bone marrow, basic structure. Second is organs which carry around the capillary are the pericytes, which they anchor around the capillaries. This also, I'll tell you, this has also changed our complete concept of learning process, which we take in this autonomic nervous system. We say muscles contract, capillary muscles contract for the getting blood pressure to up. No, never this happens. The contraction is because the anchored pericytes, which has an action of contraction of your blood pressure with the autonomic nervous system. So everything is changing. That's what I'm telling you. There are a bone marrow, particularly adipose tissue, is a large 100 times more of MSCs you can get along with pericytes in adipose tissue. Third, in the peripheral circulation, when I told you some of them are doing the therapy with EPO, I specifically mentioned the results are getting very good because they also play the role in bone marrow activation along with GCMF. When they give the messenger cell as well as hemopoietic cell, which are important. Third, fourth, most important, I told you, we have progenitor neural cells basic in the brain, every organ. There's a second layer of cells in the body. Every organ has progenitor cells. Every organ is full of pericytes, a full organ of pericytes. And then the progenitor cells represent on those organs also. So in CP, I told very well, we are working like a sandwich, endogenous as well as exogenous. For your CP patients, I have a source from bone marrow, I have a source from cord blood, I have a source from amniotic. The reason I'll tell you also, MSCs, even if you use, they are immunoevasive. Immunity life in the body, they die within 7 to 8 days because the body rejects them. They don't remain in the body long time, and their role comes in the body only as a drug store. Only as a drug store. During this course, they will reach the target organ and stimulate your progenitor cells to differentiate. Not the new cells, progenitor cells. Got it, your answer?
Thank you, sir.
I think so.
Thank
you very much.
Thank you, sir. Thank you.
I would request our director sir to kindly present a memento to Dr. Pradeep Mahajan.
So continuing further, we now have the next presentation by Dr. Mukund Madhav Oja from AIIMS Raipur, Department of Orthopaedics, and he will be speaking on orthobiologics and answer to the future of orthopedics. Welcome, Dr. Mukund Madhav Oja.
Absolutely.
Very good afternoon to all the seniors, faculty, and senior dignitaries on the dais, my colleagues and my juniors. First of all, very thank you to Professor Alok sir for giving me this opportunity to speak on this topic. And myself, Dr. Mukund, I am senior resident in Department of Orthopaedics, AIIMS Raipur. And today we will be discussing on orthobiologics and answer to the future of orthopedics. So what are orthobiologics? Why we are using them? So simply we are fracturing this word orthobiologics into two words like ortho and biologics. So ortho is alluding to the bones, relating to the bones, joints, muscles, and the ligaments, all the musculoskeletal system. And biologics, these are some substances which are normally determined and that can mend the orthopedic tissues, which causes the speedy healing of these ortho treatments in ortho treatments. So orthobiologics are basically substances belonging to the three categories. That is one is the matrix, which is also called as the scaffold, and the growth factors and the cells. Cells can be any cells, like mostly using mesenchymal cells, stromal cells, which are using. Coming to the matrix based, these are the allograft based substitutes. These can be a demineralized bone matrix that is used mainly in non-union, delayed union, and expanding phase of the aneurysmal bone cysts. It can be available in gel form and putty form and powder and granule form. And it's available mostly in USA as well as Grafton in brand name. Ceramic based matrix, these are the stimulants which we use in our department also. These are calcium sulfate based. And others similar to these are chronos, which are mainly a beta tricalcium phosphate. These are actually the bone void fillers, which are mainly used in non-unions as well as carriers to carry the antibiotics. And the third is the collagen based. So these are some photographs. This is on the left corner at the top, which we use in our department regularly, is a stimulant. It is a calcium sulfate, and it is mainly used as a delivery system for the antibiotics in mostly in the cases of infections. When we get an infection, post-operative or periprosthetic infection, we use it as a stimulant and as a carrier for the antibiotics. Other are the demineralized bone matrix. These are the Grafton as well as available. And one is the Chronos. Chronos is available in various forms. It can be cylindrical, it can be square, it can be a wedge-shaped, and mainly used in spine surgeries as well as other surgeries. So it is like a scaffold over which a bone can grow and helps in the non-union as well as in various osteotomies. So some are the factor based. These are the mostly the factors which we are getting. It can be a PRP. It can be a PRP containing various factors like the transforming growth factors, platelet-derived growth factors, fibroblast growth factors, and the bone morphogenic protein. At least there are 20 bone morphogenic proteins. But currently we are only using 2 and 7 because they have only got the FDA approval. And the cells base, that is the mesenchymal stem cells, stromal cells. So these are the, which I already discussed, these are the commonly available orthobiologics, which we are using, bone grafts, bone graft and substitutes like chronos and stimulants, bone morphogenic proteins, demineralized bone matrix, platelet-rich plasma, bone marrow aspirate concentrate, autologous conditioned plasma, as well as amnion-derived products, adipose tissue and stem cells. So depending on how they are available from, either they are available from bone or they are growth factors or they are blood derived, they can be classified as simply in, like if it is derived from the bone graft, it can be autologous or allograft or bone graft substitute. It can be a growth factors like various growth factors we are getting, and blood derived like platelet-rich plasma and autologous conditioned plasma. And the other thing like visco supplementation, which are using earlier also and now also, and that hyaluronic acid supplementation and autologous chondrocyte implantation. So before going to the future, we should know something about behind the concept. What is the concept? Why we are using this orthobiologics? Why they are most of the surgeons are using, or what is the why we are remaining on this orthobiologics? Because the healing, no surgeon wants their patients to be their patients forever. They want to heal their patients, and no patients wants to be injured forever. So the healing, the body mechanism is that it gets in inflammation process, then proliferation process, and maturation process. The inflammation is at least for 1 week or 2 weeks, and it is all the three processes are overlapping to each other. There is no end point or a beginning point for one process. The proliferation in the inflammation, the various cells, mainly the blood, and accumulates there, and it forms a clot, and clot contains platelets. So we get from that there is growth factors. These growth factors again causes the proliferation of other cells, and which laid down the matrix, that is the collagen and other things. And maturation is that this collagen is matured so that it gets strength to the original injured. What is the original? Near about 80% strength can be achieved from after the injury. The orthobiologics is accelerate this healing process by giving this like PRP. We can getting an example. The PRP is mainly containing the growth factors, so we can directly put in the it accelerates the proliferation process, and accelerate the healings in this. So continue to the evolution of orthopedics, orthobiologics. First can be of hyaluronic acids can be as regarded as first generation, which were used earlier in ONEs as well as other applications. And second generation, these are the platelet-rich plasma, like the first orthobiologics in autologous form, which was used. And now coming to the third generation and future, like this bone morphogenic protein in stem cell therapy and specific growth factors, which are targeted growth factors. Now, coming to the interventional, we are using orthobiologics in various branches. Now, in the coming future, there can be a branch of orthopedics, sub-branch of orthopedics that is called as interventional orthobiologics or interventional orthopedics. So, orthopedic issues, mainly the bone, muscles, and tendons, ligament, cartilage responds differently to the injury. And according to Vora and others, this describe the regenerative therapy, which is called as interventional orthobiologics, which means injection of a small amount of solution into the multiple sites of painful ligaments and tendon insertion and adjacent joint space with the goal of reducing the pain and promoting tissue repair and growth. It is guided therapy in which we use ultrasound as well as a C-arm technique, and we use interventional orthobiologics. So coming to the various branches in which we are using the orthobiologics, and like orthobiologics mainly in the sports medicine. So there is a research article of this utilization of orthobiologics, a recent article from January 2021 and published in American Academy of Orthopedic Surgeons. According to this, orthobiologics mainly significant numbers in sport medicine doctors. Among the orthobiologists, platelet-rich plasma is the most commonly used, and osteoarthritis is most common indication for this. Now we are in the stage, according to the recent edition of the Campbell, there is a augmentation of ACL reconstruction. When we use orthobiologics, we are using now platelets derived PRPs in the tunnel of the ACL, where we use the graft to increase the osseointegration of the graft. Now PRPs are mainly used in tendinopathies like tennis elbow as well as rotator cuff tears. So this is a diagrammatic representation. So this is how in the first figure you can get, this is how is a bone patellar bone tendon graft, which are ACL reconstruction showing. If it is untreated with allograft, now after we concentrate the platelet around 5 times, and we are using platelets-rich plasma along with the collagen sponge, and we have integrated with the graft as well as the tunnel. So it gives a superior response and early rehabilitation. So orthobiologics in hip preservation surgeries. So there is again a paper on this. In this review, they compare 5 RCTs containing cell therapies like bone morphogenic bone marrow aspirate concentrate using for the avascular necrosis of the femoral head. And all case series and case reports use other orthobiologics like BMP and PRP, bone graft substitutes, etc. as well included. And they further concluded that that further comparative studies are much more required in this field. So this is a diagrammatic representation how we use in the such like the avascular necrosis of femoral head. Then we are put anything which we use bone graft as well as a PRP by drilling the holes, and this may be used in the early stages of the AVN, not in the later stages. So orthobiologics and fracture healings. Now, talking about the future, the earlier study you can see in the corner left, this is the earlier study which was published in 2012. The bone graft substitute in orthobiologics, which was used mainly for the fracture non-unions. So the above study was 2012, that is for the non-unions, and the second study, it was recent, and it was used in the acute fractures. So there is a shift. We can see that orthobiologists in the past decade are in past decades to a more preventive approaches. We are preventing the process of non-union by using the orthobiologists, by using them in acute fractures itself. Orthobiologics and osteoarthritis. So osteoarthritis is the most prevalent cause of knee pain, and if it is left untreated, we don't intervene in this, and then it can lead to a joint replacement surgery. Shows a promising result only in the early stages of the OA, and commonly used intra-articulars are PRP as well as bone respite concentrate and stem cell, which can be used intra-articular also. In futures, comparative studies, clinical trials will definitely justify the worth of orthobiologics in the field of osteoarthritis. Coming to the orthobiologics and spine surgeries. So mainly the orthobiologics are mainly used for the augment the fusion, where patients coming with listhesis as well as radiculopathies in which there is the instability in the spine. So orthobiologics are mainly used to augment this fusion along with the other implants and for the unstable spinal fragments. And with the advent of orthobiologics, spine surgeries are now shifting from a minimal invasive to a minimal invasive surgery. First, we have to do for our open surgeries. Now we are using endoscopic surgeries and deliver this orthobiologics, and will help in augment the fusion, which commonly used orthobiologics are DBM in this, PRP and BMP2, and bone graft substitutes are used. So these are some examples. So in the first, there is a case of infection as well as non-union. It was this is a granules which I am saying, these are stimulants, and which were used after an infection. The implant was removed, and the stimulants were used to deliver the antibiotics. In the second case, in the second diagram, the knee, you can see that it was used for the AVN of the condyles of the femur, as well as when we use for the osteoarthritis of the knee. And the third picture, you can see that spinal fragments, as well as which have been on the sides, you can see it has been augmented with some kind of orthobiologics which we used. Now coming to the limitations, orthobiologics and the limitation. Limitation is very much important because coming to availability, the orthobiologists are not available easily available and not easily accessible to all the patients. They are mainly used as a clinical trials, as well as mainly used in institutional studies and in higher centers. Therefore, they are not accessible to most of the patients. And cost. Second is the cost. If there is a stimulant which we use in the department, 5 grams of stimulant is worth of 25,000 rupees, and we are getting some problems, and also in which we are different government scheme like Ayushman, and we are not getting sometimes this stimulant. So the cost is the most important factors. More clinical trials as well as will be needed to make it a standardized mode of treatment. It is not a standardized mode of treatment. We don't have yet much of the level 1 and level 2 studies. They are only that surgeons are coming that our experiences. So they are going into level 5 studies. So they are getting some responses. Some are not getting the responses. So there is a need for level 1 and level 2 studies in the field of orthobiologics, and needs some products have to need FDA approval as well as other regulatory body approvals from India and market to readily available. Adverse reaction. Some orthobiologists carries adverse reaction also. Like we have used a PRP in our department also. And some of the patient get synovitis, and it is a non-microbial synovitis. There was no infection. It was responding to the, it was due to the orthobiologics, the PRP we had given. Second, third, lastly, the stages of the disease. Orthobiologics are not for all these various stages of the disease. If we are getting a bone-on-bone disease like in OA, if it is a bone-on-bone disease, the bone and bone are both are contacting each other, then there is no role of orthobiologics in that case. It is mainly in the stage 1, stage 2 disease, as well as in the AVN also. It is mainly earlier stages of the disease where we can get the much benefit for the orthobiologics. So this is a picture which can show that it's an iceberg illusion. It is seeing which are on the we are on the top. We are seeing only in the top the orthobiologics, and the rest that is in the way. Most of the thing is in the quest of the exploration only. So the take-home message can be it is mainly a definite place in the orthopedic surgeons on the armamentarium of the orthopedic physicians. They are widely used in showing promising results in various fields of orthopedics like sports medicine, knee, major joint orthostasis, spine surgeries, hip preservation surgeries, and many more things. And the discipline of that medicine which deals with regeneration of tissues through a precise placement of these substances under the image guidance is termed as interventional orthopedics, which can be in future, can be a sub branch of orthopedics also. And they definitely have optimistic outcomes for the future. Thank you, sir.
Thank you very much, Dr. Oja, for a very lucid and crisp presentation and showing us how orthobiologics can make a change in orthopedic practice. So thank you very much. We are short of time, so we will have discussion during lunch. Okay, thank you very much.
President, a momento to.
Now I invite Dr. Swashish Ray from Kolkata to speak on stem cell transplant in post-traumatic spinal cord injury, a review of 7 patients with minimum 3 years follow-up. Dr. Swashish, please.
Good afternoon. This is a presentation on stem cell transplant in spinal cord injury, which not many people do and not many people we get. The second is more important, that we do not get too many people who would like to volunteer for getting their blood or bone marrow out, sticking a needle inside, because this is not 100% guaranteed treatment. This is, as yesterday sir had emphasized, ethical committee has to be convinced that this person is an ideal person for this kind of treatment, number one. Number two, that person, all the members of his family, not only his wife, some few days later, someone might come and tell, why did you give him an injection of spinal cord? He has got a tumor now. No, you have to ask him, who are all the people who are with you? Let them come, and you have to, probably 20 people might come, and you have to get 20 people consent. The consent of the patient as well as 20, 30, 50 people consent. Nobody knows. At 6 months later, someone might sue you in court. This is a very important subject and very important thing to remember, that it's not like surgery. It's not like, okay, fine, you have been given a consent, you signed the consent, your wife has signed the consent, tomorrow morning, you remain at NPM, tomorrow morning, we will take you in OR at 9 o'clock. Anesthesia is ready. No. This is not the thing. These are totally experimental. The ethics committee has to be totally convinced. The patient has to be convinced. Your doctors has to be convinced. All the team members have to be convinced that this is the ideal person. There is a criteria. The whole criteria, at least 99% of the criteria has to be met for this treatment. Otherwise, if it boomerangs, you are totally in a soup. Okay, let's come to the presentation. This is complete spinal cord injury. I'm not going into details. The different types of stem cells all has been talked about. There are lots of clinical trials going on throughout the world. In India also, Indian Spinal Injury Center and some other centers are undergoing their experimental and clinical level therapies, and R is level 2 evidence. Level 2 evidence we have still now, and we are in human trial because after having got a complete NOC from our ethical committee, who had completely scored all the data throughout the world and seen that, okay, in animals and in randomized trials, the people had, the subjects have had a good result, then only they had permitted us. That was back in 2015. They had permitted us to start the trial, human trial, and we had started human trial, and still now we have done 16. This is only a follow-up of 7 who have had a follow-up of 3 years and more, and still it's going on. This is overview and pathophysiology of stem cell treatment. All this has been talking about. I won't talk about that. This is the demography of the series. 7 subjects, 5 male, 2 female. The age range of the age is 14 to 52 years. Mean 32.71. Standard deviation plus or minus 12.09 years. 3 subjects had injury in the cervical, 2 each in dorsal and lumbar region. Causes were variable. All were traumatic. The range of intervention was between 6 to 18 months after having them running from pillar to post, everyone giving them, you won't revive. Okay. Mean is 11.28 months, standard deviation 4.42 months, 4 male and 3 female. 5 subjects, stem cell were harvested from bone marrow. 4 male and 1 female. Sorry for me. 4 male and 1 female had been harvested from bone marrow. 1 male and 1 female, the stem cell were harvested from peripheral blood. 2 subjects from the peripheral blood and 5 subjects from bone marrow. Nowadays, we don't take it from peripheral blood. Nowadays, we only take it from bone marrow. This is the technique how bone marrow aspiration is done. Yesterday, Professor Khanna had detailed it, and I'm not going into details now. This is fluoroscopic guided. This is ultrasound guided. All the orthopedic people know how to access the bone marrow. After having taken out, everybody knows the bone marrow has 2 parts. One is the red bone marrow, one is the yellow bone marrow. The red bone marrow contains more hematopoietic cells, and the yellow bone marrow has more mesenchymal cells. So we do not know where is the yellow bone marrow, where is the red bone marrow, because we are not seeing it under the microscope. So we have to puncture a number of sites, and we usually do it in the OR after giving local anesthesia or sedation, and we do a multiple puncture from posterior crest on one side or from both sides. So how much amount of bone marrow do we take out? Accordingly, what we have found out that 0.001% of mesenchymal stem cells is available from bone marrow. So if we take out about 100 ml of bone marrow, we will get only about 1 ml of mesenchymal cells, which is enough for a spinal tract intervention. So 100 ml of bone marrow is not a matter of joke. So we use 50 ml syringes on either side. The 2 people on either side in the same setting, 50 ml syringes. We have big plungers like FNSC plungers. We have big plungers. We start them. We do not have affordability for these machines which suck out these bone marrows. So we use manual methods. We use big plungers to aspirate the bone marrow from both iliac crusts. So we can get it easily done and do it fast. So 50, 100 ml of bone marrow is aspirated, then it's taken, the bone marrow is taken for centrifugation, and after that, there are 2 methods. One is the Ficol-Park method of cell separation, Another is a cell separator machine. Previously, when we used the Ficol-Park method, it was a little costly. We didn't have any access to cell separation machine. Nowadays, we have tied up with a blood bank who have a good cell separation machine, and we send the bone marrow in liquid nitrogen to them. Then they thaw it, and then they use their cell separation machine to separate the mesenchymal cells. As is indicated, you get the mesenchymal cells from the Buffy coat stratum. What are mesenchymal cells? The International Society for Cellular Therapy has developed criteria to outline human mesenchymal cells. These are defined as those cells that are able to adhere to plastic and express a number of cell surface markers while undergoing multilineage differentiation. Mesenchymal stem cells are multipotent stem cells obtained from various adult tissues like bone marrow, stroma, adipose tissue, etc., etc. Cultured or non-cultured, we do not culture bone marrow. We do not. But before aspiration of bone marrow, we give Neupogen injection, which is GM-CSF, colony for stimulating factors, 3 successive days, and on the 5th day we harvest the bone marrow. First 3 days GM-CSF, and the 5th day we harvest the bone marrow. And after the bone marrow is harvested, nowadays we use cell separation method. We do not use the Ficol-Park method nowadays. Bone marrow is concentrated. Bone marrow is taken in a heparin bag, and after that, centrifugation and separation protocol concentrate the indispensable BMA aspirate cellular content to BMA concentrate. Excessive BMPF, BM plasma fraction is manually removed. That is, it is sieved. Microsieve, the blood bank has a microsieve. They sieve the particulates. BMC injected volume. Previously, we used to give about 3 to 5 ml or 10 ml even, because after that we found out that most of them did not have mesenchymal stem cells, because most of them we couldn't harvest the mesenchymal stem cells due to non-availability of good cell separation machines. So nowadays 1 ml or 2 ml of mesenchymal, because intrathecal site of an injury is a very small area, and that area has to be targeted specifically. We don't want to wash the whole spinal cord from head to sacrum. No. Transplant procedure. We use intrathecal method. In the previously in this series, of the 7, we had given 2 patients or 2 subjects intravenous. Nowadays, in all subjects, we give intrathecal injection. How do we give an intrathecal injection? First, we do an MRI of the patient. If the patient has an MRI, fine. If the patient doesn't have an MRI or an old MRI, we do a fresh MRI. After the fresh MRI, we always do a spinal cord tractography. When we do a spinal cord tractography, we definitely assess the area of loss. We call it an area of void, or the radiologists call it an area of void or area of loss from the tractography, because in a plain MRI, we do not get an area of void or area under the curve, area of void, or whatever the radiologist, if there is any radiologist, they know it. We always do a spinal cord tractography, measure the area of void so that we know how much bone marrow, how much mesenchymal stem cells has to be given or injected. In that way, we calculate how much of the bone marrow has to be aspirated. Sometimes we need to aspirate about 120 to 140 or 150 ml of bone marrow, which is very, very tough manually. We know it's very, very tough. Sir will tell how tough it is to aspirate about 100 ml of bone marrow with 50 ml syringe, because of the 50 ml syringe, for 30 ml, there will be air bubbles only. After the after we have got a good amount of mesenchymal stem cells, they are cryofrozen in liquid nitrogen minus 196 and transported back to us. And then we take these mesenchymal cells, mix them with 1 ml of lidocaine, and use previously we had used spinal needles to that targeted areas. Nowadays we use Tuhaar needles. Anesthetists will know what are Tuhaar needles. We use Tuhaar needles, which are epidural needles, and they have plastic sheets. And we in lumbar, it's very easy to target the areas. In dorsal, the anesthetists get it from the between dorsal 10 to 12 epidural injection, which is not epidural, but they break the dura and go intradural. It is very difficult to get an intradural access because the catheter is not that, the catheter diameter is not that much to get an intradural access, but you can find out in from research works that after a spinal cord injury, the distal spine always shrivels. It is a part of the Wallerian degeneration. The distal spine always shrivels, and because the distal spine shrivels, you can obviously get a wider pericaudal area. So in the cervical also, as you can see, previously we used to do a targeted cervical intrathecal injection. Nowadays we use epidural needles, Tuhaar needles to go into directly into the cervical region from C8 up onward. Though we haven't got up to C2 or C1, no, we haven't got that higher lesion. We had got a lesion up to C5 and C6, and that was enough. It is the same way as a epidural injection, but the way our anesthetist also told that if you give in only two subjects recently, just 6 months back, one subject, and about 8 months back, one subject during the lockdown period, we had given it.
Dr. Ray, sorry to interrupt you, please.
Okay, I'll just. We had given it subarachnoid because the blood-brain barrier also breaks down after spinal cord injury. Statistical analysis. The source of the stem cell was found to be significant. Bone marrow has more sources than peripheral blood cells. No significance was found regarding the separation method and method of transplant. So separation method in both fecal park and cell separation is equally similar, but the cost is the factor. And moderate correlation was found between the age of the subject and the ASIA score. Now I'll come back to the ASIA score. If I get back, in our series, all of the patient had come with ASIA A grade. That means complete quadriplegia or paraplegia. But in 3 years, most of the 5 patients, of the 7 patients, 5 patients had improved to ASIA E. That is the normal. Now the question might come, is it the normal regeneration or is it the stem cell which is improving? That is up to the pathologist, histopathologist, and the electron microscopist to find out. We don't know. And 2 patients are still in D, but in the new patients, I won't divulge, they're still in the trial process. Conclusion, while age and source of harvesting of stem cells in this small sample were significant with the end result of improvement using ASIA score clinically and Kimura scale in NCV, mode of cell separation, mode of transplantation was not significant with the end results. And this is just a small endeavor from Spine Services India, which is our institute. And I'll just a disclaimer, none of our authors were supported by any funds from our sources, and we had to pay most people from our pockets. And thank you. Jai Hind. Any questions?
Thank you, Dr. Ray, for excellent presentation and sharing your work with all of us.
I think we are running short of time. So if there are any questions or queries, you can discuss with Dr. Way during lunch hours.
I'd like to request Professor S.P. Dhaneria sir to kindly present a moment.
I next invite Dr. Ekta Khandelwal, Associate Professor Physiology, AIMS Raipur, talk on sickle cell disease, role of hematopoietic stem cell transplantation.
A very warm good afternoon. Myself, Dr. Ekta Khandelwal, Associate Professor Physiology, AIMS Raipur. First of all, I would like to extend thanks to the organizing team for giving us this platform in this new normal era of COVID for presenting our work and our talks. So I'm going to speak on sickle cell disease and its recent role on hematopoietic stem cell transplantation. The overview of my talk will be, I'll be discussing what is actually sickle cell disease, what is a little bit about pathophysiology, its prevalence because it is one of the most common cause of global burden nowadays, then current treatment option available for the disease, what is the future perspective, that is the role of hematopoietic stem cell transplantation, its limitation, its perspective and conclusion. Before beginning a talk, when I was reading about this, I come a beautiful line, which I want to quote from an author, that is Koff et al. In American Journal of Hematology. He says, when one considered the additional contribution of sickle cell disease associated with reduced quality of life, uncompensated care, lost productivity, and premature mortality, the full burden of sickle cell disease is likely to be quite high. So with this, let's see. The introduction. Sickle cell disease is an age-old disorder, but its existence come into play in 1910 when James Henrich, a physician, has in Chicago found out that most of its patients come with abdominal pain in joints with an unexplained etiology, along with jaundice and unexplained tiredness. There are many landmarks in the history of sickle cell disease, but one is very important, that of Linnaeus Pauling. Linnaeus Pauling is a person who actually said the first disease for which molecular defect identified. It is a substitution of a single nucleotide in the sixth position of beta globin chain of hemoglobin, abnormal hemoglobin polymerization, and it is an ideal thing for hematopoietic stem cells transplant-based technique. So in the same very paper, Linnaeus says, I believe medicine is just now entering into new era when progress will be much more rapid than before, when scientists will have discovered the molecular basis of disease and will have discovered way molecules of certain drugs are effective in treatment and others are not. So with this, let's come to the pathophysiology of sickle cell disease. As we all know that this is an autosomal recessive disorder, and it is the 11th position of the chromosome where this gene for hemoglobin is being situated, and there is a single nucleotide mutation, that is adenosine is changed with thymine. This leads to formation of glutamic acid and valine. This glutamic acid, which is a normal part of the beta chain in normal RBC, do a normal function, but when it is changed with valine, whenever there is a deoxygenation, the blood cell is changed into crescent shape. And this crescent shape is because there is a polymerization, and this polymerization of a hemoglobin leads to formation of tecoids. This tecoids gives a spiky shape of a hemoglobin, and it is very brittle in nature. So the lifespan of RBC is also very reduced. Along with it, leads to obstruction and cause vaso-occlusive crisis of sickle cell disease. The genetics of sickle cell disease is generally it is copied by 2 genes, and we have to understand that there are usual traits of it. We have 4 basic syndromes of sickle cell disease. One is your trait, another is your anemic, which is SS, that is homologous. Along with we have HBSC disease, which is basically, we have two double heterozygous, that is HBSC disease and sickle beta cell thalassemia. They have a different presentation. Definitely it is the SS, and this is double heterozygous disease has more severity of disease. And when they present the symptoms and complications with this, typically it occurs in the infant during first year. During the first life, till fetal hemoglobin is present, it is well maintained, but when it is gradually changed, the symptom starts appearing. It is the dictylitis and the fever, which is very severe, and it is also known as hand-foot-mouth disease. Apart from it, we have a pain in chest, abdomen, limbs, all form of vaso-occlusive crisis, and which leads further decrease in the lifespan. The overtime sickle cell disease has affected almost all organ of the body, but it is mainly which is affected is your kidney and spleen. Vaso-occlusive crisis, which is one of the presentation of sickle cell disease, is actually the most common cause of morbidity. Right now, we are working in this area of vaso-occlusive crisis to understand what is the pathophysiology behind it. And it leads to the cause of death. The global burden of sickle cell disease is quite high, and the prevalent in the different parts of the world, including sub-Saharan, African, Middle East, and India. Extensive studies by Anthropological Survey of India data reveals that sickle cell disease is having a high frequency of 35% across the eastern Gujarat, western Odisha, Maharashtra, Madhya Pradesh, Chhattisgarh, and North Kerala. So we in Chhattisgarh are present in actually in the sickle belt. This sickle belt is basically, if you see the situation in our condition, right, it is a screening data which is taken under by Institute of Sickle Cell Institute by our Raipur itself. In 2014, it shows that the trait was 9.64% and the homologous population is 0.29% in 7 out of 27 districts. But when we consider it the recent data, what we have found that the prevalence of trait is 9.41, which is reduced, but the sickle cell disease that is access is increased in the 12 districts of 28 districts in Raipur. So it shows that there is an increasing trend in the portion of the disease burden in the state. And this is basically, as we all know, that this is particularly present in a particular tribes and caste, but it is not like that. It is also present apart from Kurmis or tribes like Gonda, Halba, it is also present in other castes across the world. So the question arises, what is the available treatment option? We all know that hydroxyurea is one of the FDA approved, is a treatment since 1995. And it is the drug which is basically considered to be the first line. Apart from it, we generally treat the patient according to the basis of their symptoms, symptomatic relief, pain-killing drugs, oral intravenous fluid, and transfusion. But transfusion itself has its own limitations. And apart from only corrected anemia, treat spleen enlargement, and all that, but they are all not curative. We have to now look something which is more promising and of curative in nature. So that is why we are here to discuss the hematopoietic stem cell transplantation. Can it be a role? So this question arises after seeing these points. As we know, the sickle cell disease has evolved from fatal disease in childhood to the chronic disease of adulthood. Just with the help of hydroxyurea, there is a decrease in vaso-occlusive crisis, there is a decrease in the complications, but still it has not gone completely. So the main life-threatening condition like either cerebral infarct, strokes, everything has just came slow down, but it has not stopped completely. And when we have seen a stroke with transfusion changing to the hydroxyurea trial, that is switch trial, it is found that hydroxyurea did not impact progressively vasculopathy. So that is why we need something to change. So in adult, if you see the mean age of survival is just 40 years. So coming to the role of stem cell transplantation, if transplantation is curative, can we fulfill this wish list? This is something which we have to think. We should be associated with low transfusion-related, transplantation-related morbidity, low organ toxicity, high disease-free interval, no GVDH. Apart from it, the only thing which we are interested in increasing quality of life of a patient. So seeing the role of HSCT is bone marrow transplant as a cure. So before going through it, we have to first see the variables we have to work with it. We have to actually see the age of a patient, stem cell sources. I'm not taking this in a detail because it's already been discussed from past few lectures yesterday also. So I have just skipped these things. So we have to actually take care of immunosuppression to prevent rejection, to prevent engraftment, and to reduce toxicity. So with this, we have to actually focus that a graft should take well and there should be a reducing toxicity. The indication for HSCT in specific sickle cell disease is quite specific. As we have seen the four different types of sickle cell syndrome, it is the SS, that is homologous, as well as the sickle cell with thalassemia is one of the major disease which causes the side effect and is potent for HSCT. So indication for HSCT is, it is the matched sibling donor. Generally, if you see, there are three different criteria for this. This is a matched sibling transplant, matched unrelated donor transplant, partially mismatched related, that is haploidentical, unrelated cord blood transplant. We have seen there is one common thing is that there is a failure of hydroxyurea treatment. So that is why the severity of the disease increases, the complication increases. I'm not going to list each and every complication because of the lack of the time. But if I want to see, just you have to see that the pulmonary complication and the neurological complication, all complication is increasing gradually and patient is not responsive. So with this, what is the protocol for this? We have, when we get a patient of sickle cell anemia, we start with hydroxyurea. If any signs of progressive organ dysfunction or stroke, we have to change, do its HLA identical matched sibling available. If there is no HLA identical sibling available, then we have to go accordingly. If we have matched, we go with matched BMT, reduced intensity HSCT, myeloablative related CBT. If we have alternative donor transplant option, we have non-myeloablative haploidentical BMT options available. Matched unrelated donor BMT and PSBT is available. So with this, we have to just see that the myeloablative transplant, which is basically considered initial days, is not very good because it is basically related with hypogonadism, ovarian failure, sterility, and secondary malignancy. Apart from it, neurocognitive disorders, seizures, everything has been increased by myeloablative transplant for sickle cell disease. So what can be an option? Though there is another thing is reducing intensity conditioning can be an option. And the trial is going on. The SCORE trial of this is going on, which says that there are 32 transplanted patients. Follow-up is being done for 3 months to 8 years. The age is between 2 to 18 years. And we found that graft rejection was only 18%. And most important, the grade 3 GVDH is 7%. So it can be a promising tool. And with this findings, we can say that it will be a promising for further. Another is haploidentical transplants for sickle cell disease. This paper is very important where Belnos has taken 14 patients and what he found that 8 patients have event-free survival for 2.5 years without any complaint and any medication further required except for a routine. And there is the graft rejection percent is 43%. There was no serious toxicity and death reported. The same way, Fred has also said that haploidentical transplant for severe sickle cell disease using identical CD34 enriched familial product. Hematopoietic stem cell is a vehicle for therapeutic generation, and it is the Journal of Medicine, the New England Journal of Medicine has done a
Dr. Ekta, please conclude.
Yes, with the children with sickle cell disease, and they have found that it has a toxic conditioning. So there is a limitation of sickle cell disease. We know the cure, but there are many obstacles. Need for HLA matching siblings. There is less than 8% have a suitable donor. Cord blood results have disappointing. So finally, we have to come through these limitations and which open the additional avenue of research. And where we can actually mesenchyme with stem cell infusion, XYO expansion of cord products using proliferative signaling, haploidentical cell infusions, reduce toxicity. So with this, I want to conclude my talk with that transplantation for sickle cell disease is evolving and improving. The new frontiers of the conditioning, optimizing stem cell source, supportive care, and GVHD therapy is helping the field advance. Our definition of success must now be based not only on the overall survival or disease-free survival, but on the quality of life. The only way of moving the field forward is developing, cooperating with the participation of formal trials designed to improve the track outcomes. Thank you so very much for your patient hearing. Thank you.
Thank you. We can take the question in the lunchtime.
I'd like to request our director sir to kindly present a moment to.
So thank you very much. And now it's my proud privilege to invite Professor Dr. Sanjay Wadhwa, actually Rehabilitation Medicine from AIIMS, New Delhi. Professor Wadhwa, good afternoon, and sorry to keep you waiting. We are almost 1 hour behind schedule, but it's always a pleasure interacting with Professor Wadhwa. And he has already supported AIIMS Raipur so many times in the past. He has also been here for the PMR and CME, which Dr. Nandi had conducted. So Dr. Sanjay Wadhwa will be speaking on stem cells in rehabilitation medicine. Warm welcome, sir.
Thank you so much, sir. Is my slide visible clearly to all? And am I audible?
Professor Wadhwa, sir, good afternoon.
Good afternoon, sir.
Dr. Nagarkar, we can see your slides very well, sir.
Okay. Thank you so much, sir. So I begin my presentation.
Thanks.
And as sir has already informed, I was asked to speak on stem cells in rehabilitation medicine. And I have been keeping track of this program for some time, and it will be very criminal on my part if I act as a barrier between you all and the lunch. But I would like to run through my presentation briefly, and I am sure there will be opportunities for detailed interaction in future. We have all been listening to the experts, those who have years of experience of having worked in the stem cell field in various conditions. They have developed a certain degree of expertise. And during these presentations also, it became obvious to me that there is a lot of need and scope for rehabilitation medicine interventions and services in order to improve the outcome of the experts who have presented their years of work, whether it is neurologists or orthopedic surgeon or hemato-oncologists, etc. And if we review the literature, in the last 25 years, there has been a large number of publications in this area of research, because the area is very promising and exciting. And it offers so many promises, improving the conditions which were earlier thought to be incurable. So in our field also, in the Indian scenario, if I may share, one of the first publications that we had in our journal was way back in the year 2008. And there are other publications also, other areas of work. And some of the other areas have been regenerative rehabilitation is now coming as a new field, and it is considered to be an interaction of the fields or overlapping of the fields between regenerative medicine, rehabilitation, which is a traditional rehabilitation, and the main goal or the objective is to optimize clinical and patient outcomes by enhancing tissue and organ functions, by reducing the disabilities and increasing quality of life. Many a times, cure is not there, but improvement of quality of life is a very important consideration. And there are other things also which can play a very complementary role, and that is sometimes use of external stimulators, therapeutic physical activities, assistive technologies, etc. Now, the list of conditions in which stem cells in our field are being tried is increasing gradually. And this is an arrangement of the conditions in alphabetical manner, starting with arthritis, whether it is rheumatoid arthritis or osteoarthritis, back pain due to a variety of conditions, cerebral palsy, degenerative disorders of nervous system, myopathy, neuropathy, Parkinsonism, spinal cord injuries, sports injuries, stroke, and trauma to other tissues of the body. And in this, the brain injury rehabilitation has an important component of stem cell intervention. And the experience is increasing, and we are learning many things. Till date, there is no finality, and work is in process, and we are learning many things. There is lack of consensus about the source of the stem cells, the protocols, and the ways of following up the patients, the guidelines, etc. Now, this is just a depiction diagrammatic of the cerebral palsy, which is a very common condition in our field. And We all know what is cerebral palsy. There is no single medicine. There is no single set of exercises. There is no appliance which helps the person. It is a combination of many things. And in this armamentarium, stem cells has been a new addition. And there are some initial trials which have shown promising result. But there is a lot more that needs to be done in this area. Stroke is another area. And this is a person who has got injury to the spine. And this person received stem cell transplant. And after the transplant, the role of rehabilitation does not disappear. Rather, it improves the role of the rehabilitation so that the final outcome is much better. What we have done, I have no hesitation in accepting. In our field in India, we have taken a few baby steps. And baby steps towards big dreams. And I appreciate and understand the value of baby steps. And we tend to forget that baby steps still move us forward. I am not claiming that we have done wonders. We are learning and we are moving on. And what we require is hand-holding by certain experts who have shared their experience during this important academic event during the last 2 days. In AIMS, we are fortunate to have Dr. Sujata Mohanty. We have Dr. M.V. Padma Srivastav in neurology. We have Dr. Rajesh Malhotra in orthopedics. And similarly, other experts who have done pioneering work in India in AIMS New Delhi. I'm sure similarly there are experts in AIMS Raipur also. And I will request for some kind of hand-holding because we are, as I have confessed, we are taking baby steps and we want to move forward because there is a lot of promise in this area. And we will be able to improve the outcome of various other experts. And I was very much happy to note that there is an Institute of Biostem Cell Rehabilitation exclusively dedicated to this particular area of work. And this is located in Ukraine. So that means there is so much that is happening and intensive rehabilitation is very challenging. It is not easy. It is not cheap. It is not a short-term intervention. But besides being challenging, it is also very satisfying. And those who have had the experience of working in this field will vouch for it. But it should start early for the best results and sometimes even before the stem cells have been administered in the person so that we have pre-intervention assessment based on objective scales and other criteria and we can monitor the progress of the patient during the journey. Treatment and rehabilitation is a journey. It is not a single point event. Also, it is important to understand that comprehensive rehabilitation is not just physiotherapy. It is much, much more, and there are a variety of trained professionals who are involved in that. And based upon the limitations which are there in the outcome, we involve other professionals. So it is a common misconception that rehabilitation is physiotherapy, and if I may go further, physiotherapy is diathermy. It is not that. And what is important to understand is that stem cells in rehabilitation medicine or in any other field, they are resource intensive. And there are certain legal and ethical issues also, which are important. And we have to be acutely aware of the Rights of Persons with Disabilities Act 2016. It has laid down certain criteria that whenever a person with disability is to be enrolled in any research activity which involves trial of new interventions or other things, then there are rigorous criteria which are to be met so that tomorrow there is no mishap. And this law is very strict and there are punitive measures also. So in our excitement and rush for interventions, we should never ignore the other legal concerns and ethical issues, and we should be acutely aware of these things and understand in details so that we are not caught on the wrong side of the law. Unfortunately, many of the persons with disabilities have no voice. And because they are desperate to find hope, wherever there is a promise that yes, the person will get better, the parents rush to take their children with cerebral palsy or muscular dystrophy to that center. And media is often involved in creating the hype about this particular area or interventions. And there are many people who felt later on cheated and exploited because resources are limited. And I just want to emphasize that we should abide by the law and what are the statutory recommendations and guidelines and regulations. And I will not take much of your time, and I would like to end my presentation with sincere thanks to Professor Nitin Nagarkar, sir, the director of AIIMS Raipur, and Professor Alok Chandra Agarwal, a dear friend who is head of orthopedics department, and everyone else. I am sure there will be opportunity to share our preliminary work in subsequent platforms and events. Thank you so much.
Thank you very much, sir, for a wonderful presentation and showing the way forward. I think you people have rightly taken the right steps in AIIMS New Delhi, and I'm sure that you will guide our institution also.
Thank you for the opportunity, sir. Thank you.
Thank you very much, sir, and we'll keep interacting in future also. Regards.
Sure.
Thank you.
I'd like to request Professor Alok Agarwal, sir, to kindly present a memento to our chairpersons.
Thank you, Dr. Vadva, sir. You have given us a pathway for interaction, and we'll take.
Thank you, Dr. Alok.
And continue in the same direction.
It is a pleasure. Thank you so much. Thank you.
And dear friends, we'll break for lunch now and come here exactly at 30 minutes so that we can continue with the sessions. Thank you.
अच्छे दिन से संकल्पित थे तो सुबह सुबह सब उठते हैं आत्मा गुरु बात से ये यहाँ तक दर्द हो मसले की सरकार ना सत्तर से लगी मां को बात से दवा नहीं कर देगा हमसे बताइए से दर्द है
लंच करना सेशन वाले तो हो गए तो और भी बचे ठीक है अभी टाइम लास्ट सेशन उनके साथ नहीं सर वो पेपर वगैरह में कर देंगे हाँ ये डाटा कॉपी करते हैं वही कल ऐसे ही किया था
डिपेंड में रखा ड्राइवर कैंसर और तो मैं नेक्स्ट टाइम लाऊंगा
require some sufficient buffer time. Please.
Good afternoon, Dr. Bagul.
Continuing with the next session. We'll start the session now. So I'd like to request Dr. Jiten Kumar Mishra sir, Dr. Neeta Mishra ma'am, Dr. Bikram Keshri sir to kindly come and chair the next session. I'd like to call also Dr. Kanchan Mishra sir to chair for the session.
Mike. A very good afternoon to all of you. We will be starting the post-lunch session now. The first speaker is Dr. Satish Muthu, and the topic is MSc-derived exosomes in osteoarthritis knee. Dr. Satish?
I would request to all the speakers, please stick on the time, please. We'll be discuss later on, right? Yeah.
Good afternoon to everyone. We will discuss about the role of exosomal therapy in osteoarthritis knee. First of all, if we look into the Nobel Prize laureates list, in 2013, the prize has been given to these three fellows for finding out the role of transport mechanisms and their efficiency in cellular communication. If you look into the literature after that, you can see a number of publications saying that exosomes as a rising star, and even they are useful to tide over the bacterial toxins and even in COVID. And there are a lot number of databases generated after that for exclusively for these extracellular vesicles. Once they were considered as a garbage disposal system, taking all the waste materials from the cells and getting disposed. But later on, with the greater understanding, it has been known that these exosomes are a channel for communication between the cells. And these databases have been established. And as you can see here, there are around 286 studies enrolled in this database with these protein molecules and RNAs being derived out of it. First of all, what are exosomes? They are bilayered membrane extracellular vesicles released almost by every cell type in the body, useful for intercellular communication. What does it contain? It contains RNAs, proteins, and other biomolecules. What are the extracellular vesicle components? There is not only the exosomes that constitute these extracellular vesicles. There are other vesicles like ectosomes, microvesicles, microparticles, prostosomes, telosomes, apoptotic bodies, and nanovesicles. How are they different from the exosomes? Mostly based on the size and the origin and the markers what it carry. In case of exosomes, they are around 50 to 150 nanometers in size, and they carry markers like CD9, CD63, and TSG101. And you can see these are the molecules in the structure of an exosome. They have these fusion proteins, cytoplasmic enzymes, chaperones, trafficking proteins, and signal transduction proteins. How are they formed? We will see a short video on it. These are the cells which secrete these exosomes. Initially, these exosomes are formed by an intraluminal budding from the host cell. Playing slow. Okay. Okay, it is just formed by intraluminal budding of the cellular plasma membrane, and later on the proteins and the microRNAs being packed into those vesicles, and later on they are released into the extracellular milieu. And how they are uptake at the target sites. They have various mechanisms like clathrin-mediated endocytosis. There are various mechanisms by which the cells endocytose these vesicles into them to have an effector action. And what are their roles? Since 30 years of their discovery, their role in various physiological and pathological conditions has been ascertained. And what are their roles? There is another video how they function. The exosomes being released from the cell of origin is being transported either through the body fluids, and they reach the site of action and have their role at the target site. The biological roles in normal physiology as a morphogen transporters, maintaining the stem cell plasticity, maintenance of the homeostasis, immunomodulation, and anti-inflammatory function. Exploring into these properties of the exosomes, various literature has come up saying that they are a better therapeutic strength, and a topic called exosomics has evolved, which details about the physics and biology of their functioning. As you can see, there are various literature which supports exosomes as a morphogen transporters, as a stem cell plasticity modulators, and the factors which modulate the phenotype modulation of the target sites, and even in the maintenance of tissue homeostasis, immunomodulation, and anti-inflammatory function, and also even in the synaptic plasticity also. And you can see in case of cancer immunomodulation, they function as the mediators of cancer propagation also. They increase the host immunity by aiding the dendritic cell sensitization and immune co-stimulation. And they also, with the expression of death ligands, they help in controlling the cancer cells also. But in the either way, it is getting affected. And this is our study on the mesenchymal stem cell derived exosomes published in Cartilage Journal. And what is the role in osteoarthritis? We can see that osteoarthritis has a lot of pro-inflammatory cytokines playing a role in their pathogenesis. So these exosomes play on the either sides. They increase the inflammatory marker expression, and they have an effective role on the cartilage also. And you can see into the profiling of the exosomes which is seen in this osteoarthritis. You can see that this particular miRNA expression, 92A3P, is being downregulated, and also 95-5P is also regulated in exosomes. Hence, it has some pathological role in osteoarthritis. And you can also see that there is a negative role by increasing the modulation of matrix metalloproteinases, CCLs, variants like 1520 and CXCL1s, which will lead to inflammation and degradation of joints. It has also a defensive role, like this microRNA 200C is increased 2.5 folds in the exosomes in osteoarthritis, which has protective role on the cartilage. And in case of diagnosis, you can see that these exosomes has particular markers like these non-coding RNAs, which are highly increased in case of increased stages of the diseases. So it can be even used as a diagnostic tool, but it is all in the pipeline of the exosomics. And what about the therapeutics with the exosomes? They are the natural nanomaterials of small size with a large surface area. It has a drug loading capacity, and it is not toxic, and moreover it is immune privileged. So you can see that it has all the essential properties of an ideal nanomaterial to have an effect at the target site. And what are the MSC derived exosomes having a role in osteoarthritis? You can see that these bone marrow derived MSCs secrete these exosomes, which decreases the inflammation at the target site and also has a counterprotective action. And which content in the exosome actually has a therapeutic potential that is being explored. And you can see that this non-coding RNA called KLF3AS1 has been found to have, it has been discovered recently to have this therapeutic potential in osteoarthritis. What are the future prospects of this exosomal therapy? You can see that it has been used as a 3D cultured nanoparticles and scaffolds and 3D printed models. You can see that compared to that of a 2D culture, 3D culture has various propensities like that of a native cell. So it is better. And there are various publications to support that. Some nanoparticles modulate these exosomal functions like that of silica or gold, and which has been used in case of pathological milieu to reduce their action in case of negative modulation. And there are various publications to support that also. And what about the scaffolds? There are various publications stating that there are scaffolds to support these exosomes at the targeted sites to have an extended function. And what about this 3D printed stuffs? Using a 3D printed technology, you can exactly make a structure of a scaffold particular to that of the cartilage loss to have a prescribed delivery of the exosomes. This is a stereolithotropic 3D printed model of the cartilage loss, which has been printed and impregnated at the cartilage loss site, which will deliver the exosomes gradually so that the function of exosomes is being extended and patient tailored. These are the various prospects with these exosomal therapy in osteoarthritis. And you can see there is a lot of research undergoing. It is not yet for clinical use, and it will, we hope so. In decades to come, it will be the treatment of choice in case of osteoarthritis. Thank you. To conclude, we can say that exosomes are nothing but vesicles. Most of the exosomes in the OA environment are for the pathological effects, and there are various ways by which these mesenchymal stem cell derived exosomes can be used for cartilage protection also. And thanks for this opportunity.
Thank you. Any questions?
Dr. Muthu, I must congratulate you. You are one of the few speakers who have kept to the time.
Yeah, that's great. That's why we allowed if anybody have just any single question,
So we still, yes, as Sir has said, we have time for 1 or 2 questions.
Okay, ma'am, go for next.
Thank you. Thank you, sir. Thank you.
Thank you so much.
Our next speaker is Dr. Madhan Jayaraman. His topic will be on gene therapy in osteoarthritis of knee.
Very good afternoon. My topic is gene therapy in osteoarthritis knee. So why we need gene therapy? Their articular cartilage defects and meniscal lesions have reduced capacity for regeneration. So the concept of using gene transfer for cartilage repair originates from the idea of transferring genes or gene coding sequences along with the vectors to have a temporally and spatially defined delivery of targeted molecule. So what is gene transfer? It is introduction of foreign gene or gene sequences into different types of cells to modify the natural course of the disease. So we are introducing a foreign genetic material, so it will integrate with the nucleus and it exerts its action. So the transgene expression will be occurring. For a therapeutic intervention, gene transfer into a sufficient high number of target cells is essential for secretion of various concentration of transgene product. So the heart of gene transfer is vectors. We have 2 types of vectors. One is viral vectors and non-viral vectors. Viral vectors acts via transduction. We have 4 viral vectors: adenovirus, adeno-associated virus, retrovirus, and herpes simplex virus. Non-viral vectors acts via transduction. Here the methods are chemical, electrical, and mechanical methods. So non-viral vectors are chemical methods of complexing DNA to various macromolecules. It avoids the risk of acquiring replication competence to viral vectors. So it can be repeatedly administered and it carry the large therapeutic genes. So inside a cell, it stays as an episomal form to have a short-term transgene expression. Viral vectors. These viral vectors enters the body into natural entry pathway, and it has a legitimate safety concepts because of that infectious etiology. Here we have 4 viral vectors. Adenoviral vectors allow the high transduction efficiencies And adeno-associated virus is mainly used in cartilage because they are non-pathogenic organisms and they are replication defective human parvovirus. Parvovirus, adeno-associated viruses. So the vector-based AAV are produced by complete removal of viral gene and making them less immunogenic and less toxic than herpes simplex virus. This adeno-associated virus is transcribed for months to years due to the stabilization of episomal transgene cassettes by concatemer formation. So there are three modalities of gene transfer. One is in vivo gene therapy, second one is ex vivo gene therapy, and third one is biomaterial-based gene therapy. So what are the target cells we use to have the gene therapy? One is progenitors, that is the locally available stem cells. The second one is isolated articular chondrocytes, and the third one is cell adjacent to articular cartilage defect. So it can be osteoblast, osteocyte, synoviocyte, fibrocartilage. So all these cells can be targeted. So what is osteoarthritis knee? It is a basic chronic progressive degenerative joint disease. It not only affects cartilage, but also bone, subchondral bone, synovial lining, ligaments, and muscle tendons. So due to complex pathogenesis, the cartilage will go for softening, fibrillation, ulceration, loss of articular cartilage, sclerosis, and subchondral bony cyst. So it is hypothesized with the interplay between rate of cartilage repair and degeneration. So what are the treatment options available? Physical therapy, pharmacological therapy, reconstruction, orthobiologics. The new ones are cell-free exosomal therapy, which was built earlier, and the gene therapy. So this is the complex pathogenesis where increase in protease, cytokines, TMP and MMPs leads to cartilage degeneration and leads to apoptosis and necrosis of the chondrocyte. So osteoarthritis knee is the diminished results from the diminished production of normal cartilage matrix, enhanced protection of matrix degenerative enzymes, and decreased responsiveness to reparative stimuli. So in vitro gene transfer, we have 5 mechanisms here: inhibiting inflammatory and catabolic pathways, stimulating anabolic pathways, avoiding the pathological formation of osteophytes, and prevention of apoptosis. So while inhibiting catabolic pathways, we have to increase that is IL-1RA and counterproductive cytokines IL-4 and IL-10. Activation of anabolic process. So here we have to administer the components of cartilage forming matrix, that is IGF, insulin-like growth factor 1, fibroblast growth factor 2, BMPs, and TGF-beta, and transcription factors like SOX genes. Restoration capacity is done with in vitro application of IGF-1, FGF2, and telomerase and heat shock proteins. So the foreign material can be directly or indirectly be given to the cells to modify the cells, and successful attempts have been recorded with the viral coding vectors of IL-4, IL-10, and TNF receptor antagonists, and combination of all these three things. So there are two methods. One is direct gene delivery and indirect ex vivo method. In direct in vivo method, we have viral and non-viral vectors. Viral vectors have high transfection efficacy, and non-viral vectors have high safety because of less immunogenic nature. And indirect delivery is through isolating the chondrocyte or stem cells and integrating it with gene of interest, then culturing it and giving to the site of action. Ex vivo culture is considered safe because there is no viral vector, no free vector particles introduced in the body. So it also, here we have isolated the stem cells or chondrocytes. So we are increasing the cellular count of the product which we are administering. And synoviocytes have been employed to deliver the inhibitors of inflammatory and catabolic cytokines. And dermal fibroblasts has been modified for the purpose to overexpress interleukin-1 receptor antagonist and soluble TNF-alpha receptor antagonists or combinations. So multipotent cells have been suited for more transplantation because to increase the number of cellular count in that site of action, and progenitor cells are mainly for differentiation, multipotential differentiation, and capacity for expansion. So one more method was injection of muscle-derived stem cells modified by gene transfer of BMP4 with the vascular endothelial factor antagonist for cartilage degeneration in rat model. So biomaterial-based gene transfer is via all this prefabricated hydrogels, solid scaffolds, and injectable hydrogels. So there are totally 8 clinical trials registered all over the world. Out of 8, 4 trials were completed, and 1 trial is in the recruiting phase, and 3 trials are not entered the recruiting phase. So this is the first trial in 2012 in Cytotherapy Journal. It was published. It is a phase 1 study where human chondrocytes have been expressing increased expression of TGF-beta1 for osteoarthritis knee of 4th grade. So the cell line used here is human juvenile allogenic chondrocyte cell line, and here retroviral vectors have been coded along with cDNA, that is complementary DNA, to increase the expression of TGF-beta1. So chondrocytes have been isolated from the donor, and it has been modified with the gene of interest, that is TGF-beta1. Then it was amplified and cryopreserved. Once needed, it is given to the clinician for the purpose. So here what they have done is cocktail of 1:3 ratio of irradiated TGF-beta1 transduced chondrocytes to untransduced chondrocytes from the same donor of 3.5 ml has been injected in the knee joint, and it was evaluated. So dose-dependent minor illness were noted in the study. And the second study was, this is phase 2 clinical trial with 27 patients of ONE of 4th grade. It's a multi-center single-blinded study. Here the patients were randomized to receive TGF-beta1 transfused cells with a dose escalation. 6 into 10 power 6 or 1.8 into 10 power 7 cells ratio has been given. And both groups were analyzed for VAS IKDC WOMAC scores, which showed improvement at the end of the study. The third study is a phase 2 study. It's a placebo-controlled randomized trials to express the effect of clinical parameters of TGF-beta1 transduced chondrocytes in 54 patients. Here they have taken grade 3 OAD patients. So single injection has been given with a blend of TGF-beta1 transfused cells or placebo. Placebo is for the second group. The treatment group, which received TGF-beta1 transfused cells, reported significant greater improvements in IKDC score VAS at the end of 1 year follow-up. So the complications here they have observed was TGF-beta has a great role in promoting recapitulation of the developmental program, and it helps in formation of osteophytes. Higher intra-articular levels and joint fusion osteophyte development in animal model. They observed joint swelling in 12 cases, arthralgia in 5 cases, which were resolved at the end of the study, and one patient has got anaphylactic shock, which also has been resolved. The minor effects observed were injection site edema, pain, and the swelling. This is a clinical trial number so-and-so. This is assessed for safety, tolerability, and efficacy of XT150 for the treatment of osteoarthritic pain in 32 patients of ONE 2 and 3 grade. So XT150 is the plasmid DNA with a variant of human interleukin 10 transgene. This gene was given, this genetic component was given as a single injection to ONE patients, and the functional score of VAS, WOMAC, and WHO score has to be observed at the end of 6 months. This is an ongoing trial. So conclusion, gene therapy for ONE is a promising strategy for addressing regeneration of osteoarthritic cartilage. So for gene-based treatments for ONE, a major step towards clinical entity on encouraging preliminary results. So further, phase 3 study has to be conducted and the results has to be appreciated. Thank you.
Dr. Madan, thank you. It's an interesting topic. But as we know, genetic gene therapy is well work in genetic disorder. You can repair the gene like DMD, hemophilia. Already hemophilia, DMD, we have the gene therapy. But it's a wonder if you work gene therapy in the new way. There's nothing like that. Thank you. Nice. Yeah.
Our next speaker is Dr. Neha Garg, and the topic is role of PRP in unexplained infertility. Dr. Neha Garg.
Yeah.
Good afternoon, everyone. I'm Dr. Neha Garg, Senior Resident in Department of Obstetrics and Gynecology. I'll be presenting on autologous platelet-rich plasma and unexplained infertility. Infertility, as we all know, is on the rise. Around 1 in every 6 couples
That is 15% of the people in reproductive age face this problem. Usually, when a couple comes to us with infertility, we try to find out what is the cause behind it. If female factors are found, it could be the female factors, male factors, or in up to 70 to 80% of the cases, the cause is known. In around 20 to 30%, the cause is not known, with all the defined investigative tools available to us. In such situations, it is known as an unexplained or an idiopathic infertility. In such a case, because of the uncertainty with the diagnosis, there is no uniform protocol which exists in clinical practice. Treatment by necessity and by default becomes empiric. There are a range of treatments, including expectant management, superovulation, intrauterine insemination, IVF, and IVF-ICSI. But there has been a limited data to support the efficacy of any of these treatments being used as the first line, or what protocol, what guidelines to be followed. Usually, in the initial stages, when the couple comes to us, it is the expectant management that is advised to them, because in the previous studies, it has been shown that couples who have unexplained infertility, they respond better to expectant management. It has been shown from studies ranging from 2007 to 2015 that 13 to 15% of them conceive in the first year of attempt. It increases to 35% in the next 2 years. It is more beneficial to younger couples. A study done by Strisby et al. Showed a blooming 27% ongoing pregnancy rate with expectant management, as compared to 23% in IUI with controlled ovarian hyperstimulation. Expectant management for 2 years, therefore, is the best choice for good prognosis when woman's age is less than 30. This requires knowledge in terms, the female should have good grasp about her menstrual cycles, ovulation time, and the best time for having a timed intercourse. The advantages, the drawbacks related to the ovulation stimulation and the investigative procedures, those are disadvantages like multiple gestation and ovulation hyperstimulation syndrome is avoided. Now, because of the ambiguity as to which treatment modality to be used, there has been a lot of studies which have been started in this last decade, stating that autologous PRP can be beneficial in these patients. This autologous PRP is referred to as the regenerative concentrate of active plasma. The volume of plasma, it is the volume of plasma with exponentially increased platelet concentration of 5 to 6 times above the baseline. These platelets contain alpha granules and dense granules, which provide various growth factors which stimulate the biological healing, homeostasis, and tissue rejuvenation by supraphysiological release of biological macromolecules at the site of the injection. There are no side effects which are reported because it just accelerates and simulates the natural repair mechanisms of the human body. In 2015, a study by Chang et al. Evaluated the role of PRP in thin endometrium in 5 patients undergoing frozen embryo transfer cycles. The endometrial thickness increased after PRP infusion in all the patients and reached above 7 millimeters on the day of progesterone administration. All patients became pregnant, so a positive response. One of them had missed abortion, whereas the other 4 had viable pregnancy. In 2016, a review article by Gracia Velcho et al. Showed that autologous PRP was a potential method of improving 18 women with refractory endometrium. In 2017, a similar study was done with a larger subset of population, which showed both endometrial thickness and vascularity to improve with intrauterine instillation of PRP. Positive beta HCG values were observed in 60.93% and frozen embryo transfer, and the clinical pregnancy rate was 45.31%. Similarly, other 2 studies also showed, done by Zademodaris et al. And Colombo et al., showed that PRP had good beneficial effects. So therefore, this PRP has been an upcoming topic of research, dealt very little in the field of reproductive medicine. Therefore, the need for this study. So our study was done in the institute to compare the autologous PRP with the expectant management in cases of unexplained infertility, which are attending our OP. The healthcare setup was a tertiary care setup. The duration of study was 2 years. A total of 50 patients were recruited for the study. The inclusion criteria was all cases of primary unexplained infertility, women in the reproductive age 18 to 40 years, normal ovulatory function and regular menstrual cycles, patients who had no other factors contributing to their infertility, with bilateral fallopian tubes being patent, observed at laparoscopic chromoperturbation or hysteroscopic salpingography or sonosalpingography. Their spouse had male factor fertility confirmed by adequate WHO parameters. Now, out of the total 50 group, 25 people were allotted in the PRP group and 25 were in the expectant management. Now, in the PRP group, which was labeled as group A, now PRP was prepared by taking of 10 ml of patient's own blood, which was drawn in a syringe containing sodium citrate anticoagulant. Differential centrifugation was done. A total volume of 1 to 1.5 ml of PRP was thus obtained. This was infused intrauterine from 3rd to 7th day of the menstrual cycle using an IUI cannula under ultrasound guidance, using all aseptic precautions. This was followed by advice on timed intercourse. Now, the second group, 25 patients, were advised for expectant management. That is, the females were explained about their menstrual cycle and the tentative dates for their ovulation, and timed intercourse was advised for them. The results were the age, the number of years of infertility, and the BMI in both A and B group were matched. Now, in the second table, as we can see, that the number of follicles and the endometrial thickness before and after the PRP treatment. So after the PRP treatment, there is a beneficial effect on the number of follicles. That is, it has increased from 3 to 11, and it is statistically significant. Even the thickness of endometrium has increased. So therefore, this PRP had a rejuvenated effect on both the endometrium and the ovarian reserve. This was supposedly because of the release of the cytokines and the growth factors, including vascular endothelial growth factor, transforming growth factor, platelet-derived growth factor, and epidermal growth factor, which can regulate cell migration, attachment, proliferation, differentiation, and promote the extracellular matrix accumulation, which might help in fetal implantation and the clinical pregnancy. The endometrial, as you can see in the images, the endometrial thickness has increased. Now, the total results were that out of the group A, in which we had used PRP, out of the 25 patients, 13 patients conceived, which is a whopping 52%. In the group B, which were advised for expectant management, out of 25 people, 4 people conceived after 3 cycles of expectant. The rest, the failed management people were again allotted to PRP group, and with 21 people being allotted, 42% of them, that is 9 patients, 9 patients conceived. So in our study, excluding those 4 patients who got conceived with 3 cycles, remaining 46 patients had received a single dose of PRP, which says that 22 patients conceived, that is 47.82%. There were no side effects in either of the groups. This graph, the first graph, shows a highly positive correlation between intrauterine autologous PRP injection and pregnancy rate. And the second graph shows a weakly positive correlation between expectant management and pregnancy rate. So therefore, to conclude, autologous PRP is a novel technique that can treat unexplained infertility with favorable outcomes. It was found to be safe, easily available, inexpensive treatment modality. However, further research in the form of large-scale randomized controlled trials is needed, which would help to strengthen our observations and enable practitioners to use this modality clinically to optimize their success rates. Thank you.
Thank you, Dr. Neha. That's a very interesting topic you've spoken upon. You mentioned so many studies. Are there any other Indian studies?
Mike, please.
Ma'am, Indian studies were not there, ma'am, actually, and most of them are in relation to IVF conceived, ma'am. Like they are either they are failed frozen embryo transfer patients, failed IVF. There is no particular study which starts with PRP being the first line of management, ma'am, which was my idea of this presentation, ma'am, that this can be used in accordance with expectant management to give better results for the patients.
Maybe the other group could have, I mean, you could have taken the second group as the other modalities of treatment of the primary infertility.
Ma'am, actually, in all the previous studies, ma'am, which has compared even IUI or IVF, all of them have been compared with the expectant management, ma'am, to have a common baseline. That's
So
why
that
in
is
our
what I
study
said.
also-
If you can compare that group with the PRP, that would be a very good study. Thank you so much.
Thank you.
Please come for the discussion.
Yes, yes.
Dr. Dia.
Hello. Yeah, I think Dr. Narmada is not reachable. So no. Next speaker is Dr. Sakshi Gupta. Actually, she's going to speak something very interesting topic and something different what we are listening since yesterday. As a clinician, as a scientist, we doing every day something new thing, a new way the treatment, some modified treatment, but we are not aware whether we can do our technique the patent or not. I bet every day you people doing a lot of the new thing, but you are not aware of where we go for the patent. So now Dr. Sakshi Gupta going to tell about this how this new thing we can do patent, we cannot patent. So that is very interesting. So I invite Dr. Sakshi Gupta. Please go ahead.
Very good afternoon to all the dignitaries, and thank you, Dr. Kanchan, for this introduction. I would like to thank the organizers for giving me this opportunity to share my views. So, intellectual property strategy in regenerative medicine. You must be thinking why we are having this talk amidst all these sessions of regenerative medicine, right? So, regenerative medicine, as we all know, tissue engineering, controlled drug delivery, immunomodulation, genetic engineering, these are all branches of regenerative medicine. And as we are listening to the stalwarts in the field for the past 2 days, that regenerative medicine is going to the cellular therapy, molecular therapy, it is going to be a boom for the treatments in this field to the mankind, and it is actually the new line of therapy, we should say. So how we should go ahead, how we should safeguard the interest of the researchers who are working in the field. So how IP is related to it. Now let's discuss the intellectual property rights. What is intellectual property per se? Intellectual property is something which is produced using the human intellect, and it should have commercial value. We have a invention, we have an idea in the mind which is a novel invention, and we think that it is useful, but it should also has a commercial value along with it. Besides, it gives right to the persons over the creation of their mind. So what is the need of this IPR and regenerative medicine and stem cell research? How we can what is the need, how it is useful, or how it is a requirement of the current scenario? As we know that huge efforts are put into the research when we are doing into the lab on the patients. Doctors are thinking how to go ahead, how to heal the patient as soon as we can. So the amount of research, amount of efforts we put into the research. So the intellectual property rights, it essentially gives encouragement to the people who are involved and the pharma industry per se. Besides the funding, the money which is invested into this research. Since this IPR, intellectual property rights, are going to give us financial gains. We can sell these rights. We can, like property, we can sell this intellectual property. If you have a patent or a trademark or copyright, we can sell it. We can earn royalty out of it. So these are going to give us financial gains, and we expect returns per se. And most importantly, this regenerative medicine can positively transform the current medical situation, and since it can change the cumbersome treatment related to diseases like Parkinson's, neurological disorders, type 1 diabetes, coronary diseases, and in fact in cancer also, in the past few years we have seen that regenerative medicine has given hope to people. So these type of rights give us a monopoly to the innovations, and it prevents secret exploitation of the invention by the competitors. So if we can protect these innovations which we make, the formulations, the compositions, what we are making, So we are essentially protecting our rights. We are protecting competitors or the people exploiting all these things. So how we can go ahead? How we can protect the innovations in this field? So the intellectual property right related to regenerative medicine products, these are mainly protected by patents, though there are copyrights also, trademarks, GIs, designs, and all these are different types of intellectual property rights. But patent is the intellectual property right, which is essentially for the science and technology innovations. Okay, so whatsoever science and technology innovations we have, we apply for a patent for all those type of inventions. So what exactly is a patent and what can we patent? So a patent is an intellectual property right for science and technology innovations, which gives the inventor monopoly rights over their inventions. So if I have applied for a patent, I have made a composition, I have applied a patent for it, I have been granted a patent. So it is my property. Now I can sell it further. I can give it to the industry to commercialize it. I can prevent the competitors or the infringers to use it. But the rights for a patent is for 20 years total. I mean, these are not like for the age. It is not a lifetime. It is not there. Patent rights are only for a period of 20 years. After 20 years, it comes in the common domain, and then it is the public domain it comes. So then people can use it. And what exactly can be patent? Any machine, manufacture, process, method, or composition for that matter, or formulation. It can be patented, but it should follow the following three characteristics, the three criteria which are essential when checking for an invention, if it is patentable or not, is it should be novel, means it should be a new invention. Non-obvious means the people who are all skilled in that particular art, it should not be obvious to them. I mean, it should not be obvious to the people who are orthopedics that if we are putting this particular composition into the wound area, it will heal. So then that makes it an obvious thing. So it should not be obvious, and it should have industrial applicability. If these three criteria are passed, then that invention we can take it to the next stage. Then we check whether we can file a patent or not. So if the invention has passed all these three criteria, can we patent it? So there are two categories. I mean, for patent, it is not like that any invention can be patented. It falls in two categories. First, it can be a product patent. It means a physical thing like a device, a manufacture, a composition of matter, or formulation per se. So all these things come into the product patent. The second type is the process patent, which means a method of doing something new or a new way of doing something old. Means a composition is already there in the market, but if we are making it in a way that it is giving rise to a cost-efficient process, then yes, that can be. So can any regenerative medicine product can be patented? No, it is not like that, because all your stem cell related patents fall into the section 3B, which talks about the morality and public issues. Like anything which is prejudicial to the human, animal, or plant life, it is not patentable. So the embryonic stem cells, studies related to that is not patentable, but adult stem cells are. Besides, as per section 3C, it does not allow gene sequences to be patented, but genetically mutations, genetic engineered ones, we can. Pre-D says a new use of a known substance. No, if we are saying that it is applicable in knee, but now we are using it in orthodontics. So it is the new use of a known substance. That is not patentable. Obvious combinations, like we are just putting two things together and then saying a new usage, that is also not patentable. And very important is section 3I for the regenerative medicine inventions, that it prevents the method of treatment. So no surgical method can be patented, but devices can be patented. The diagnostic kits can be patented. And we can't patent the clones also. Human, plants, animal as a clone, we can't apply a patent for. Like these are a few case studies in this the applicant has applied for a patent on a process for isolation of mesenchymal stem cells, but it was rejected. So the claim which was granted was isolation of mesenchymal stem cells from a heterologous cell population, means no in vivo processing was there. Similarly, a method of treating a neurological disease. So method of treatment was rejected, but the composition they were using in it, that was granted. In this, a method of treatment or injecting was rejected, but a method of manufacturing a composition was allowed. So what we can patent is, if we are isolating a cell, then method of isolation and screening method can be patented. If we are purifying it, method of purification can be patented. If we are use drug production formulation, we are making that formulation can be patented. If we are transplanting it into a patient, then instead of that method of transplantation, the drug delivery system or the device can be patented. So we can patent it, but not the treatment method per se. Right. So to conclude it, I would say that though the regenerative medicine is a very promising field and it is going to be a boon for biotechnology sector of the country. And in the past few years, we have seen that 55% of the total patent publications in 3D organ domain are pending. But the growing number of applications shows that it is a growing market, thereby showing that the environment is now on the move and it is time to regenerate our intellectual property strategy, which can be redefining how we are drafting our applications, how we are drafting our innovations person. Thank you.
Dr. Sakshi, thank you. So nice of you. It's a really interesting topic, because I had idea, if I'm going something to do something exactly new thing, then go for the patent. It's not like that, right? If we modify the method, if something that be patentable, right?
Yes, sir.
Not you have to do everything new way.
No, everything new is not required, but the new method of doing the old thing, or we are getting into the old product only, but the method is new, which is cost efficient, which is energy efficient, or I would say the faster process. So the process is new person that can be patented.
Okay, thank you. We are behind the schedule, so we are not going to allow the other question. Thank you, Dr. Sakshi Gupta. Thank you.
Thank you, sir.
Our next speaker is Dr. A. Stem cells, Indian regulations about stem cells. Will be presenting online.
I think Dr. Bagul, in place of Dr. Bagul, Dr. Manoj going to present. Dr. Manoj Bhosle. Dr. Manoj Bhosle, please go ahead.
There. Yes.
Hello.
Yeah, Dr. We are hearing you. Go ahead, please.
Yes, sir. Just give me a few seconds. I am just launching this, sharing my screen. Basically, I would like to correct myself. Myself, Dr. Manoj Bansode. I am a Vice President for Regulatory Affairs and Biotherapeutics at Diponate Biointelligence Private Limited, Bangalore. And I am sharing right now. Yes, this coming.
Dr. Manoj, we are behind the schedule and you are very interesting.
Yes, sir. Yes.
Please go ahead and please summarize within time. Thank you.
Yes, sir.
Is there any technical problem?
Yeah. Can you see my screen?
Please go
Is
ahead.
it visible to you?
Yes, your screen is visible. The first slide.
Yes. I'm taking a very short and brief outline the legal provision of the stem cell and stem cell based drug in India, the MCI Code of Ethics Regulation in India for applications and clinical application of stem cell derived product, and the brief definition as per new drug law of 2019, clinical trial requirement, screening committees, licensing process, and application review system, and the industry for the guidance for the industry. See, Code of Ethics Regulation is, you might be all knowing that how the regulation of ethics is being done by, as per MCI guidelines, the prognosis regarding consultation to the patient about the stem cell therapy, and a physician should clearly know the what he is explaining to the patient with respect to the stem cell and stem cell therapy offerings in clinical practice. So I'm not much putting my time to explain this because all you might knowing. So I will directly go to the main part of this regulation, that is the new drug definition. As per new drug and clinical trial rule 2019, in India, stem cell is legal. Stem cell is coming under new drug definition, and they have given in a gazette notification of drug regulation that a stem cell is a drug including active pharmaceutical ingredient phytochemical drug which has not been used in a country to any significant extent except in accordance with the provision of the act and the rule made there under as per condition specified in the labeling thereof, and has not been approved as safe and efficacious by the central licensing authority. In that definition itself, in third point, they have included a stem cell derived product. Means from the 2019 in India, stem cell is regulated, stem cell is legal, but it falls under a new drug definition. Means it is a drug. When it is called as a drug, when there any stem cell, when it is being processed, isolated, cultured for more than 24 hours, then it is falling under drug definition. So you can see the gazette notification also, which was published in 2019. So what stem cell drug derived product means? Stem cell derived products are used to refer as a product which are used in the form of drug intended to be administered to the patient.
Your slide is not here, not moving. Your PPT is not moving.
Oh, is it?
Only first slide is going on.
The first slide.
Oh, wait a minute.
Hello, Dr. Manoj, can you hear me?
Yes, I am hearing, and I am trying to show you because I thought it is being shared.
If you do have any technical problem, we'll come you back again.
I don't know why it is not being able to see.
Okay, you take time. I'm going to call the next speaker.
Okay, fine, no problem.
So we'll move on to the next topic, that is by Dr. Karthik Raja. And the topic is low carbohydrate diet in anti-aging. Really a very interesting topic. This will be an online presentation.
Good evening, one and all. Thank you to the Indian Stem Cell Study Group for giving me this opportunity to talk about low carbohydrate diet in age reversal. I'm Dr. Karthik Raja, National Professor as a consultant dermatologist from Chennai. Let us initially talk about biology of age. What happens during aging? Aging is nothing but an impact of accumulation of molecular damage and cellular damage over time. It doesn't happen overnight. Okay, and it causes gradual decrease in physical capacity and mental capacity. What happens is the telomere length shortens, and that in turn causes repair in DNA function, and the cell division alters. Growing risk of disease and ultimately results in death. Okay, this process is not linear. It's not consistent with time. It is loosely associated with chronological age. That is why we see some 70 years old enjoy extremely good health, functioning, and they are moving around like when they were in 20s and 30s, and they look younger and they feel younger and they are living in life. And at times, some other 70 years old are very frail, they need support, somebody have to carry them, somebody have to support them, they cannot work on their own. All these things are happening because of there is disparity between chronological age and biological age. Why that happens is because of various reasons, the environmental diet as well, the lifestyle choices that they made during when they were young. Okay. What happens at the cellular level is, if we see, you can clearly notice that the protein inside the cells reduces drastically. The complete protein reduces drastically, and the damaged proteins increases rapidly. There are a lot of damaged proteins in the old cell as well. New cell, there are a lot of fresh proteins are available. And the other major component, what we notice is the ribosome. Ribosomes in the endoplasmic reticulum reduces in numbers. Okay, this is what happens during aging process in the cell level. The microfilaments, cytoskeleton, and everything is damaged. Telomere length is shortened. All this is because of the stress response to the genes and the growth genes. It is because of the parity of it. You see this woman, the one in the left is 84 years and one on the right is also 84 years. The right has been having a good active lifestyle and the left is have been having a very easygoing lifestyle, and that is the result what we are seeing in the aging person, 84 years. Can we really reverse aging? What is anti-aging? The opposite of aging process or preventing the aging process or delaying the aging process is anti-aging. Okay? To reduce the accumulation of multiple damage and cellular damage, increase the physical capacity, mental capacity, and ultimately reduce the risk of disease and delaying the death. How can we achieve that? Cell therapy and stem cells are one way to achieve that. We have been past 2 days, we have been seeing lots and lots of lectures about that. We're very clear that we can repair many of the damages, many of the reversible damages that can be repaired with the cells. But is that the only way, or is that the only solution what we have, or everybody can they afford this? Let us think about the most common component that causes this aging, the diet and lifestyle modification, which is sustainable and which should be sustainable. And there have been many people who have been doing this for ages and different people at different. This is one study done in a mouse that calorie restriction causes telomerase reverse transcriptase-like activity. That means the shortening of telomere doesn't happen if there is calorie restriction. That's what they have found. The calorie restriction is reduction in food intake while avoiding malnutrition. That is a key component. We should avoid malnutrition, but we should reduce calories. How to do that? I'll just give you some 3 or 4 points that before that. This is one important point. We should avoid malnutrition, but we should restrict calories. How are we going to do that? I will tell you. Can delay the onset of cancer and age-related diseases. Reduce activities of telomerase and enzyme. That is the study's finding. Okay, now the other component. What are the essential nutrients? Minerals are essentials. They cannot get it on your own. Our body doesn't produce any minerals. So we need to intake minerals. We need to intake vitamins. They are also, again, essential vitamins are there. We need to intake them. Those cannot be produced by our body. Vitamin D can be produced with vitamin sunlight and vitamin D precursors. Proteins, there are essential amino acids which have to be taken through diet. And fats, there are essential fatty acids that has to be taken through diet. Water can be produced by body itself. Maybe a shock to somebody, but body produces its own water with metabolism. Okay, carbohydrates, protein, and the fats, they during their metabolic process they release some amount of water because they are based upon carbon, hydrogen, and water. H2 is already there, but that is very minimal. We need to always ingest water also. But carbohydrates, is it really essential? No, it is not essential. We don't have to take carbohydrate through the diet. Glucose can be produced from pyruvate pathway with the fats and proteins in the diet. The other component, let me come to the other component of aging process. Age causes aging. What is age? Advanced glycation in products are formed. They are the components which causes aging. Okay, how it is formed? It is formed by irreversible non-enzymatic reactions between reducing sugars, glucose. With that, amino acids and proteins reducing nucleic acids. They react with glucose and cause AGEs, advanced glycation end products. They are thought to ultimately lead to oxidative stress. Hyperglycemia exacerbates age formations. The major cause of endogenous age is the result of auto-oxidation of circulating glucose. That is the reason for this production of AGE, the advanced glycation. Okay, the exogenous sources of tobacco and diet, endogenous sources, hyperglycemia, high oxidative stress. Eating too much of carbohydrates is the reason for serum AGE, and they are causing oxidative stress and inflammation, TNF-alpha enhancement, CRP spikes, and incidence. All these causes caused because of serum AGE. Another drug which have been implicated in anti-aging effect that many of the dermatologists are using it. Many of you also might be knowing about it is metformin. What metformin does is it reduces the glucose level from the blood by enhancing the insulin's activity or sensitivity, what we can say. Okay, our carbohydrates are non-essential. Carbohydrates hastens the aging process. Anything that destroys the carbohydrates from body, like diet, exercise, and fasting, enhances anti-aging effect. These 2 points we know. Why to consume carbs and then try to burn them? Very low carbohydrate diet or low carbohydrate diet that we call it as. And this diet recommendation is made by ADA and AHA in 2019 or 2008. Remember exactly, as a primary first-line treatment for type 2 diabetes, they have recommended this. What does this contain? The carbohydrates should be restricted to less than 40 grams per day, and the 40 grams also should come from vegetable sources, not from grains. Protein should be a goal. 0.8 grams per kilogram of body weight is required to maintain daily activity and repair cells. 2 grams is required to build your muscle mass. So you can take either way from 0.8 per kilogram to 2 grams per kilogram per day. Some quality sources like eggs, meats, and fat. Fat we have to leverage. If you want to have more calories, increase fat in the diet. If you want to take less calories, reduce fat in the diet. That is how we have to use the fat. It doesn't mean we have to take too much of it. Immediate effects of low carbohydrate, what we can notice is the blood glucose level goes down. Blood glucose level goes down, what happens is insulin requirement goes down. Insulin is produced less by the body, it reduces sodium retention. Insulin is required. Insulin is needed to reabsorb sodium from the renal tubules. The insulin is not there, sodium is not retained, so BP is reduced, reactive oxygen piece is reduced, stress in the entire system is reduced. Long-term effects in the low carb diet are essential nutrients are provided. We give all the essentials like fats, vitamins, minerals, and proteins. Non-essential nutrition like carbohydrates is avoided. It is the effective detox process. You avoid toxins, the body will detox itself. It enhances the repair by producing, by giving all the essential nutrients. Collagen synthesis increased because of vitamin C presence as well as the essential amino acids. This is a study, and in the study they have noticed the same age the monkey is age 27 years old. Well, this one is having adequate calorie food, and this is having calorie restricted food. You can see by the fur coat, the face, the wrinkles and stuff, the anti-aging effect of calorie restricted diet. Real life changes. Let us start talking about monkeys and studies in mice. Let us start talking about people who have been following this diet. In Tamil Nadu, around more than 5 lakh people are following a group, and that group who suggests this very low carbohydrate diet. A lot of people are following and getting wonderful results. This guy from 2015 and 2000 today, look at his face, look at his texture of the skin and everything. Clearly, he's reversed his age. This guy, apart from the hair dye, everything else is just because of the diet. Look at the posture change. Look at the shoulders, the physical activity, and everything is enhanced because of the low carbohydrate diet. Look at this fellow. The left and right, there is drastic difference. The skin doesn't sag because there is enhanced collagen production. We are taking adequate protein, we are taking adequate fat. Cell wall is made up of cholesterol. We should take cholesterol. Humans require cholesterol. That is how this kind of changes are possible. And look at this medico who has lost about 30-60 kgs of weight in a span of 3 years. Okay, points to ponder. Are carbohydrates really essential? No. Why to take a non-essential nutrient as a major component in our diet? Glucose metabolism produces advanced glycation end products. AGEs are implicated in most of the AGEs in the body. Why to take glucose? AGEs causes oxidative stress. Low carbohydrate diet reverses aging to a certain extent. It delays further damage at least. Thank you for the opportunity. I think the time is up. I think I have finished within the time. Thank you.
Thank you very much, Dr. Karthik.
Thank you, Dr. Raja. It's very nice, interesting topic. Really, we can check our age process. We can overcome all the problem. But I know already scientists discover it. With the play of the telomere, we can stop the aging.
Yes.
Thank you. Due to short of time, we are not allowed the question. Thank you, Dr. Raja. Thank you. Dr. Alok and Dr. Pradeep Mahajan, can you come on dash to facilitate our chair speaker? Dr. Pradeep Mahajan, please facilitate. Dr. Nita Mishra. Ajay, Dr. Jiten. Thank you, ma'am. Thank you, Dr. Jiten. Thank you, sir. For the next session, I'm going to invite the chairperson, Dr. Manish Khanna. I think Manish Khanna is not here. He left. But I'm here. Dr. Alok Agrawal and Dr. Satyen Punjani. Dr. Satyen, please come the dash.
So friends, as you all know, that this is a very prestigious session of Indian Stem Cell Study Group Gold Medal session. We have a group of chairpersons and we have a group of judges lying in the hall. And the papers are from Dr. Ranjit Chaudhary, Dr. Shilp Verma, Dr. Buddhadev Nayak, Dr. Ankit Sahai, Dr. Nagaraju, and then Dr. Samarjit Dey in the same sequence. The marking will be 7 marks for presentation, 3 marks for content, 3 marks for discussion and rebuttal, and 2 marks for the time. There are total 15 marks. So let us start on the session. The first speaker is Dr. Ranjit Chaudhary, who will be speaking on role of PRP in plantar fasciitis. Ranjit, there are 10 minutes. So basically it means it is 8 plus 2. 8 minutes for speaking, 2 minutes for discussion, but the work will be continuing.
Good afternoon. Today's my talk is role of autologous PRP in recalcitrant plantar fasciitis. What is plantar fasciitis? The plantar fascia provides the support to longitudinal arch of foot and act as a shock absorbent. Despite it contain itis in name like the plantar fasciitis, it is characterized by lack of inflammatory cells. Primarily, it is a degenerative process of plantar fascia at its origin on medial calcaneal tuberosity. The cause of plantar fasciitis is multifactorial, but most cases result from overuse stress, which cause the microtear of plantar fascia. There are various predisposing factors like space planus, space cavus, limited ankle dorsiflexion, excessive supination, pronation, obesity, heel pad atrophy, aging, and occupation require the prolonged standing. Approximately 50% patients have a heel spur, but spur itself does not cause it. The ultrasound evaluation often reveals the calcification, intersubstantial tear, thickening, and heterogeneity of the plantar fascia. Then what is the treatment? The NSAID, ice pack, shoe insert, plantar fascia stretching exercises, night sprint are first line treatment. In spite of this first line treatment, approx 10% of the patient symptom does not improve with conservative measure and develop chronic courses. The invasive injection techniques such as the autologous PRP and steroid are used in this kind of recalcitrant plantar fasciitis patient. Often, single steroid injection are not useful and may require multiple injection, which may be associated with potential complication like the plantar fascia rupture and fat pad atrophy. Local injection of PRP is emerging therapy for ligamental pathology. What is PRP? What is PRP? The PRP is harvested by centrifuging the large amount of the patient's own blood. The platelet contain alpha granules, which are rich in protein and various growth factors, like the platelet-derived growth factor, transforming growth factor beta, IGF, VEGF, and EGF. On activation of platelet, release these growth factors. The supraphysiological amount of these growth factor and cytokines at disease site augment the neovascularization and healing process. We have done a study with aim to evaluate the efficacy of PRP injection in case of plantar fasciitis, which have failed with conservative management for 3 months of duration. It is the single center prospective interventional study. Total 50 patients, 23 is male and 27 is female, 38 is unilateral and 12 is bilateral foot affection. The technique of PRP harvestation that we used is under sterile precaution. The 20 ml of blood are directly from vein into the trisodium vacutainer. The vial are left in standing position for 1 hour, then spin at a speed of the 3000 RPM for 10 minutes. The PRP quality was assessed. The platelet count more than 2.5 times of the patient baseline count was accepted for injection. The 2 ml of the PRP injected in maximum tender point of the heel via the peppering technique. The post-injection NSAID are usually avoided because these drug interference in the post-injection inflammatory healing process. The patient was assessed for the pain improvement with VAS and AOFAS at pre-injection 1 month, 3 month, and 6 month post-injection duration. The results, the VAS score. We can see in the table the pre-injection VAS score is 7.9, which decrease at 1 month, 3 month, and 6 month follow-up continuously. And in the statistical analysis, we found there significant difference between the each interval. If we and on AOFAS score, the pre-injection score was 66, and it was continuously increased in 1 month, 3 month, and 6 month follow-up. And in this AOFAS score, the statistically significant difference found between the each group. Now, what is else study that we have? Else study that are available in literature. The Monto et al. Done a study to compare the effect of the PRP and steroid in chronic severe plantar fasciitis. He have included the 40 patients who did not respond with conservative management for 4 months, and he randomized in 2 groups, one for the PRP and another for the steroid. And he injected the 3 ml of PRP or 40 ml of depometron under ultrasound guidance and follow up the patient with AOFAS score at 3 months, 6 months, and 12 months, and 24 months. The corticosteroid group have a pre-treatment average AOFAS score is 52, which was initially improved at 81 3-month post-treatment, but decreased 74 at 6 months and dropped to near baseline at 58 at 12 months and continued decline. Final score is 56 at 24 months. In contrast, PRP group started with average score of pre-treatment AOFAS is 37, with increase to 95 at 3 months and remain elevated to 94 at 6 months, 12 months, and final score is 92 at 24 months. This is the graph. This shows the previous mentioned score. The blue color for the steroid. If we can visually assess, this is at the 3-month follow-up, the EOPAS score are maximum. Then the EOPAS score are decreasing at 6 months, 12 months, and 24 months duration follow-up. Where in PRP group, the improvement in EOPAS score are maintained throughout the 24 month of follow-up. There is another systemic review and meta-analysis by Young et al. Who evaluate the effect of PRP in plantar fasciitis. The 9 RCT, total 430 patients was included in meta-analysis. The significant difference in VAS was not observed between two groups at 4 weeks and 12 weeks between the treatment. However, PRP exhibit the better efficacy than the steroid treatment after 24 weeks. This is the forest plot of the VAS when comparing the PRP and steroid. Look, first at the 4 week of follow-up, the mean difference are in favor of the steroid group. But when we see at a p value is 0.5, so this is not a statistically significant. At 12 week, again the mean are in favor of the PRP, but this time the p value is 0.3, so it is not a statistically significant difference. But at 24 week of the follow-up, when we see there is the mean in favor of the PRP group and the p value is 0.03, so there is statistically significant difference between the PRP and the steroid group at 24 week of follow-up. So they concluded the PRP is superior to steroid treatment in long-term pain relief. However, the significant difference was not observed between short and intermediate effect. Conclusion: the use of PRP in recalcitrant plantar fasciitis are seen to be more safer, efficacious, and curative in long-term follow-up, where the traditional corticosteroid provide only short-term relief only. Thanks.
Thank you, Dr. Ranjit. Yes. The paper is open for question and answers.
What are the statistical tools you use to analyze this?
Sir, I use a student t-test to compare pre-operative with pre-injection with post-injection. I compare with pre-injection with 1 month, pre-injection with 3 months, pre-injection with 6 months. And I also compare with 1 month with 3 months and 3 months with 6 months. All interval I compare and all interval found to be significant.
Did you compare with the steroid along with?
No, sir, I didn't include the steroid in my study because I didn't get the ethical clearance for the randomized trial. It was the study that I have shown is published in literature from other authors. Sir. One is the meta-analysis that I have shown.
So you
just shown the result and compare and review the
graph coming to be.
Sir, forest graph is already Ian et al. Have published it that I have shown.
That's not yours. Yeah. That was in the meta-analysis.
Yes,
I mean, that was in the literature which you posted.
That is the review of literature.
Dr. Ranjit, what has been your shortest and longest follow-up?
Sir, actually in thesis, I usually only can do up to the 6 months of the follow-up. But after completion of my thesis, I follow up the patient that the result are not included in this study, but I found the result, the improvement in pain score are sustained and patient does not relapse.
Good. So the maximum follow-up that you did on your own was around 2 years.
Yes.
Thank you. Thanks a lot.
The second speaker is Dr. Shilp Verma. Our topic is a comparative study between LS, that is a steroid, local steroid versus PRP in tennis elbow.
Good afternoon, everyone. Respected Chairperson and Organizing Secretary Dr. Alok, thank you for presenting a paper in international podium in this stage. Myself, Dr. Shilp Verma, Senior Resident in AIIMS Jaipur, presenting a paper on the comparative prospective study of platelet-rich plasma versus corticosteroid injection in the case of lateral epicondylitis. Lateral epicondylitis or tennis elbow is seems to affect 1 to 3% of general population in 3rd to 4th decade of life. It is due to the combination of mechanical overload and abnormal microvascular response in the case of lateral epicondylitis of elbow at common extensor tendon origin. Most famous personalities, a sports person, also suffered from the lateral epicondyle injury like Sachin, Clark, and Jim Wake. Now, let us come to the pathology. It's actually an overuse syndrome. The pathogenesis of overuse injury is thought to be the result of cumulative microtrauma that weakens the structure and vascular element of extension tendon. Diagnosis can be made by Cousin test, Mills test, chairlift test, and Modley's test. Helps in the diagnosis of the patient. The treatment modalities, most commonly we are using analgesic with immobilization, that is a standard modality. Other modalities, what we can do is a wrist bracing or elbow bracing, local corticosteroid injection, shockwave therapy, modifying poor technique in sports of work, or in the case of persistence or recurrence cases, we can go for the surgical intervention. Recent study have been explored the use of the platelet-rich plasma in the treatment of lateral epicondylitis. Platelet-rich plasma, or PRP, is derived from an autologous sample of the blood and centrifuge concentrate the various growth factors. PRP is rich in the growth factor, protease, adhesive proteins, and cytokinins. We had done a study to assess the functional outcome in the patient with lateral epicondylitis treated with corticosteroid injection. Second, to assess the functional outcome in the patient with lateral epicondylitis treated with the platelet-rich plasma injection, and to compare the functional outcome between the platelet-rich plasma and corticosteroid injection in the case of lateral epicondylitis using visual analog score and Liverpool elbow scoring system. Let's review the literature, what has been already proposed in the past. In 2010, Booms et al. Had done a level 1 study in 100 patients that includes 51 of the PRP cases and 49% of corticosteroid cases. They had followed their cases for 1 year and used DASH score and visual analog score, disability shoulder, arm, and hand score system, and visual analog system to evaluate their pain management. They concluded that PRP reduces the pain and increases the functional compared to the corticosteroid injection. Another study has been done by Jose et al. In 80 patients in 2013. They had given PRP injection under USG guided injection and followed them for the 6 weeks, 3 months, 6 months, and 12 months. They had evaluated the patient using visual analog score and DASH disability arm, shoulder, and hand score. They found a significant improvement in the case of DASH score and DASH score. Our study is a prospective comparative study. Source all of the patients with lateral epicondylitis who were not better with 6 weeks of conservative treatment. Method is a block randomization. We had taken a 40 patient, included 20 patient in each group. That's 20 patient in the PRP group and 20 patient in corticosteroid group. We had taken the patient from age of 20 to 70 years and the patient with persistent symptoms of lateral epicondylitis for more than 3 months, not responding to 6 weeks of conservative management. We had not taken the diabetic patient or rheumatoid arthritic patient. Patient with the history of trauma received the injection at the lateral epicondyle in the last 3 months, and the patient with suspected nerve injuries. Technique for the corticosteroid injection, we had taken a 10 ml syringe, took the 2 ml of methylprednisolone acetate, that is Depomed, and dilute it with the 5 ml of 2% plain lignocaine. Under aseptic precautions, lateral epicondyle is palpated and injected. For the PRP, we had taken a 15 ml of venous blood, mixed with 5 ml of anticoagulant, that we took a CPDA. We had taken the 4 vials, 5 ml each, and centrifuge. We had done the centrifugation in 2 stages. First for segregation, second for concentration. For segregation, we had done a 3,500 rotation per minute for 7 minutes. And for separation, we had done 3,000 rotation per minute for 5 minutes. In the end of the after the segregation, we took the Buffy coat. Again, we had done the concentration. At the end of the concentration process, we took a 5 ml of PRP. Post procedure, we are advised the patient not to do a heavy activity for at least 7 days and discharge the patient with oral tramadol injection with paracetamol BD doses for 2 days. Now we will assess the outcome. We had used the visual analog score and Liverpool elbow score. We had evaluated the patient pre-procedure, after 6 weeks, 3 months, and 6 months. Visual analog score, Liverpool elbow score. It's a clinical as well as a functional score, which consists of total 15 questions, 4 points each. The maximum score is 53. Results. What we got from our result, in the corticosteroid group, a statistically significant improvement in functional outcome in visual analog score and Liverpool elbow score in corticosteroid group of patient where p-value is less than 0.01%. Comes with the PRP group. Statistically significant improvement in the functional outcome is visual analog score and Liverpool elbow score in the patient in platelet-rich plasma group of the patient where p-value is less than 0.01%. Now we'll compare both the groups. Intergroup comparison using independent student t-test shows a significant improvement in visual analog score in PRP group of the patient compared to corticosteroid group of the patient with p-value less than 0.01 in 6 months follow-up. Similarly, we got a result in the intergroup comparison using the independent student t-test. Significant improvement is seen in the Liverpool elbow score of PRP group of the patient compared to the corticosteroid group of the patient with p-value less than 0.01. Conclusion: in the end of our study, from our study, it is evident that PRP as well as corticosteroid provides a symptomatic relief in the treatment of tennis elbow with significant decrease in the VAS score and increase in the Liverpool elbow score. When we compare PRP and corticosteroid injection, PRP proved to be more effective modality in the treatment of lateral epicondylitis with statistically significant better functional outcome and better pain relief. Limitation of a study, or we can say scope for the further work. We had just taken a 40 samples, 20 patients in each group. The sample size we could take a better, means last sample size would have been better. We had followed the patient for 6 months. A long follow-up for minimum of 2 years would be better to predict any difference in the outcome in other group. There would be a possibility more pain because of large amount of PRP injection to the patient on day of injection. However, in our methodology did not consider this, and we had not recorded the VAS score on the day of injection to know whether there was an increased amount of pain in the patient treated with 5 ml of PRP injections. Thank you, everyone. And today is a Valentine's Day. Wish you happy Valentine's all.
A very nice presentation, timely presentation. 2 questions are permitted. Please let the watch running because that shows how much questions are to be permitted. Dr. Shilp.
Yes, sir.
What has been the interval in your cases in preparation of PRP and doing the actual injection process?
So we were taking the patient directly to OT, taking the blood and centrifuge it. First cycle we did it for 7 minutes. Then second cycle we'll do it at 5 minutes. As soon as we'll get a 5 ml of PRP, prepared PRP, we'll inject in the patient. Sir.
You prepared it and immediately put it?
Yeah, immediately we are giving.
So this alleviated any problem of activation of PRP? Required?
No, sir. We had not. Actually, for activation is mostly we have done for fibrin like things, sir. But in the case of PRP, sir, directly we are doing it, sir. Means our procedure itself is taking more than 12 to 13 minutes. So we'll proceed continuously, sir.
Did you also have a long time follow-up?
Yes, sir. We were following. It was a thesis study, so 6 months was for ethical clearance. But still, we are following the patient, and most of the patients are symptomatically better.
Yes, please ask.
Hello, Dr. Shilp. I'm assistant professor in the Department of Physical Medicine and Rehabilitation, Dr. Ronak.
Thank you, sir.
It was a great presentation. I want to ask something. Why you have taken 3 months in the exclusion criteria of any injection procedure? Why only 3 months?
So, like tennis elbow, it might be due to acute tear or there is a strain in the muscle, which can easily resolve muscle healing process. Generally, muscles resolve or tendons resolve by 3 months. It takes 6 months to complete resolve, but symptoms should resolve in the case of 3 months. Sir.
Okay, you are talking about only healing.
We tried to rule it out the normal cases, and we are particularly focusing for the tennis elbow. So
you are talking about healing process, not about any medication and half-life, no? Only about healing process.
No, sir. Initially, we gave conservative treatment for all of the patients, sir.
Okay.
Yes, sir. We tried all the patients. We gave a conservative treatment for the modality. Then we took it the patients.
And how was the compliance of the patient in the next round when you are giving PRP in the second visit?
Pardon, sir, I didn't get you.
PRP का जो second visit में और उसका follow-up कैसा था patient का compliance?
So patient was initially corticosteroid injection was much better, means they were giving a good result. But in long term, after 6 months, we were getting a PRP is much better than corticosteroid. Same, sir, our slide is also showing intergroup comparison. That is a blue color line with a PRP, and corticosteroid is a red bar. This is a VAS score. The less the score, better the patient. So corticosteroid initially, first and second term, corticosteroid was better, but in long term, PRP will be effective.
Okay, thank you.
Thank you, sir.
Very nice.
Thanks.
Thank you, Dr. Shil. The next speaker is Dr. Buddhadev Nayak. He'll be speaking on comparison of platelet-rich plasma versus suprascapular nerve block in periarthritis shoulder.